Yeah, on. So, good morning, everyone. Good morning, sir. Good morning. Good morning, Paramita. Good to see you.
No, no, I have some work, some commitments today. That is why I have some puja at my place. So I'll not be able to be there the whole time. So
We'll do the darshan with you. Please take your computer there.
surely.
Okay. So we are on.
Yeah,
Satish,
can we start?
Yes,
Yeah.
yes,
what is the flow?
yes.
Ah,
Yes, sir. Yes, yes. Dinesh, ready? Dinesh?
Yes, sir, we are ready to go. Now you can start, sir.
Yeah. Very good morning to all of you. Dear friends, welcome you all again to an interesting webinar focused on a very basic to advanced ENT surgeries. Shall be demonstrated with the practical discussion with none other than the legend, Dr. Satish Jain. And this is our 10th webinar with Dr. Satish Jain. And each and every webinar, it lasted from average of 4 hours to even 9 hours and 10 hours on an average of around 7 hours to 8 hours. So almost 80 hours of webinar Dr. Satish Jain has given to all of us and learning. And today we have with us Dr. Kirtane, which is our privilege. And our speakers today are Dr. Rajeev Pachauri, Dr. Ashish Bumkar, Dr. Ashim Desai, Dr. Sanjay Khanna, with the moderator, Dr. Paramita Saha. Once again, my heartiest welcome to all of you from Sun Pharma. This is Mahindra Varman from Pharma Care Division, the division which is dealing with Cipodem, Recipar, and Montacapex. Once again, my heartiest welcome and have a good webinar. And over to Dr. Rajeev Pachauri. Thank you.
Indraji, you missed the Guru Purnima day. On a very auspicious day you chosen, yeah.
Yes, yes. I mean, my salute to all the gurus of this webinar and also my gurus in my profession.
Yes,
Thank
and to
you.
the gurus of the farmers.
Yeah, thank you. Thank you.
So good morning, all my friends from this country abroad. And today is the 10th, you can say, version of our this episode. And that's like episode of this series.
The serial killer.
Yes, yes, you missed version of. So the series going on to just to uplift the ENT amongst all of us. And today we have very auspicious day like this is Guru Purnima. And those who are from out of India for it, Guru Purnima, just like we you can say we pray, we just remember our teachers who taught us in our all the fields. And for ENT, we have our Guru today with us, Dr. Kirtane sir. And today's day is devoted to Dr. Eve Desai, who taught us the ENT in the very advanced form that time. And you have to go see our one more guru like Dr. Satish Jain, and he is guru of all means he is teaching us so many things since last 1 month, and today is the 10th series of this event. So I think we will go for the Stapes surgery, which is I think a dream of every PG who want to learn the surgery. And when they come out from the PG type postgraduate, they come to practice, they want to do this surgery as a, but there's a fear is there, and fear is obvious because so many complications being taught in the theory and during books, and so many complications being seen by those people. So I think that today we have kept 6, 7, 8 hours with our all the legends, Dr. Asim Desai, Dr. Ashish Bumkar, sir is there, Satish of course, and from a panel from all around the world, and they will just join us and lots of discussion we'll have. And we just main purpose just to take out the fear about the surgery from yourself, your mind, which is there, and you should try and all the pathophysiology, whatever is regarding autosclerosis, medical management, surgical management, complications, all the different varieties will be shown today. So I think all the best to all of you and enjoy this ride. And after next from tomorrow, try to do this surgery with full confidence and go in this world. So again, thank you very much, sir, all my teachers, my guru, and Satish, Ashish, and Paramita is there. Dr. Sanjay Khanna. Sanjay Khanna is my very good friend. He will moderate it today. He is a dynamic surgeon. He is doing all the surgery. And best over to Dr. Paramita. You want to say something?
No, I think I will let Dr. Kirtane sir say
Yes,
first.
sir.
So
Yes.
happy Guru Purnima to sir, who's been my guru always. Sir, you
Guru
please,
of Gurus.
sir. Yes.
Yeah.
Sir, any comment?
No, nothing. It's an auspicious day, and there, right on the screen in front of you, Satish Jain, the Guru of Gurus.
Yeah.
There. I
Guru
mean, I've
of
rarely heard of people
many like
addressing
me.
6,000 to 7,000 people and operating before them. So, I think I would just like to quote what I have read, and that is about knowledge.
Yes, sir.
Knowledge is not knowledge unless it is shared, and that is what Satish has demonstrated so ably. So congratulations to him, and I think we can proceed with the day's program.
Yes, yes, yes.
Yes,
Thank
sir.
you, sir.
Rajeev, if I may make a mention about the fear factor you said,
Yes,
if somebody has seen this great master Satish Jain, decidedly remove the carotid tumor, make
Yes.
the carotid, and suture it meticulously in 23 seconds flat.
Yes,
I
sir.
don't think there is anything more fearful in any ENT surgeon on the planet's mind. Foot
Come
plate
on,
is
Ashish,
nothing.
leave it.
You are
leave
never
it.
going to die if you mishandle a foot plate. But the way what he did in 23 seconds, I have timed him, also speaks about the team. They were anticipating, everything was ready. The right suture, everything just fell in his hand. It's incredible. I mean, that was a moment. So fear has no place now in the ENT world.
Yes,
And,
sir. That's
Thanks to Dr. Satish Jain for that.
Thank you. Thank you, and good morning, everyone. As we all
Yeah, good
know,
morning.
we are here today for a special purpose to discuss on some special thing, which is a special sense of our body, hearing. And that
Satish, your
too,
voice is too low.
we are here to discuss. Can you hear me?
Yeah, better.
A unique spatial sense of the body, hearing, and for that, the unique structure which transmit the hearing. A 2.8 milligram weighted structure having a dimension of 3.2 millimeter in the oval window. The structure which moves a few nanometers by sound, transmitting the hearing. What a unique sense. And that too on this pious day of Guru Purnima, which is marked as a day to respect your gurus. And today we are here to respect someone whom we have dedicated this event. And we all know he is none other than amazing, incredible, and phenomenal Dr. ABR Desai. We all know what kind of dedication he has been shown to ENT, and for everyone, I am so fortunate to have been associated with him, and he has treated me like his son. He always told, I have two sons, Ashim and Satish. I am so, three sons, Ashim, Satish, and
I
Ashish.
thought that dialogue was also for me.
It is.
Always like this. He's treated like this. And for everyone, this master who started his career as a general surgeon long back, he did his, after master in surgery, he did FRCS in general surgery from London, and then he did FRCS from Edinburgh in otolaryngology. He started his career from Tata Memorial Hospital as a cancer surgeon. He used to do a lot of abdominoperitoneal resections, head and neck cancer surgery, and so many things. And finally, he found himself devoted to something, reconstruction of the hearing mechanism. That time that was in infancy. You can imagine when stapedectomy was introduced in 1956 by John Shea. He was the one who did the first one in 1961 in India. And that is how, it's almost 60 years back, he introduced those concepts. And after that, he revolutionized the modern otology. He worked with Hugo Fish as well, and he handled the Indian version of the Hugo Fish Micro Foundation. And since then, you can imagine in 60s, he revolutionized by his phenomenal philanthropic work by organizing so many free camps in the rural area of many parts of the India and treated thousands of patients free of cost that times. And that's how he created awareness amongst the people about the otologic surgery. You can't imagine how much he was dedicated to, how much he was dedicated to teaching. And in his career, he performed the topic we are going to hear discuss today, the Stapes surgery. He performed more than 13,000 Stapes surgeries. He performed more than 30,000 middle ear reconstruction surgeries. Imagine the kind of work he innovated. So many procedures like interlake tympanoplasty, two cartilage osteoplasty, so many reconstruction in otology, middle ear and stapes surgeries, which has we are going to discuss day long and in the coming webinars. So, this man who has revolutionized the science of modern otology in our country, we are here to pay some respect to him. This workshop, this webinar which we have planned today, was earlier scheduled to be in month of April, 5th of April in Mumbai, with Sir's physical presence, but because of this COVID situation, we couldn't make it. And I was supposed to see Sir, but couldn't travel to Mumbai in last 3 months, and hope to have him next time in our session together. To for everyone's information, he had his ENT career of more than 50 years. He is now 88. His, yes, of course, for last few years, couple of years, he has not been very active, and now his most of the work is being carried forward by Ashim Desai. So, sir, can I? We have Kirtne sir here, who has an association with ABR Desai sir, probably for more than 30, 40 years. And I hope sir wants to say something about this legendary.
Yeah, thank you, Satish. Shall I speak?
Yes, please.
Yes.
Yeah.
Who can stop you? Sorry. Sorry.
You know, when I was a resident, I'm talking about 1969, 70, 71. We used to know the ENT people in the field because they were all professors or honoraries at the various medical colleges, and those were the people whom we knew. Here was one man who was not attached to any medical college, and yet he was one of the best known ENT surgeons in the city. So we had heard his name even in our residency days, but we never had really a chance to meet him because, to be honest, he was not attending one of the monthly meetings which were held at the medical colleges. So we had only heard about him and heard that he's very good, he does a lot of good work, etc. And then I happened to meet him once at a meeting, and when I talked to him, I was so impressed by him. First of all, as a person, he was very proper, very gentle, extremely polite, and most important, with whatever little work we presented at that time, he was very, very encouraging. I mean, he was the perfect gentleman. Then I had the occasion, because when I started seeing patients in my clinic, etc., some patients which he had operated would land up with me for something else. And the moment I saw that little endoral incision and the fantastically well-healed cavity or tympanic membrane, I mean, I didn't even have to ask the patient who operated on you. I knew it was Dr. ABR Desai. I can truly state here, Satish, today that I have never seen ear surgery outcomes as lovely as what I saw from this man. From nobody else have I seen these kind of outcomes. Every
For
case
last
that I saw
60 years,
was
consistently
fantastic.
for
And
last
that is
60
why
years.
I wanted to go and watch him. So he says, most welcome. I went. He didn't have a camera on the microscope. He had a side tube. And I was watching him. And that is the time I realized what microsurgery really meant. I mean, I realized that what we were doing was something else. This man was so meticulous and he explained everything. There was a scientific reason for every step that he took. Yes, he took a lot of time because he went at the pathology really well. And I remember then I was so impressed with him that a very dear friend who was an airline pilot and who developed infection. I treated him, wouldn't heal. So I took him to Dr. ABR Desai. And he said, we'll have to operate on him. And I said, look, he's an airline pilot. If something happens, and that is the reason why I brought him to you. And he operated 3 hours under local. He cleared all the granulation tissue and kept an intact canal wall. It turned out to be tuberculosis, and we had to give him antitubercular treatment. But the point I'm trying to make here today, 35 years later, this pilot is still maintaining his profession and flying in spite of the fact that he had such a gross disease in the ear, and which would have in any other person's hand led to deafness and I don't know what. This is the reason why all my favorite patients. Hello, can you hear me?
Yes, sir.
Yes.
Okay, all my patients went to him for surgery. My own sister-in-law, when she required autosclerosis, I said, we'll go there. And she said, why not you? Why are you not operating? I said, no, you're just too precious for me and would want to go to him. Now, when I got to know him, I went and watched him operate many times. And this is one thing I want to tell you, that you don't do research just in medical colleges or big institutions. I know this man was doing a stapedectomy. He would make a 0.4 millimeter fenestra with a perforator, put in the piston, then take a headphone of an audiometer covered with a cloth, sterile cloth, and do an audiometry on the table. Then he would take out the piston, increase the fenestra size to 0.6, put a larger piston, again do an audiometry, take it out, do a 0.8 fenestra just to find out what size fenestra and what size piston would give him the best result. And you can't compare the result in two different patients. The conditions are different. So he did it in the same patient. Now, can you imagine the working of that mind where he had the confidence that on the table, you know, talked about fear of the footplate. There was no fear here. Everything went like clockwork. And this is how this man's mind worked. When Ashim was a resident with me, I remember Dr. ABR Desai would invite me. We would go to Willingdon, sit down, and over lunch. And the only thing we discussed was not politics or not cricket or not Bollywood. Only thing we discussed was Stapes surgery, tympanoplasty. He had a single track mind in that respect. And of course, his wife, Veena Ben, I mean, I have never seen a more gracious hostess. She was always there with us. She would sit quietly while we discussed, but an amazing, amazing person. So I'm not surprised with parents like this. Ashim has turned out to be what he is, and he's carrying on the work that his dad is doing.
Thank you.
So I think, Ashim, you have got very, very large shoes to fill.
Yeah.
And I'm sure you'll achieve that. I'm sure he'll be proud of you. But you have a tough job ahead of you, because that man is leaving behind a legacy which I don't think anybody I can foresee can really equal. A fantastic man, a perfect meticulous surgeon, and a gentleman to the core.
Thank you, sir.
Really
Thank you,
my
sir.
privilege to have known him and been associated with him. Thank you.
Thank you, thank you. And
Beautiful,
like sir
beautiful
rightly
speakers.
said,
Well,
I have
well
witnessed
presented.
this fact. Whenever Dr. ABR Desai was operating, every time he would do himself intra-op audiometry. He would always say, doctor, if you really are rushing for something, if you have to catch flight, don't operate that day. And he would never make an issue. Time is never a factor. And for every small thing, he may take even 1 hour longer. He will make sure that it goes perfect, and then only he will finish to it. That is the kind of perfection he was having.
Satish, if you allow me 2 or 3 minutes, I'm sorry, I'm this thing.
Stick to
I will
time.
make 2 or 3 minutes about, I will pick up on what Kirtane sir has said. Just a little bit of clarification. At one point, ABR Desai had a surgical waiting list of 14 months. I think that sort of a waiting list, I don't think anybody can see anymore. The other important thing, like sir said, he would not go to conferences, not that much, at least initially. And one day when me and Ashimi were going all over the country, and he called us actually in his room and says, why are you all doing this? I said, sir, we think we have something to teach. I said, if you have something to teach, if the world is putting a premium on it, they should be coming to you. Why do you want to impose your teaching on others? That was his sentiment. He says, if somebody finds you worthy enough, they will find you and come to learn. This was an important insight. He says, why are you imposing yourself on others? And the second thing was about the side tube. Long ago, now 30 years back, when I went to him, the cameras were not there. I had told him I will come the next day. The earlier night, his assistant called me and said, I'm just confirming whether you're going to attend sir's surgery or not. I said, yes, I'm coming. It's important because if he fits the side tube, his light gets cut. In those days, the beam splitters were not so good. That was his level of dedication to a student. if you are coming, he will fit it in, but not at the cost of the light that is. So this was something, and he would take color pencils and describe. He was a brilliant teacher. And one thing, once he asked me, Ashim tells me you are a good Stapes surgeon. And I was modestly, whatever, no sir. So how do you deal with the difficult anterior crus? This is 30 years back, and I did not even know that there is something called as a difficult anterior crus. And my journey in Stapes surgery began there. The difficult anterior crus, and today we will talk about it. Sorry,
Thank you,
sorry
Ashish.
Satish.
Thank
I had to
you.
bring this.
And before we start our program,
You are
I
not
will like
audible.
to have a few words from Morwani sir, who has been like his family friend, who has been associated with Dr. A.B.R. Desai for last 40 years or more. So, sir, can we have something from you before we start our program?
Satish, your audio is very low.
Just put the
यार,
microphone
क्यों
towards
सुबह
you.
सुबह परेशान करते हो यार?
हाँ रात को करो परेशान.
Morwani sir, can you hear me?
Yeah, better now.
Morwani sir, we can see you on the screen. Nice.
It's okay,
Anyway,
don't get upset.
so for our today's program, friends, we have, as you know, we have our luminaries, our guests, my dear friends, Ashim and Ashish, and we have done couple of such events earlier as well. Our Stapes Carnival we did in 2013 in Jaipur, which was Ashish's unique idea, wherein we did 50 Stapes surgery in 2 days with different techniques. With different techniques there, and this was the version, minor version or smaller version of the Stapes Carnival, which was scheduled in April in Mumbai. So today we have Ashim and Ashish with us, who are going to enlighten us, and you will be amazed with their knowledge, their experience. Ashish, you all know, he is a different soul. He is ये लाइट गई क्या? जब से बैठे ना, कभी ऑडियो नहीं आता, कभी नेट नहीं आता. क्या कर रहे हो तुम सुबह पहले यार? रात भर से तैयारी कर रहे हो. अब यार फालतू बात मत करो यार. अरे लाइट गई. क्या करते हो यार? मजाक बनवाते हो यार. चालू हो गया तो इसलिए मैं कहता हूँ दिनेश को खुद को होना चाहिए. कहाँ प्रॉब्लम कहाँ है? लाइट गई ना, वाईफाई बंद हो गया. कौन सी लाइट गई? थोड़ी देर इंटरव्यू उस पर कर दे. कर दिया क्या? मैं क्या बंद रखूँ? ये सब मेरे को क्यों कह रहा है? पहले करना चाहिए ना. सफाई में मांग रहा हूँ मैं. क्या यार, इतनी देर इतना हजारों लोग जुड़े हुए हैं, ये बंद हो गया यार. क्या यार, डूब मरोगे कोई बात.
And it is amazing how, I'm sure, Sir Kirtani sir, you also done
No,
stapedectomy?
I think when I was doing my residency, it was not a complete laterectomy, but
Posterior
removing the
third.
posterior half. That means the technique was you first fractured the superstructure, where sometimes the whole foot plate came out. But if that happened, we put a vein graft. We didn't sweat. But
My brother, it's a pleasure, honor, and privilege to be with my two brothers, Ashish and Satish. And we've together done a lot of good work. And I'm really fortunate to have these two by my side. And take this opportunity to do my hardik pranam to Kirtane sir and Morwani sir, who've been our teachers. Thank you very much for gracing this occasion. And we're truly honored to have the two of you here.
Is just a few nanometer, and that is Stapes bone. And we have a couple of live surgeries here today. We'll have intense discussions with these masters on various aspects of the Stapes surgery, right from the diagnostic workup till complications and how to handle them. We have already, a lot of people had logged in earlier, and we have already more than 400 people, 400 questions came to us regarding this Stapes surgery. And today we have in our moderators, along with Dr. Rajeev Pachauri, who is the mastermind behind this course, Dr. Rajeev Khanna, Dr. Sanjay Khanna from Karnal, who is a senior ENT specialist, and his academic orientation with so many accolades, awards, and so many publications. He is attached to most of the premier corporate hospitals in Delhi and Haryana. Thank you, sir, for being with us and making this event better and better. So, today we'll be starting with a live surgical demonstration of a case having conductive hearing loss. This diagnosis of otosclerosis is not always established before the surgery, unless you have operated upon the other ear. So diagnosis is mostly clinical, and we need to take help of certain investigations. We today will discuss in detail the role of radiology separately. And before we talk about the first case, who is a lady, 40-year-old lady, with a moderately severe conductive hearing loss bilaterally, I'll show the audiogram and tympanogram finding which we get done. This, are you getting some slide on the screen?
Yes, yes.
Ashim, boss, Ashish.
Yeah.
These are the listed investigations which are mentioned in the literature to help reaching the diagnosis of otosclerosis.
Yes.
Practically, we don't get all these investigations done. In our hearts and hearts, we all know.
Yes.
For the audience, I believe today, nothing to mention, these two guys are going to speak out of their heart. What they have seen in their life, what they have experienced, nothing something fabricated, nothing something, they are not going to speak anything which they don't know. So Ashish, honestly, when any case coming to you with an intact tympanic membrane and a conductive hearing loss, do you get all this list of investigation, or any investigation, or what investigation, to be very specific and precise?
The tuning fork is missing from this list. And honestly now, by 30 years now, we can actually smell an otosclerosis when they walk in. There is a certain way in which the patient speaks. There's a lot of clinical input that you get. The way when it's bilateral, of course, that the way their voice is very soft. One of the more important questions I ask them is, when they are eating their food, is there increased difficulty in hearing? And if that is so, it sort of tells me towards a conductive loss. Sorry, I'm saying this.
Yes, yes.
And there's another thing that I've observed but not published because I'm not into publishing. A skin which looks like mine, a darkish Indian skin with light eyes. this is my observation, more often than not, these will turn out to be otosclerosis. Satish, sorry,
Yes,
this
yeah,
is all.
that is very important aspect, that you can have in your mind a sense of diagnosis as the patient comes to you that could be having atosclerosis. The way the patient speaks, the moment you have a look at the tympanic membrane with a hearing loss, and of course, like you mentioned, the tuning fork, and you
Yeah.
put a Weber's and get a lateralized Weber's to the same side, it gives you a diagnosis. I have not
The Sindhi
mentioned tuning
Papad test
fork.
we call. When they are crunching on the papad, it's the most
Yes.
difficult for them to hear the
Yeah,
outside.
yeah, and but I'm sure you are not getting all these investigation done. Are you?
No, 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 no.
Audiogram?
Yes, of course.
Any respect to the carrots
No,
nodes or any tympanogram or
in my
anything?
early practice, I've had a problem with my audiologist giving a unilateral SN loss as a conductive loss. I explored the child, and of course, the chain was mobile. I put the thing, the eardrum back, and a repeat audiogram was done, and it showed sensorineural hearing loss. Now, theoretically, I could have been in trouble because somebody would have said preoperatively there's a conductive loss, and now it's an SN loss, so created by you. So, very, very important unilateral conductive losses. Be very, very careful, especially in children.
Yes. And the second thing you mentioned about the tuning
Ashim,
fork.
Ashim,
I
Ashim can take
know
over.
Ashim uses tuning fork like anything.
Yes.
Ashim.
Yeah. So I would say that tuning fork is a preliminary and most important part of our surgical decision, because although your audiogram can tell you anything, if the tuning fork is not negative and the Weber is not moving towards the side that you choose to operate, one would choose not to regard the audiogram. Now, in my practice, I've been very fortunate to have two outstanding audiologists working with me. So I'm very, very confident with their audiogram. But having said that, each and every patient, I will subject him or her to a tuning fork test by myself and be sure that it is absolutely coordinating with the audiological findings. Along with this, to take the matter that Ashish spoke a little bit further, that when you have a large discrepancy between the test year and the non-test year, such as a large conductive or a large mixed loss, and the other side showing mild SN loss or no loss, in those cases, narrow frequency insert masking, not just headphone masking, is the most important part. Because
You need to explain that, Ashim.
yes, when you do a headphone masking, that's all right when you have a normal hearing ear on the other side. But if you have a moderate loss on the other side, the headphone will give you only 60 decibels of effective masking. Now, crossover occurs over 45 decibels. So, effective masking will not occur merely with a headphone. So, for that, you need to use an insert masker. And insert
So the masking is important. That point is very well taken. The masking is important.
Yes, absolutely. Masking is, without a masked audiogram, you should not be operating. I will stick my neck out and say that. And you need 90 decibels of effective masking if your hearing loss has a sensory neural component of more than 40 dB or even a large conductive component. So insert masking is essential in the non-test.
Thank you.
Yeah,
Wonderful.
that is important. So guys,
Now
before we start, yes.
Sorry. Yeah, sorry, please.
Yeah, please. Go on,
Now
go on.
coming to VEM, vestibular evoked myogenic potentials, this is a very important test when you are considering otosclerosis with ongoing Meniere's disease also. Sometimes bilateral mixed loss with vertigo.
No, the point is, this is in your routine test battery or not?
Is
No,
it
not
a
routine. Sorry,
standard
not
form?
routine.
Okay.
Not
Not routine.
So, before we go into the live surgery, this purposely we are discussing this diagnostic part, which is very, very important for half an hour
Epidemic reflex,
with the
Satish, you
CT
should
scan as
speak.
well. Yes, Ashish?
You speak a little bit on the impedance and the stapedial reflex,
Okay,
please.
that's what I was coming to. So, first on the audiogram, like both of these guys said, the audiogram we always get done. And a very specific thing we always discuss in the audiogram is about the Carrett's notch. Carrett's notch is what? A depression in the bone conduction at certain frequencies, speech frequencies, sometime maybe 1K, mostly at 2K, sometime even at a 500. So what is that for the junior colleagues? This is not bone conduction loss, this is not inner ear loss, that is a loss in the bone conduction because of the fixation of the stapes, because of the conductive hearing loss. And that is not specific to the otosclerosis, it can happen to occur in other conductive hearing losses as well. So what happens? to be very, very clear, our bone conduction mechanism has three aspects. One is, as the sound strikes the skull goes in vibration, and those are the inner ear fluids as well. And that vibration in the inner ear fluids stimulates the cochlea. That is the main part of the inertial component. The second and third component of the bone conduction passes to the middle ear mechanism. What is that? What is these ossicles? These are bones suspended in the bone again. That is the skull. So their relative vibration to the skull, that relative inertia of the vibration of the stapes to the skull leads to movement of the perilymph, and that is conducted to the inner ear, and that component of inertial is a significant one which is lost in otosclerosis because the stapes is fixed. And second is, some of the sound passes through the extra auditory canal vibrating the tympanic membrane and goes to the middle ear system. That again is lost. So that middle ear component which is lost is reflected as a carrot's notch, that is loss in bone conduction in speech frequencies. So this is important to understand. Why I am mentioning, in spite of having bone conduction loss on the audiogram, as the stapes fixation is taken care of with the piston, this improves. So in spite of having done the surgery for the conductive hearing loss, air bone gap, still the bone conduction improves, and that is what the gain in bone conduction. So some of the patients having some loss in the bone conduction as well are still the very good candidates for the stapes surgery. It's not that those are having SNHL are not are good candidates for stapes surgery. So this leads to a phenomenon of overclosure. Overclosure means your bone conduction is improving, your air conduction is improving, and it looks like your air conduction, final air conduction is better than the previous bone conduction. So that is overclosure. The second, like Ashish asked, I will emphasize a little bit on the tympanogram and the stapedial reflex, that is known as, this test battery is known as impedance. I mentioned a little bit during the internal tympanoplasty case as well. Impedance is a very important investigation. So first of all, I'll take 5 to 10 minutes to tell you what is impedance. Why God has given us a middle ear. The middle ear has been interposed for the amplification of sound, the environmental sounds coming from the environment to the inner ear, going to the inner ear. The reason is, when sound travels in the environment, it has no resistance as it passes through the air. But as this sound passes to the cochlear fluid, which gives amazing resistance, the sound, most of the sound can get reflected back. And because of this middle ear transducer mechanism, as the sound is preferentially conducted to the ossicles and amplified to the level that majority of the sound passes to the inner ear fluids, and that's why we are able to hear. So that impedance matching mechanism, the middle ear is matching that impedance which is otherwise provided by the cochlear fluid to the other environment. From the air to the cochlear fluid, the sound which gets resistance, which gets impedance, is matched by the middle ear, and that is the function of impedance matching. So any middle ear pathology, suppose maybe to the ossicle, tympanic membrane, perforation, discontinuity, whatever, or otosclerosis, whatever happens to occur, leads to mismatch in the impedance and leads to conductive hearing loss. So this, to record this phenomena of impedance matching, is this test, impedance audiometry, and how you can do it simply by an instrument known as electroacoustic bridge. So this instrument has three components. What you need to do is, you have to put a probe in the ear which completely seals the extra-auditory canal, and this probe has three components. One component gives a constant sound at a low frequency, 226 Hertz. The second component detects the sound. Whatever sound you give, it is reflected to the tympanic membrane because of the impedance of the system. And whatever reflected sound is calibrated by the other tool. That is electroacoustic bridge. That is taken by the second probe. And the third thing is connected to a manometer. So what do we record out of this? What do we want to record? Our middle ear, from the tympanic membrane to the stapedial foot plate, this impedance it is matching. If this impedance has increased or decreased, it is recorded by this electroacoustic bridge. So whatever sound which is given by the sound probe, how much of it is being reflected is recorded, and that will give us a information of the impedance of the entire system. Now, to record this impedance, the criteria are very difficult. So, the opposite of the impedance is admittance. Compliance, you can say. So, if the compliance of the system is good, we will record it as a high amplitude. If the compliance of the system is low because of the impedance, maybe because of fixation of the stapes, fixation of ossicles, maybe because of tympanosclerosis, whatever, we will record as a low compliance, and this is the basis of impedance. Here in the stapes, because of the fixation of the otosclerosis, the impedance is increased, the resistance is increased to the sound transmission, and will find on audiometry or the tympanometry as a low impedance curve type. There are variety of curves defined because according to the compliance. The high one when there is ossicular discontinuity, and the low one when there is fixation. Could be because of any reason, and since this is otosclerosis fixing the final transmission of sound to the inner ear, that will reflect as a low impedance. The another aspect of this impedance test battery is the stapedial reflex. This is same. Again, we all know when the sound is transferred, it goes to the cochlear nuclei, from there to the superior olivary complex, and from there the efferent to the seventh nerve, the stapedius muscle is stimulated. And when the stapedius is stimulated, it increases the impedance to prevent the further sound transmission. That is a protective mechanism. So, in order to test that, this impedance is again an important test by means of which we record the impedance exerted by the stapedius. So, these are two tests which can give us a great idea about this diagnosis of otosclerosis. These are all adjuvant tests. There is no confirmatory test to diagnose otosclerosis so far before intraoperative exploration. But yes, if you have an audiogram saying a conductive hearing loss where your tuning fork is directed to the same side, as we always take up a case which has a worse hearing, so obviously the Webers will reflect to the worse ear. Then the tympanogram with a typical type AS curve, which you may not get always. If the patient has a fixation of the stapes with a thin drum, you may not get the type AS curve. But yes, in a normal drum, you will get a classical type AS curve. This situation. This is important because in otosclerosis now the stapes is fixed. Even if the stapedius contracts, it will not be able to elicit the reflex, and that is classical of this. This is important because in any case, with even a conductive hearing loss, maybe low frequency loss or minimal loss or small loss, if the stapedial reflex is present, it 100% rules out otosclerosis. This is very, very clear. So, certain tests are important to substantiate your diagnosis or to rule out your diagnosis. Yes.
Do you mind making a comment on the role of impedance in the post-operative period? When
not really.
Says,
not really.
Can you simulate by increasing the pressure?
Yes, lot of people have tried by preserving the stapedius tendon.
No, not about the stapedius tendon. I am asking post 2 months, 3 months when the patient says, "Is it safe for me to fly?"
Yes.
Can you do a simulated middle ear?
Okay, that's an amazing point by Ashish, which I will emphasize here, and that is important for everyone. That is always a question that can I fly? You know, a lot of patients ask when you do stapes surgery that, doctor, can I fly? Or when can I fly? Or it is important for the professional, flyers and divers and so many things which are exposed to the pressure changes. So, like Ashish mentioned, the test we take in our practice into consideration, which I believe is the best test to give them a clearance whether they can fly or not, is the tympanogram. The reason is, as I mentioned, in tympanometry we put a probe in the ear and hermetically seal it, and with a manometer we can increase or decrease the pressure. On those patients post stapes surgery, if you really want to check whether they can fly or give them certificate in writing, you do a tympanometry test. What will it do? You raise the pressure by 400 millimeter or so. I will tell you why 400. Because at this pressure, the tympanic membrane becomes like a solid wall to prevent further pressure transmitting to the inner ear as a protective mechanism. So, all the radial fibers of the tympanic membrane come into action, contract and make the tympanic membrane like a wall. So, it does not mobilize anything further inside. And after that 400 pressure, if you still keep on reaching pressure, there will be no inward movement of any ossicle, anything. Otherwise, you know, if you exert 100 millimeter pressure, the tympanic membrane will go inside, the malleus will go inside, there will be gliding movement at the IS joint, and then the incudostapedial joint, and then the foot plate will go in. This is the normal mechanism. At 400, the tympanic membrane becomes a wall. It doesn't lead to any further movement of anything inside. And when you raise the pressure further above 400, there is no movement inside. So anybody
400, the patient has no weakness, the patient
so
can fly.
if the patient passes this tympanometry test at 400 pressure without any vertigo, he is fit to fly. As simple as that.
Perfect.
There is one more point here, that at 400 millimeters of water, you have a static inward displacement of the prosthesis by 0.5 millimeters.
Maximum.
So that is a maximum inward displacement.
Yes.
And therefore, if that elicits some form of vertigo, then you are sure that there is some problem.
Yes.
So that is one more point that you should know, that the static displacement also is very important.
Yeah. So see, this is the point from a master, that if this pressure, when the 400 millimeter of pressure is exerted, and as the stapes goes inside normally, now there is no stapes and there is piston, and piston has nothing to impede below. In a normal stapes situation, there is annular ligament to impede the further movement, you know. In the highest pressure situation, you know, I tell you the figures. Normally the stapes goes inward and out few nanometers, maximum 30 nanometer for the maximum sound hearing. With 400 pressure, it can go up to 230 nanometer inside. Nanometer means 230 nanometer means 0.2 millimeter. With this piston now placed in place of the stapes, where there is no annular ligament, it can exert more inward and outward movement, and like Dr. Ashim said, the piston can go in the extreme pressure situation up to 0.5 millimeter. So if the patient passes the tympanometry test where the piston is going even up to 0.5 millimeter and it is not pressing on vestibular end organs, not giving any vertigo, that means he is fit to fly.
Yeah.
Perfect.
Yeah.
That should be very clear. Then the other test, before we move on to the CT scan, the VAMP, like Dr. Ashim said, VAMP is generally not required. This is required, I will tell you, to differentiate from one condition, that is superior canal dehiscence. We'll see in radiology, I will show you what it is. So VAMP is what for everyone? Vestibular evoke myogenic potential. So when the sound is transferred to the ear, as the footplate goes in, when the saccule is stimulated, the vestibulo-colic reflexes elicit the movement in the muscles in the neck, potentials in the neck, and that you can record through an electrode inserted in the sternomastoid muscle. And if you get those myogenic potentials in the stapes, they are classically absent because of the conductive hearing loss. If you find a VAMP, that too on a very low threshold, that rules out otosclerosis 100%.
Yes.
Got my point again? Like stapedial reflex, if you elicit, there cannot be otosclerosis. Similarly, if the VAMP is coming at a normal threshold, it cannot be otosclerosis. And if VAMP is coming at a low threshold, higher stimulation, that looks like something is like a third window lesion in the inner ear, like superior canal dehiscence. So these tests are important to rule out, to differentiate, or to do a differential diagnosis with other lesions. OAE, otoacoustic emissions, reflect the function of the outer hair cells. Again, in the conductive hearing loss, the OAE is absent. So if you still find OAE, it rules out otosclerosis. And again, if the patient has a OAE present, if the patient has a VAMP at a low threshold, all these are a stapedial reflex present, you have to do radiology and rule out other inner ear lesion like superior canal dehiscence. So the whole idea behind this test battery is to reach to correct diagnosis. They all help you reaching correct diagnosis to avoid a misdiagnosis. Still the final diagnosis will be on the table. And more than that, if you see the histopathological studies on the temporal bone, on those patients who are operated for otosclerosis, who had a fixed foot plate, wherein the surgeon placed the piston, good hearing, everything went off well. And a post-mortem temporal bone study, histopathological study is done, and you will be amazed to know not more than 40% of those patients are having true autosclerosis. There are so many other systemic diseases which result in Stapes fixation, giving the same clinical condition like autosclerosis. So it is not always the Stapes fixation is autosclerosis, but yes, most commonly it is autosclerosis. It can be fixed because of other systemic diseases as well. Lot many other connective tissue diseases and all that lead to Stapes fixation.
Satish,
Yes,
can you hear me?
Yes.
This is Sanjay Khanna.
Yes, boss. Please.
Yeah.
Boss, feel free
There
to
are few
interrupt me
questions, if
anytime.
you can take few questions.
Yes, please.
Suppose there is a conductive hearing loss at low frequencies and normal in higher frequency. So what is your suggestion in that?
Conductive hearing loss in the low frequencies
And normal hearing at higher frequencies.
yes, so that is something we were discussing. A conductive hearing loss, particularly in the low frequencies, you have to be suspicious about certain other lesions and you need to rule out. You need more test battery. That's how I listed this test battery to rule out those conditions. Like for example, many of the patients of autosclerosis have a subclinical endolymphatic hydrops, which is not clinically manifesting by means of vertigo or any other symptoms. And they have subclinical hydrops and they present with a low frequency conductive hearing loss. They are not truly autosclerosis, maybe having autosclerosis associated with hydrops as well. And if you don't rule out this before surgery, you may have a disaster later on. Like for example, many a times we have seen no surgeon on this planet has seen untoward complication in Stapes surgery. Everything went off well, you inserted a piston well, everything you come out well, and you finally, the patient develops a sensory neural hearing loss. Because there are certain uncontrollable regions, uncontrollable factors beyond your visibility, beyond your control. And I will mention in my radiology talk after this that how you can even pick up such subclinical lesions by means of radiology. So those dubious lesions with conductive hearing loss in the lower frequencies, you have to rule out a subclinical hydrops where by means of radiology I will tell you, and some other tests as well like electrocochleography, and you have to rule out the test things like superior canal dehiscence or any other third window lesion. So
also, I think the condition of the tympanic membrane, I doubt whether, that would probably, it's a old something that has gone wrong. And
we are assuming as a normal intact tympanic membrane, Ashish, in that situation. So Ashim, would you give any special attention to those patients like Dr. Sanjay Khanna has asked, having low frequency conductive hearing loss, selective low frequency up to 2000 say?
In these cases, I would re-look at the masking of the audiometry.
Yes.
Look at my Rene and Weber's right up to 1024. And the third one is that for 150% such cases, I would consider imaging with the very close windows to make sure that there's no superior semicircular canal dehiscence in such cases.
Okay.
And
so
finally,
like, yeah.
I'm sorry?
Yeah. Come, carry on.
And finally, if there is even a slight mixed component, I will also do a speech discrimination score on that time. That also a mass speech discrimination score.
Great. So that is important. You need to do a proper masking for those patients. And more than that, I have certain reasons to warrant a radiology in those situations. So Ashim, I am a strong proponent of advocating radiology for every patient. For that reason, I will tell you, there are many reasons to it. In your practice, I know you are not getting CT scan done, honestly, in every patient.
Not in every patient.
Ashish, you as well.
Yes.
For which patient you are advocating CT scan, for that matter, for the audience?
All of the above. The special situations of children, mixed hearing loss, vertigo, tinnitus, doubt on diagnosis, all of the above require CT scanning, as well as unilateral severe conductive losses. Those also will be subject to CT scanning irrespective of their age.
Revisions?
And always revisions, without exception.
You know why I'm asking? We had this, we learned this lesson from our event Stapes Carnival. Ashish, you remember?
Yeah.
That time we didn't get all patients CT scan done. And 3 patients we had gushers. And all those three patients were below 20 years.
Yes.
They had conductive hearing loss. They had, like Dr. Sanjay Khanna asked, a predominant conductive hearing loss in the lower frequencies.
Right.
We missed the diagnosis as we didn't have CT scan for those patients, and they finally we got the post-op CT scan done, and then we had to cut a sorry figure. We got the gushers in those patients which could have been avoided by means of having a CT scan. That's the value. So we learned that lesson, like Ashim said, in children. All patients below 20, CT gives useful information in terms of not only ruling out all these. The juvenile autosclerosis is very common, and you know, in juvenile autosclerosis, it is mostly associated with a very commonly associated with the obliterative kind of lesion. And a good CT scan can give you pre-op information that this particular patient has obliterative autosclerosis, and you have to be accordingly prepared with that. You have to be accordingly taking consent from the patient for that, as those patients are not having that good result as other patients. So imaging is one aspect we always emphasize, and here I will take you.
Sir wants to say something.
Yes.
Satish, two things.
Yes, sir. Can you bring your mic closer, sir?
Yeah, can you hear me now?
Yes, better.
One is when you're suspecting a superior semicircular canal dehiscence, look at the audiogram. The bone conduction is abnormally good in these patients. You'll get bone conductions coming
absolutely,
close.
Absolutely.
That
Absolutely.
Something that puts you on guard that a very good bone conduction.
Yeah.
And secondly, in a very young child, if you see mixed loss, where autosclerotic is not really to be expected, we've had patients with incomplete partition 3, where the inner ear is exposed to
communication with the CSF space.
That's right, and that is where they have a big gap. So if you have a 3-year or a 4-year-old coming with a big mixed loss and it's showing a type A tympanogram, that
the same thing happened in Stapes Carnival when Ashim was operating that case, and he came across a sudden gush of perilymph. You remember, boss?
Yeah, boss.
And that patient, we got the scan done later on, and it was a X-link.
Yeah, so it's not really a perilymph gush. It's
CSF. So you know what happens in those situations, like sir said, communication with the CSF space. There is a situation like a sort of inner ear hypertension. There is more pressure of fluid behind the foot plate because of communication, abnormal communication with the CSF space. And that extra pressure in the vestibule keeps the foot plate movement restricted. And when you get your audiogram done, it will give you a false impression of a conductive hearing loss. Got my point?
Yes.
That kind of a false impression of a conductive hearing loss in a situation of inner ear hypertension because of inner ear abnormal communication with the CSF space, if you don't have a radiology, can take you to the same situation like we had faced. And that was, had we been having a CT scan before, we would certainly avoid surgery in that patient. That was a lesson to us. So here,
one more question, Satish.
Yes, please, sir.
Just
sir, you feel free to interrupt me anytime, as you are getting a lot of questions from the audience. Please.
Yeah. So there is a question related to the investigation audiogram.
Yeah.
A female patient with age 40 years.
Yeah.
Having a bilateral moderate mixed hearing loss with the airborne gap of 15 to 20 dB. What is your take? And reflexes are absent. What is the take on this?
Can you repeat, boss? Sorry, I couldn't listen to it completely.
Okay. There's a patient, 40 years female.
Yeah.
With bilateral moderate mixed hearing loss.
Okay.
With airborne gap of 15 to 20 dB.
Yeah.
And reflexes are absent. And how to proceed for this? What do you suspect in this?
See, bilateral mixed loss in a 40-year female, obviously the tympanic membrane must have been normal.
Yeah, obviously it is normal.
Yeah. I would advocate a CT scan. That's what I am coming to. The reason for getting a CT scan, for what? I need a CT scan. These patients with a, secondly,
advanced autosclerosis.
Secondly, I would definitely confirm with my tuning fork. See, in spite of whatever audiogram I am getting, I would always do a tuning fork before establishing a diagnosis of autosclerosis. So, in spite of having a mixed loss, I will get a good Rini negative. In spite of having almost equal loss, even a 5 dB difference, I will get a Weber lateralize, and that will substantiate my diagnosis as well. And in all these mixed losses, like I mentioned in the previous slide, like Dr. Ashim mentioned, his particular indications, I am irrespective of anything getting CT scan done, but his indication is very specific in a mixed hearing loss. That will give us a lot of information about the etiology of the mixed loss as well, if some part of the inner ear is involved. Ashim, you do anything differently?
No, absolutely not. I completely agree with you that when you say 15 and 20 dB of airborne gap, as Dr. Khanna said, then Rene and Weber become even more important than ever before. And
yes.
And to suppose, assuming that it still appears to be otosclerosis, your CT scan is all right with that, and assuming that your Weber is not very specific, then you would do a speech discrimination and operate on the better side.
See, that is important. Before proceeding for the surgery, this master's word as a speech discrimination is, to me, is essential. This is something will really give you a true idea of the overall quality of hearing the patient is going to gain. Whatever audiometry say, max hearing loss, mixed hearing loss, if the patient speech discrimination is poor, if it is below 50, you have to think twice before doing a Stapes surgery, because you have to tell your patient the prognosis. In spite of doing a mobilizing by means of putting a piston, you may not get a good hearing result in terms of hearing for practical purpose. Boss, anything you want to add on?
No, please go ahead now. We are already at 11 o'clock here.
Yes, yes. So Ashish, we are not in hurry. Our aim is to discuss all these things, huh?
But 4 surgeries, no? Okay.
Yes. So what I was trying to say, the imaging, the role of imaging. The reason is, imaging not only take you to the right diagnosis, that reaching to the diagnosis, the role of imaging is minimal. Imaging is not directed to diagnose otosclerosis, what I mean to say. Sometimes you may not get any otosclerotic foci. You may find absolutely normal high resolution CT scan of the temporal bone, yet patient may be having otosclerosis. So role of imaging, obviously sometimes you may get a diagnosis, but role of imaging is different. The role of imaging is to get anatomical details, is to give us anatomical information which may make our surgery otherwise difficult. It gives us information in sort of giving contraindications to surgery, so many information, and overall it prevents you from cutting a sorry figure many a times. So the imaging, first of all, what kind of imaging we should order in those situations. So imaging what we order in this situation is a high resolution CT scan of the temporal bone. Fine slice. Nowadays we are getting more and more cone beam CT scan where we can get a thin slice up to 0.05 mm of the structures. This particular yes, 0.05 mm with a cone beam. Cone beam is an amazing technology wherein the CT scan can be done even in the sitting position with hardly any radiation exposure. According to the literature, the overall radiation exposure is 16 times less than a regular CT scan. And many of the countries it has been advocated to be, done even in the pregnant ladies because there is hardly any radiation exposure. And more than that, there is no artifact. That's why it was introduced in the dental, field to prevent the artifacts coming into picture. So cone beam in that respect is much better, but though you can't do contrast studies and other things with a cone beam, but for a regular high resolution CT scan, the cone beam is best. So a good, high resolution CT scan is required so that you can see each and every point. Now the question is, you remember Ashish, when Kirti sir conducted a panel of the LChem,
yes,
I sent afterwards a protocol of imaging, our protocol, to see the things in imaging, that is to be given to the radiologist.
Yeah.
That give this pro forma so that they can fill this, and believe me, we had given that pro forma to the radiologist having more than 100 points. They refused. They can't spend more than 2 hours to fill that performer for bloody reporting a CT scan temporal bone, and nobody. So the ultimate thing falls upon the surgeon only, that we need to know how to read that CT scan ourselves, to acquire that information dynamically and in terms of distances and everything on our own, which radiologists otherwise cannot provide. Because if you get a radiologist report in such CT scan, they will report as a normal CT scan temporal bone, which is of no value.
Yeah.
So what kind of CT scan we need? ये खोलना. Yes, ये phone आया. अरे. So are you getting the picture of the CT scan?
Yes.
Yes.
This is the axial CT scan 0.5 mm, and what I am trying to show you, to start from above to below, we will be discussing in our forthcoming webinars about the CT scan of the temporal bone again and again, but relevant to that particular pathology. So today I am showing the CT scan of the temporal bone in perspective of autosclerosis, nothing else. I am not showing in perspective of CSOM or tumors or anything. What all you need to see in relation to autosclerosis. Simple, as simple as that.
Yeah.
बंद करना है इसको, कौन फोन कर रहा है? Yes. So if you go from above downwards, see the first structure what you come across, we all know. What is this? That is superior semicircular canal.
Yeah.
That's what we were discussing. We got the first question today from Dr. Kusum Patidar about the third window lesions. Can you highlight? So this superior semicircular canal is one structure we were discussing, like Krishna sir mentioned. We need to see whether this canal is dehiscent or not. Now the first question is, can we get to know by this scan? This is axial scan. We are coming from above downwards. Imagine the patient is lying in the same plane in which we operate. And this is anterior to posterior, you get the information of structure like this. Okay. Now the superior canal which has gone above, to see the best picture of the superior canal, we have to reconstruct. See, now I am reconstructing it. Can you see? Now see where the superior canal and how to see it. And that, see, why I am showing this, the radiologist is not going to tell you at all. So, and you can miss the diagnosis. There are a lot of reports where the superior semicircular canal fistula was missed, patient were explored, found absolute normal mobile foot plate, abandoned the procedure, came back, and the patient had the same system persisting. Other scenario, patient were operated, explored, patient had a fixed foot plate. You know, Ashish, this is interesting.
Yeah.
Patient had a concomitant fixed foot plate along with the superior canal dehiscence. And you know what happened? Earlier, until the foot plate was fixed, patient was asymptomatic of the vestibular symptom, because there were only two windows functioning. Because the stapes was fixed, patient had a superior canal dehiscence, one window, and the round window, other window. And there was no third window lesion because of the autosclerosis, the foot plate was fixed. And for that, patient was operated and the surgeon made the third window. And then the patient becomes symptomatic. You know, there are so many such reports where the surgeon made the patient symptomatic by creating a third window, which was a natural window, and missed the unnatural third window, that was superior canal dehiscence. So once there is a superior canal dehiscence, see this coronal scan, can you see this coronal?
Yeah.
Now see my cursor, this is the vestibule.
Yeah.
This is the vestibule, and there are three canals. This is lateral canal laterally, this is posterior canal behind, and this is superior canal going up. Can you see this going up?
Yeah. Nicely, yeah.
Keep an eye on the superior canal.
Yeah.
See, I am reverting it back.
Yeah.
There is a thick bone above it. Can you see this?
Yeah. Yes, nicely seen.
So if there is a thick bone above it, it rules out superior canal dehiscence. As simple as that. There is no other test. Clinically, yes, if you are suspicious of if you are very conscious about the patient's clinical history, like Ashish said in the morning, he can pick up his mind senses when the patient walks in that she has autosclerosis. So if we are very, very particular about the patient history in these patients, you know, their typical history, they have a history of occasional vertigo even with the loud sound. They have a history of occasional vertigo, any point of time, and they have a tendency to hear their own sounds. You know, sometimes the patient complain that I can hear my eyes moving. You tap on their ankle and they will hear. That is oversensitivity to the bone conduction. If they eat something, they clench their teeth, they hear it very, very pronounced. And that is a classical symptom of this superior canal dehiscence you will find in those patients. Generally, we don't elicit this history in detail, and it has an immense role. Because if we miss this and explore this patient, we'll cut a sorry figure. And like Kirtner sir rightly said, why these symptoms are coming? Because of this lesion, their cochlea partition becomes more sensitive to the bone conduction. So even the patient, even in these patients, you tap on the lateral malleolus of the leg, the patient will hear immediately. That kind of oversensitivity to the bone conduction, and that reflects in audiogram as well. Like Kirtner sir said, these patients will classically have bone conduction in minus. Over good bone conduction. I have seen these patients having bone conduction. I have in our center having minus 15 dB bone conduction, and if you see, that is classically, you know, good enough to give you a suspicion of a third window lesion. So
there is a comment from Dr. Girish regarding this. If there is a superior semicircular canal dehiscence,
yeah,
you have autophony and sound-induced vertigo also.
Yeah.
So
yes.
He has just commented on this.
Yes, you can have this kind of feeling. And see, once there is superior canal dehiscence, I mentioned during the cadaveric dissection, you go by the, you know, middle fossa approach. You have to remove the bone flap, and the moment you elevate the dura, you saw the prominence of the, you know, superior canal and the arcuate eminence, and there you will find dehiscence. What all you need to do is put some bone vest, fibrin glue, and some fascia and come out. That's it. It is such simple operation you can do even under local anesthesia in no time. So this was the first thing you need to see once you look at the CT scan. See, I told you CT is not really important to establish a diagnosis. I will show you certain pictures. In the first patient, this patient only where I am showing, I have a clear cut, you know, focus on the fistula anterofenestrum in this patient. I will show that. Now before that, as you go down, now see, you need to look at the other canals as well. If there is any malformation in the other canal which may be leading to, or which may lead to vestibular problems later on. Now the more important is the intra-auditory meatus, like sir said, Kirtner sir. If there is any abnormal communication of the intra-auditory meatus with the inner ear in these patients, and if you have a CT scan and you pick up, that is a good enough indication to abandon, to rule out the surgery and give a hearing aid and think of something else. So the intra-auditory canal, all dimensions of the intra-auditory canal must be seen, and intra-auditory canal, see this, the cochlear nerve where it enters the intra-auditory canal. This cochlear aperture dimension should be assessed thoroughly. Can you see this cochlear aperture?
Yeah.
This is where the cochlear nerve enters into the intra-auditory canal, and this same point, if you remember, I demonstrated in the temporal bone dissection, where the cochlear nerve forms and enters into the intra-auditory meatus. This is the point. If you remember this point?
Yes.
This is where the cochlear nerve. And see, with your CT scan, you can easily measure the dimension of the cochlear aperture. See this, 1.67 millimeter. If it is more than 2 or 2.2 or something like that, like Kirtner sir said, this is a direct communication, suggesting that there could be a direct communication between the intra-auditory canals and the cochlea, and that can lead to gusher, and in those situations the Stapes surgery is contraindicated. So there are so many things which your CT scan can really prevent you from going to those problems. Same is the vestibule. There is a situation called enlarged vestibular aqueduct syndrome. You know, again, what happens in that? Because of the inner ear hypertension situation, because of the enlarged vestibular aqueduct, many of these patients present with low frequency conductive hearing loss. And again, if you don't look at the vestibule and the vestibular aqueduct, again you fall in a misdiagnosis and you can open up those patients. What my point?
Yeah.
So see, look at the dimension of the vestibule and the vestibular aqueduct. At this point, you see this is the vestibular aqueduct. You see if it is dilated, or look at the vestibule. If it is dilated, then you have to think twice before taking such patient for surgery. Now, cochlea. See this modulus in the cochlea. If it is defective, this is what exactly Kitne sir said in the morning. If this modulus is defective, it shows there is a direct communication. And Ashim, boss, that was the patient, our patient. Yes. And you know, the carnival, we had a gusher, had a defective modulus. It was IP3 actually. It was X-linked syndrome, which led to inner ear hypertension, conductive loss, and we operated. And I got the scan done later. And for that patient, after a year or so, she had a complete hearing loss, and we had to do a cochlear implantation in that patient. And she is doing well now. So, the other thing you need to see, you know, the course of the facial now. See, this is the labyrinthine segment. Yes. Can you see? That's the first genu.
Yes.
That is the tympanic segment. See this tympanic segment?
Yes.
See this tympanic segment? And this is the mastoid segment. Why I am showing this? This is a very important situation, because this can lead to overcrowding of the over window of the facial nerve is dehiscent and falling down. And if you don't know preoperatively and paraoperatively, if you come across a situation like dehiscent facial nerve, prolapsing facial nerve, again you have to think twice before operating those patients, unless you are very good. If such patient come to Ashim Desai, we will operate. He will do so many maneuvers. We will come to know from you, boss, today later on, what you can all do in those situations. But if you get it as a surprise, then it's a big problem, particularly to a surgeon who is not very experienced. But by means of CT scan, you can get to know exactly how your relationship between the overriding facial nerve, the horizontal facial nerve, and the oval window. So how you can see? Not on this scan. Again, in CT scan, we should know what plane can give you best information. What structure can be seen best in what plane? What my point? So here I will show 3D reconstruction, coronal again, and then you see very quickly the relationship of the oval window and CT scan. See, so simple. So simple. Let me show you first where the oval window is. Can you see the ossicular chain? Look at the ossicular chain. See the malleus?
Yeah.
Yeah.
Now see the incus?
Yes.
Long process of the incus, and see the stapedial suprastructure, and where they are heading to? This oval window. See this oval window? This is the vestibule in the depth. And see what is there in the above the oval window? Can you see this small structure?
Yes, the facial nerve.
Just facial nerve. Now in this coronal section, upside down, imagine, had this facial nerve been here down, over the oval window, would you take such patient for surgery? You have to tell them that you may have to abandon this. If the patient agrees, then you can take a call. Experienced surgeon like you can always do this by doing various maneuvers, by mobilizing, going even above or below the facial nerve. But yes, if you are not aware of this situation and find it as an intraoperative surprise, is a big problem. And then you may have to take...
Many times canal is dehiscence also here.
Yeah, many a time horizontal segment canal dehiscence is very common. Microdenses are very common. And once facial nerve is prolapsing, that is obviously going to be dehiscent only, then only it can prolapse, you know.
Yeah.
So this situation on this coronal CT scan, if you find this facial nerve lying below in the line of the oval window, that is something giving you a direct idea that your facial nerve is prolapsing. Now you have to take a call on your own. Okay?
Yeah.
What about gushers preoperatively? If we can see on CT scan, there are too many questions.
Yes. So I have already mentioned for the gushers, number one, if you have a dilated intra-auditory canal, if you have a big, cochlear aperture more than 2.2 millimeter, if you have a dilated vestibule, if you have a dilated vestibular aqueduct, and some people theoretically call it, let me show you. See, this is the cochlear round window and this is the cochlear aqueduct. Though though this has never given a gusher. You know, the most of the work I have gone through, I have seen and read and discussed. The majority of the work, the extensive work on this cochlear aqueduct is done by Professor Robert Jackler. His publications, mind-blowing publication on cochlear aqueduct, enlighten us what exactly it is. There are a lot of myths involved with it. Not a single case of gusher till date actually is attributed to the cochlear aqueduct. For example, that is always a myth. Because whatever, in spite of having a dilated cochlear aqueduct, it is filled up with a mesh of fibrofatty tissue, which doesn't directly, transfer the CSF pressure to the inner ear to give it a gusher. This is always a myth. But yes, if it is dilated, you can see on CT scan, this can be a source of communication of infection from the intracranial space to the inner ear, or from inner ear to the intracranial space, for that matter. And this is the principal source of, meningitis transferred to the inner ear through the cochlear aqueduct to give it the situation of labyrinthine ossificans. That is the responsible thing. That is cochlear aqueduct.
Satish, there is a question from
Yeah.
Dr. Pushkaraj, Mumbai.
Yeah.
How to see persistent stapedial artery or aberrant ICA?
Yes. I am coming to it. So I am coming from above downward. This is all relevant. This is very important, valid question.
Yeah,
that's why you need CT scan.
CT scan.
I remember Ashish's case last year, and we have a picture today as well, when he came across a case of persistent stapedial artery. In our practice, I have seen only 2 cases so far. I don't know Ashim, his figure is 6,000 plus, how many times he has seen the persistent stapedial artery. But this is rare, and this is a small vessel, a tiny. Boss, how many stapedial arteries you have seen?
4.
4. Great. So, this CT scan, like somebody asked the question about the persistent stapedial artery. This CT scan cannot pick up the artery as such, but it can give you enough evidence, ample of evidence that patient might be having persistent stapedial artery. The reason is, we need to understand the embryology of this vessel. This vessel, in brief, I'll tell you, this vessel is a branch of dorsal hyoid artery in the embryo, which is the principal artery in the embryo, like external carotid in the adult. And at some point of time, around 10 weeks of the embryo or so, this vessel runs over the promontory, goes towards the stapes, and at the 10th week of embryo, as the stapes art starts developing, the obturator foramen of the stapes develop, this vessel gets absorbed. And there is no more stapedial artery, and this leads to formation of future middle meningeal artery. Now in those patients where this vessel doesn't get absorbed.
Allow me, I'll say this is the magic. Why is the stapes, the shape of it is an arch?
Yes.
Because of the obturator foramen.
Where this vessel passes.
Only artery in the body in the embryonic age where the direction of the flow changes magically from the internal carotid to the external, and then it changes. This is something very, very magical. This happens between 5 weeks to 10 weeks in the embryonic life. And this is why, and it goes more, ultimately it exits just posterior to the cochleariform process. Therefore, the anterior crust tends to be little thinner because the artery is positioned more anteriorly.
Yes,
Between
that is
the anterior crust and posterior crust. Go ahead.
super. See, that's how embryology is important. So normally this artery gets absorbed, leads to future meningeal artery, and we don't see this artery persistent in a normal individual. Now, if this artery persists, it passes through that stapedial arch, then enters the facial canal, and then through the facial canal it goes intracranial and destined to supply certain intracranial structures. So, in case this artery is persistent, we may not be able to see this artery passing on the promontory. That's a small vessel, and that is a soft tissue. We may not be able to pick up on CT scan. But what we can pick up in that situation, if the artery is passing through the facial canal, the dimension of the horizontal facial canal would be more than the usual. See, this is horizontal facial canal. In any given patient, when you are suspecting otosclerosis, having this dilated horizontal facial canal, dilated more than double, gives you suspicion that there could be a persistent artery passing through it, number one. Number two, as I said, it leads to future middle meningeal artery. Once this artery passes or persists, There is no middle meningeal artery as such. And in that situation, on CT scan, very easily you can pick up, see this.
The foramen spinosum.
Yes.
Spinosum is absent.
Yeah. So where is foramen spinosum for everyone? This is the pterygoid process. This is the pterygoid process. Behind the pterygoid process is the foramen ovale, and then behind that is the foramen spinosum. So when this artery is persistent in the adult, there is no middle meningeal artery and there is no foramen spinosum through which the artery can pass through, and that is a good enough indirect evidence that patient might be having a persistent stapedial artery. We'll discuss later whether we can do anything to it or not, but here on the radiology this is relevant. That question was relevant, that how to pick up a persistent stapedial artery. Then we have already discussed about the inner ear and all these findings, if there are any, the facial nerve, if there is any prolapse, and secondly the ossicular chain. Like we will get to know from Ashim, he has a huge experience of fixation of the malleolar ligament. In autosclerosis, because of the fixation of the ossicular chain, it is not uncommon to see hyalinization and fixation of the malleolar ligament, contributing further to the conductive hearing loss. Why it is so important? Because even if you improve the stapedial fixation, if you ignore that fixation of the malleolar ligament, the conductive hearing loss will persist. Now, you can pick up intraoperatively by checking the mobility of the malleus thoroughly. If you are good experienced, you can pick up even the slightest fixation of the malleolar ligament, and that we will learn from this master today, how to exactly check the mobility of the malleolar ligament. But if you are not very experienced, you can have a very good idea of the malleolar ligament fixation on the CT scan. Couple of times we have seen the malleolar ligament completely ossified, and we picked up on a CT scan where the malleus was fixed and the reason for conductive hearing loss along with the stapedial fixation. So see in the atic, can you see the malleus and incus?
Yes.
There are three ligaments which are important to us for that matter. One is anterior malleolar ligament, one is superior malleolar ligament, and third is posterior incudal ligament. All three ligaments around, if they are ossified and fixing in the atic, you can have a very good idea. Can you see in a normal situation these ligaments will not be visible on CT scan unless they are hyalinized and ossified. So see this, it looks like these two ossicles are suspended in the atic without any connection, and that is the normal situation you need to see on CT scan. See the malleus anteriorly, where would be the anterior malleolar ligament? Anterior to it, going towards the anterior atic. Okay, and this ligament passes anteriorly, I mentioned in the cadaver, through that passes further anteriorly through the Glacerian fissure, under which the chorda tympani passes through the canal of Usier. So this is the site of the anterior malleolar ligament. How to see the superior malleolar ligament? To see the superior malleolar ligament, you have to go to the coronal picture. See the coronal picture? Yes. See this. See the incus, see the malleus in the atic?
Yeah.
Very clear? If there is superior fixation of the malleus in the atic, you can get to know very easily with bony fixation, and I have seen 7 or 8 cases in my practice where I have found the malleus fixation superiorly in the atic, and you can very easily get to know on a very good high resolution CT scan. And if this information is having in your mind pre-op, you know the implications. Many a times to go on to the superior limit of the malleus in the atic, you have planned a transcanalicular surgery, transmeatal surgery, and then you may have to go post-oral. You may have to go post-oral. So you can plan your surgery better, you can counsel your patient better that you may need a post-oral incision. Dr. Ashim does the same thing with the mini endoral. That is the advantage of mini endoral incision, boss, you are doing. You can go with the same incision to the atic as well. But this is something, if you know pre-op, it is always good. See, if we know our diagnosis well, by means of taking advantage of the radiology, we can, certainly avoid all these intraoperative surprises. That is the goal of, radiology. If you agree with me or not, I would like to have your opinion.
No, brilliant. Absolutely. There's no question.
So all these things you can get to know. The carotid artery, like sir asked the question. See, this is horizontal carotid. Can you see?
Yeah. Yeah.
This is the cochlea. We saw in the dissection how intimate they are in relationship. You know?
Yeah.
The cochlea and the carotid. If this partition is gone, bony partition, this acts as a third window.
Yes.
Leaking the current from the inner ear, acting as a third window. Again, if you don't have a diagnosis of this, is a disaster again. So third window lesion is not always superior canal dehiscence. Anywhere this inner ear current is leaking, you know, example I tell you, enlarged vestibular aqueduct can behave as a third window. This dehiscence carotid can act as a third window. Any semicircular canal dehiscence can act as a third window. Any cochlear dehiscence anywhere can act as a third window. And more importantly, I have seen a case where we did a cochlear implantation, had an extreme cochlear autosclerosis. And you know, the cavitation of the cochlear autosclerosis was communicating to the internal auditory meatus, acting as a third window. So third window can be because of many reasons. Only thing, by means of radiology we can pick up. And more importantly, now I will come to the diagnosis. In the last, I told you this is of least value. I have not told you anything about the stapes and the oval window and all those things so far. Yes. Now see if I am coming from above downwards. This is the horizontal facial.
Yeah.
Below the horizontal facial, this is the vestibule. Can you see?
Yes.
And can you see the stapedial arch?
Yes.
The anterior and posterior crest, can you see?
Very nicely. Yeah.
See this? By this CT scan, you can have a fairly good idea how thick would be your foot plate, number one. See, this is so important for a beginner. It may not be important for a master like Ashim Desai and Ashish, because they have been doing a lot of obliterative stapes surgery done. If he gets an obliterative, he will start drilling and give the same result, believe me, which everybody cannot. So the idea is, if we have this pre-op information, this has a strong influence, a strong impact on the overall outcome. Because if you have an obliterative autosclerosis, the results cannot be as good as in a blue foot plate. Except the exceptions are there. If you are so good, like Ashim, I have seen him, he did in Jaipur, in the, Stapes Carnival, I remember that patient, had a complete obliterative autosclerosis. He took 2.5 hours, drill each and every part of the autosclerotic foci, and then made a fenestra, put a piston, and that patient is till date having absolute closure of the airborne gap. That was a master section. But believe me, it is so difficult, it is not all that easy to drill away the obliterative foci. So, if you know this information on radiology, that your foot plate is too thick, obliterative, this is a good enough evidence to warn your patient about the results. Think twice before taking up that case. You can refer to a more experienced one, or you can advocate a patient a hearing aid, if you can't do that. So this thickness of the foot plate.
Question, Dr. Satish.
Yes, boss.
Yes, sir. Sorry, carry on, please.
Yeah. So this thickness of the foot plate can be assessed based on the cone beam CT scan. I mentioned 0.05 mm. We have seen on cone beam, measure the thickness of the foot plate, that it is 0.3 mm thick, and intraoperatively we observe the same thing, how thick the foot plate is. And if you, Ashish, if you have this information that your foot plate is 2 mm thick, and if you know it before, won't it change your approach and counseling to the patient?
Absolutely, yeah, absolutely.
See, this is so important. The second thing what you need to look at the oval window here, the integrity of the stapedial arch. Can you see the entire stapedial arch?
Yes.
And the incudostapedial joint in this dynamic CT scan?
Yeah.
So good. The entire information you get. Now the most important thing.
In revision surgery, this becomes an important.
Yeah. Now the most important thing I am going to show you. This is your vestibule. This is your foot plate. Can you see this hypodensity anterior to it?
Yeah. Yes.
Why I am saying so? See the contrast of the hypodensity. The bone of the cochlea, this otic capsule is so bright. Can you see?
Yeah.
And this part of the otic capsule where the otosclerosis starts, the fistula anterofenestrum.
Yes.
What is otosclerosis? Where the thick enchondral bone of the otic capsule is replaced by this spongy bone.
Yes.
More vascular bone, more hypodense bone, and you see the difference in hypodensity. That is what the beginning of the otosclerosis is. Can you perceive it very clear or not?
Very, very nice.
Yes, very nice.
You may not see always, because you may not see always. This is so important. In a patient we are suspecting otosclerosis. Now this patient, I am suspecting clinically otosclerosis. I have already told before exploration there is no 100% test to diagnose otosclerosis. But now with this kind of a CT scan and corroborative audiological finding, I can be very much sure that this patient is otosclerosis. That's how it helps. Now more than that, this otosclerosis of the fistula anterofenestrum, even in a patient with a full fixation of the foot plate, you may not find this foci so big. Absolutely normal you may find. The reason is how the otosclerosis starts. You know, if you go through the Shuknet's book, Shuknet was, you must be knowing the Shuknet,
Yeah.
the great autopathologist. He wrote so many books on the pathology of the temporal bone only. 1,000 pages book on the pathology of the temporal bone. Amazing. And what he found, this otosclerosis foci starts here at the fistula anterofenestrum, very small foci, and yet can it give a hearing loss. How come? The moment this foci starts forming at the anterior end of the foot plate, it pushes the foot plate behind, you know, and the foot plate gets fixed posteriorly at the posterior stapediovestibular joint. What's my point? As the foci pushes the foot plate behind, the foot plate gets fixed at the posterior stapediovestibular joint. What's my point?
Yes.
Not true annular ligament fixation, and yet you can get conductive hearing loss up to 30 dB or so. That's why we don't generally advocate Stapes surgery in minimal airborne gaps. You know why? Because in that situation your foot plate may not have been adequately fixed. Your annular ligament may not have been adequately fixed. This could be because of this foci at the fistula anterofenestrum which have pushed the foot plate behind and fixed the posterior stapediovestibular joint. And such a case with an airborne gap, say 20 to 30 dB, if you take up for surgery with your regular instrument, where the foot plate is not completely fixed, what can happen? Floater. Easily floater.
Yeah.
So such
That is
every
why one point is
Yes.
that in general, when you are trying to enlarge the opening, it should never be done by picking at the posterior part of the fenestra, for the simple reason that the posterior pole is impacted, there's a larger chances of making it fully mobile.
yes.
When you're enlarging it, you should always do it at the expense anterior.
But boss, generally, I want to ask one thing. That's a very important point from him. Very practical. Don't go too posteriorly, otherwise you'll get a floater easily. But
Yes.
boss, generally, we don't advocate making a fenestra anteriorly because of close crossing.
Enlargement of the fenestra.
Enlargement. You are always making the enlargement in the posterior third of the foot plate. I mean,
Okay.
the fenestra.
Okay.
But assuming that you need to enlarge it, it should be done anteriorly. That
Okay.
micro enlargement, micro cleaning up of the bony fragments, so on and so forth, should be done anteriorly.
Satish, I also want, you mentioned about the pathology. There is a beautiful network site, autopathologynetwork.org. This is run by Harvard. I think
Okay.
I strongly recommend people go and see this. It's brilliant.
Okay,
Can you
great.
repeat, please?
Autopathology.org.
Autopathologynetwork.org.
Great.
Yeah, it's
So boss, Ashim,
So, Satish,
Ashim and Ashish, I want a question from you. I want to ask you something here.
Yeah.
Patient, like I mentioned that these are early airborne gap patients up to 20-30 decibel with incomplete fixation of the foot plate at the annular ligament level all around, which can give to floater. What is your indication for advocating surgery to these patients? When you advocate, Stapes surgery, at what hearing loss level in terms of AB gap?
AB, yeah.
Let Ashim take over.
So this question has come from many of us, from the viewers.
Okay,
same
so the answer
question.
to that would be in the region of about 30 dB is when I would pick it up. But the most important part, once again, is the Rene. Until the Rene turns negative, whatever the audiogram says, I will not take up the patient for surgery. But yes, typically 30 would be the bare minimum. There have been instances when people have virtually pushed for even smaller airborne gaps for surgery for social reasons, whatever may be the reason. And in those cases, it is imperative to have a laser available because the chances of developing a floater is extremely high when physically manipulating the foot plate.
Now we are having lasers.
Yes.
You are also having laser.
Absolutely.
Won't you advocate surgery to them having laser and ensure
till Rene is
now
negative.
by means of laser you can almost 100% ensure that you are not going to give floater.
Absolutely, absolutely, but not till it's Rene negative.
But still, Satish, the anterior crura, it's not just the fenestra. The
Yeah.
anterior crura is also a mechanical movement most of the times.
Yeah, so Ashish, with the lasers now the fiber is available.
Yeah.
You
So
know,
I agree.
even with the inaccessible location of the anterior crest and all that,
Yeah.
you
That's
can
how I
vaporize
have
with the laser.
Yeah.
So now you can treat early lesions, you know, with lesion not having shown complete fixation, not having shown so much of spread of the otosclerotic foci, and you can give good hearing in the beginning with the laser.
Yeah. I'm
So-
not sure whether 15 dB gap patient even wants to come to do
No,
surgery.
not
or
15 dB. It's around
Yeah.
25 dB, I would say, 20 to 30 dB, not 15 dB. So this is about the oval window. Now the other thing you,
Satish,
Yes.
can we differentiate between the congenital fixation? Can we look at the annular ligament or its absence on a CT scan?
not really. Annular ligament cannot be seen on CT scan. And for your question about the congenital fixation,
Yeah.
yes, you are right. In congenital fixation, the annular ligament doesn't differentiate, you know.
Yeah.
And so there is a complete bony fixation of the foot plate to the oval window. Generally in the embryo, it differentiates into annular ligament where the foot plate becomes mobile.
Yeah.
So in that situation, you have to do a proper surgery in the congenital. There are two situations, congenital and juvenile otosclerosis. Both are different,
Yes.
you know.
So very different.
There has to be very clear this thing in the mind. Congenital or early presentation. Like I have a child, 4-year-old, maybe bilateral conductive hearing loss with otosclerosis. I have a patient, 10-year-old, 11-year-old with otosclerosis with family history. That cannot be congenital, that is juvenile.
Yes.
Congenital have no family history, early presentation,
Non-progressive. Yeah.
non-progressive at all, and they are good candidates for Stapes surgery. We have some patients we have operated, not 4 years, but my earliest is 6 year I have operated, and absolute good result. Juvenile on the other hand are difficult, I tell you, because majority of the juvenile have obliterative focus.
And extremely vascular foci.
Yeah.
It's the bleeding occurs through the foot plate itself,
Through the
not
foot.
just the mucosa.
Yes.
So I have no experience with juvenile.
Juvenile is difficult, always difficult, and you have to have a full consent because of the future also, because you never know how durable are the results going to be.
Yeah.
Now the
There
second
is
thing
a
you need to,
question, Satish,
yes please,
from the Deepak Dalmia.
yes, man.
In how many percentage of patients in your series of Stapes surgery you have felt that imaging has changed your plan of action?
Okay, that's very good. Deepak, I tell you, again I mentioned during the internal tympanoplasty also, that you do tympanoplasty by any technique, you will get 90% result or so. Taking from 90 to 99 requires a huge task. Same in otosclerosis. Your question is valid. 90% of the time you don't get any investigation. Like Ashish said, the patient comes to your OPD, you sense otosclerosis, you explore and you go correct. 90% of the time you go absolute correct without any problem. Now rest 10%. Out of those 10%, 5% are the situation, 5 to 6%, which complicates your surgical aspect, and that is the test of your experience. If you are not experienced, you may have to abandon those situations. And if you are experienced enough, you can tackle all those 6% situation and still you can carry out without hardly any change in the overall outcome. 2 to 3% of the time, is the litmus test, and that is the time where your
These courses are really designed for that. It is
yes.
that.
It is
So
to
this
take you
this
from
course
95
is
to
designed
99.
for that 2%, where
So
your
because
radiology.
it's about, let me convert the question into, would you do a FES surgery without a
Yes,
CTPNS?
same like that.
What changes? Nothing changes really.
So Ashish,
I
why
mean,
this question comes?
want.
Why this question comes? Because 90% times you get away without any issue, and then the surgeon will say, "Why are you spending time and money in CT scan and talking all these fancy things?"
And being forewarned
You
is
know,
forearmed. So that is the.
Ashish, this is one surgery. Believe me, the most fascinating surgery, but at the same time, if anything goes wrong, gives you the
all or
highest
none.
level of
It's all or
depression.
none phenomenal.
All or none. You can 95% of the time you can give patient on table, absolute good result, so appreciable, and you are on high.
Yeah.
In 3 to 3.5%, rest 3 to 3.5%, you give partial results because of the problems, or whatever good result you give deteriorates over the period of time because of certain issues. In 1 to 1% test is the litmus test, I tell you again, which are, because of your experience you can avoid those issues, because of your radiology you can sense, you can preempt those issues and avoid them, and in up to 1% of the problem, nothing is in your hand. In spite of having done great job, believe me, you get a sorry figure. The reason is, there are certain things when you open the inner ear and things are beyond your control. You may come across a subclinical high drops. There could be uncontrollable, reaction of the inner ear leading to the vertigo, sensorineural hearing loss, long-term problem. You never know. And thirdly, you never know this unique architecture of the middle ear ossicle that is not same in every individual. I tell you an example. When Deepak has asked this question, in 1%, why I am saying is not beyond your control. Having done fantastic work on table and yet you are not getting long-term result, and the reason is very obvious. I have gone through lot of publication about it. Our ossicular chain system suspended in the middle ear is such unique, and it has several points the God has given us impedance, to dampen the sound, excess sound to the inner ear, to give inner ear loss. Impedance, the dampening, number 1 at the level of tympanic membrane. Number 2, and the most important to me, number 2 at the incudomalleolar joint, then incudostapedial joint, and out of all middle ear ligaments, the highest level of impedance is exerted by the annular ligament.
Annular. That's a magic actually. Magic.
Highest level of impedance out of all middle ear ligaments is exerted by annular ligament. The God has given us this system. So what happens? Once you, in a normal situation is different, as the sound comes, it is dampened by the incudomalleolar joint. The tympanic membrane and malleus goes medially, and that leads to movement at the incudomalleolar joint, and that is transferred to the incudostapedial joint. If that sound is not very high, that is easily transferred through that joint, and the IS joint again goes medially, and from that the stapes goes medially, and if it not excessive, the annular ligament otherwise will restrict, and the stapes will go medially for few nanometers. This entire unique system is completely destroyed after this surgery. Now the new system has come in, piston with no annular ligament. What my point?
Yeah.
Am I audible?
Yes,
Except
yes,
when
yes.
you use the vein.
Now see what that's why the vein, that's what I was coming to. So now what happens? What happens
Vein
now?
is not a ligament.
Yeah, let me tell you the biomechanics. So what happens? Now the stapes is replaced by a piston. Otherwise earlier, the whole diameter of the stapes 3.2 millimeter was going in and out, but for a very small movement, few nanometers, and now it is replaced by a piston with a very less diameter, 0.12 millimeter. For a 0.4 piston, the total diameter of the movement is 0.12 millimeter. in place of 3.2 millimeter of the Stapes. What my point?
Yes.
Yet we are getting good sound. Why? Because now the amplitude of the movement is more as compared to the amplitude of the movement of the Stapes. The earlier the amplitude of the movement of the Stapes was few nanometers. And now your piston is moving in and out much more. 0.3 millimeter means 300 nanometers, something like that. Like Ashim said, in extreme situation, 0.5 millimeter means 500 nanometers as compared to few nanometer of Stapes. That's how it is compensated, that in spite of a very small hole, our sound qualities, what we hear is very good, because the movement amplitude is more. Now why I mention at this point, like Deepak asked, in certain patients, we don't have any control about the overall post-operative hearing and the long-term hearing loss, because this has been proven now in the orthopathology. You go to the Shuknet book. Over the period of time, the quality, the elasticity of these ligaments controlling these joints weakens. You never know who the patient you are operating, the quality of the ligament, what exactly it is. What my point?
Yeah.
What is the quality of incudomalleolar joint in long run? You know what happens in the extreme sound pressure when the incus, the tympanic membrane and the malleus comes medially, that entire sound is not transmitted to the inner ear. What is the first obstruction? Incudomalleolar joint. And what happens there? Coupling, reverse coupling.
Decoupling.
Recoupling, yes. The malleus goes in and the incus goes out. That is to counter that sound going inside. That is the coupling between the malleus and incus at the incudomalleolar joint, and so that the entire sound is not transmitted to destroy the inner ear. So that coupling is controlled by the incudomalleolar joint and the ligaments, and that is beyond of control. If I have operated a patient whose ligaments are so weak, what is going to happen? His piston will go unimpeded in and out, and the patient may get sensorineural hearing loss after a few months, and then patient will come and fall upon me. Doctor, you have ruined my life, that I have developed sensorineural hearing loss. My entire whatever hearing earlier was even is completely lost. That the fault is lying on the doctor. That's why we always take a consent. In up to 1% of the patients, nothing is in our control. There are so many reasons. I'll take you later on to a slide where I will show you so many reasons which are responsible for that unknown control of unknown hearing loss, which is beyond the control. So now the next point, Ashish, in the radiology, before I wrap up the radiology part, the next you need to look at the cochlea. Why at the cochlea? In the cochlea, you need to see if there is any otosclerotic focus in the cochlea. If the patient particularly having mixed hearing loss, if you find a lot of cochlear destruction, then you have to take a call of associated medical management at the same time to prevent the bone resorption further, like the Ashim is always doing. We'll know about your protocol later about your medical management. I know sir was giving every patient sodium fluoride for at least 2 years. I don't know now. So we will get, we will know from you. So that is important. If you have a lot of otosclerotic foci destroying your cochlea, you have to take a call. That is important information pre-op on radiology. Second, in the far advanced otosclerosis, there is a lot of cochlear destruction. This information is pivotal. This information is so vital. If your cochlea is destroyed too much, to take a call of cochlear implant without wasting time. Otherwise, you will lose an opportunity to insert an implant later. So the radiology is again game changing. So all these things are important to be kept in mind. I will go to the case. Case is ready now. The first case for the surgery is ready now. And the last thing at this point of time, yes, there was a question about the jugular bulb. In few patients we have seen the high riding jugular bulb even crossing the round window, and that is something you have to be aware. If such situation is there, you have to be more prepared. It's not absolute contraindication. It depends upon your surgical expertise to handle that situation.
For annulus elevation, you have to be careful.
Yes, careful. So how you can see, this is the level of the cochlea, this is the level of the round window basal ton. See, and we don't see in this picture anywhere the jugular bulb.
Yes.
That means jugular bulb is too low. If I go lower down, see now the jugular bulb is coming into the picture. So now, if you really want to know how low is the jugular bulb from your round window, you have to go to the 3D picture. See this. Again, I will show you. Can you see this jugular bulb here?
Yes.
Let me take my cursor here. Okay? And now see the jugular bulb here in the coronal, upside down picture, to see the distance of the jugular bulb from the round window. See this, jugular bulb is here. Now if I run, see this. This is my round window and this is the level of the jugular bulb. See how far it is? This is round window here.
Very far. Yeah, correct.
And this is jugular bulb and I can measure. So this is to make your life easy. See, all these measurements help you in planning yourself. It is 8 millimeters. It is miles away, I would say, as far as the jugular bulb is concerned from the round window. So all these things are important. You need to sit with CT scan for at least half an hour before planning autosclerosis surgery. And all these points I have mentioned are specifically related to the autosclerosis. We will see the CT scan differently when next week on Thursday we will take up a case of cholesteatoma with facial palsy. Then the things we will look at the CT scan will be altogether different than what we have seen today. In spite of all this,
CT bajate raho.
In spite of all this, having a normal CT scan for that matter, Ashish, absolute normal CT scan, still we can find problems because we don't know the ultrastructural architecture at the membranous level.
Sure. Yeah.
What we are seeing is the morphology, the bony morphology, not at the membranous level, and that you can come across still intraoperatively. So, in few minutes of the time, I will be back with a microscopic picture, and in a few minutes. And meantime, Dr. Sanjay Khanna, boss. Yes, you can take questions. Yes, boss.
Message for all those viewers, more than 5,000-6,000, and all this 2-hour discussion is, I think, more than you cannot find all these points in any given books in the literature everywhere. So I think I request everyone to go through again in the evening and just find out what the content being discussed right now in 2 hours, and that will be worth for all of, I think, those who are viewers and those who are going to see the recording again.
Okay, boss, but my radiology is not over.
I know.
Can you hear me?
Yes, I will show you.
Revision, but that later, no, Satish.
I will show you something which is very important. I tell you. Why I mentioned in the beginning about the MRI. This is game changing, I tell you, MRI, and for the regions, and we are in the process of studying this particular thing on MRI, how it can benefit us as an information which can be vital. Like Dr. Ashim said in the beginning, or I mentioned as well, the subclinical high drops. Certain patients have subclinical high drops, and what happens in those patients with no symptoms preoperatively or vertigo or anything? If you have a symptom of vertigo, tinnitus, hearing loss, that can warn you of something going wrong in the inner ear. But absolutely silent symptomatology, yet you open the vestibule, do your fenestration, your piston insertion, come out absolutely asymptomatic, and a post-op patient has a terrible problem with vertigo and sensorineural hearing loss. And the reason was the subclinical high drops. How you can pick up? By means of MRI, because now it is a soft tissue in the inner ear that cannot be picked up by CT scan. And the investigation of choice we take in our practice, if I can show you, let me, is this? Okay, so what do we do in MRI in those patients? There is a specific sequence of MRI in those patients, what we call it as a contrast MRI after IV gadolinium injection. Let me take you directly to that. Yes. What is that? You can easily understand, and for what patient it is required. Advocating MRI to every patient of atherosclerosis is not practical. You understand it very well.
Yes.
Ashish, every patient of atherosclerosis you cannot get MRI done. But there are certain subset of patients, because at the same time you have to understand that nothing is in your hand every time. You never know what is going on inside 100%. So if those patients who are very, very particular about the sensorineural hearing loss, many of a chunk of patients coming to us with otosclerosis disease for surgery, their first question, doctor, I have read on Google that my whatever residual hearing can go completely with this surgery. What will you say? Yes, it can, but in a small subset of patients. And those patients, that region is beyond my control. So my result, I can tell you, is over 98%. And that is equivalent to the best results in the world. That's what you can say to your patient. But that 1%, 1.5% is not in your hand. So those patients who are more concerned, you can order this investigation. In our series, we have now over 60 patients we have got done this and got amazing findings in 3 patients, you know. So what is this investigation? By means of which you can pick up subclinical hydrops pre-operatively. What is that? So in this investigation of MRI, we inject IV gadolinium, and after 4 hours of injection of the IV gadolinium, we take the MRI scan, and that is FLAIR image, fluid inversion image. So in that, what we do, see this picture, what are you seeing in this picture? Some funny things on this picture. What is this? See, after 4 hours of gadolinium injection, the gadolinium is preferentially taken up by perilymph, not by endolymph. So the perilymph will appear hyperintense, and endolymph will appear, endolymphatic space will appear hypointense. Now see in this patient, these 2 patients, can you see here the hyperintense perilymph?
Yes.
Any dilated endolymphatic space you find here? No.
No.
Can you see on this side? Can you see on this side? This is perilymphatic space, and see the dilated endolymphatic spaces. Can you see this?
Yes.
That is good enough to tell this patient has a ongoing endolymphatic hydrops. And if such patient you take up for surgery, what is going to happen? Absolutely, such majority of such patients remain asymptomatic. You open the vestibule, you put your piston, and you happen to rupture the membranous labyrinth, which is already dilated, which you are not knowing. If you know by means of this investigation pre-operatively with this dilated perilymphatic space, if I get such patient, see this, how much of the dilated space as compared to this side, I would never operate this patient in my life. That will be a disaster on my name that I have given a complete sensorineural hearing loss to this patient. So these are certain things you can avoid by means of using the help of this radiological information. So those patients, yes.
No, go ahead, complete this.
Those patients who are too concerned about sensorineural hearing loss, those have Googled enough earlier, gone to several doctors with a fear of losing the residual hearing after this surgery, you can advocate this investigation. Let us see what is happening inside. Let me see what are the chances and get this investigation done. If I find this patient this kind of a picture, now I will strongly advocate you have a very less chances of having any disaster. But having this kind of a picture, I would say better stay away and use a hearing aid.
Yes.
Now Ashish, yes.
Satish, a role for, you've done the surgery and the patient lands up with vertigo on the same day. Is there any role for imaging in such patients? The pneumolabyrinth and,
yes,
on day 1, day 10 and...
Yes, that's very important. Not day 1. Obviously, the patient develops vertigo or sensorineural hearing loss if you do it Weber's test or whatever. And that too on, uneventful Stapes surgery,
Yes, when the surgeon believes everything was fine.
So first management is obviously a conservative one with a steroid, antibiotic, and that will learn from Ashim. He has a huge protocol for this.
Yeah.
But if it goes, uncontrolled.
So just role of imaging, since you are here, I
Yes.
just wanted to
So
complete
imaging
the,
has an immense role. Number one, by means of imaging, both CT and MRI, you get a lot of information. By CT scan, you can get to know how deep your piston is inserted inside the vestibule. Many a time, unknowingly, if your piston has gone too deep to damage the membranous labyrinth, you can get to know very easily by a CT scan. Though it overestimates by a fraction of millimeter, but still it is very useful. And those patients you can immediately take up for re-exploration, remove the piston, put a vein graft and put another piston of adequate length. Secondly, with a persistent this kind of a feeling, you have a suspicion of a perilimb fistula then. Then again your imaging can give you help. On CT scan, if such patient with this persistent problem after 7 days, on CT scan what you will find? The pneumolabyrinth, the air in the labyrinth. See, the moment you open the labyrinth, the air will be
there
there.
has to be a, yeah, correct.
You get the CT scan, next day done, the air will be there, definitely.
There.
But
So
it
up
will
to
not
10
persist
days.
for 7 days. If it persists for 7 days or beyond, that is a definite indication of a perilimb fistula. And same thing you can get on an MRI, a heavily titubated MRI, where the fluid of the the inner ear, because the middle ear doesn't have any fluid. Middle ear doesn't have any fluid. Any fluid in connection with the fluid in the inner ear flowing in the middle ear, that is a direct evidence of a fistula. And then you have to take a call. Any more questions, Sanjay sir? Ashish,
Many questions are there
yes, please.
related to this investigative part, radiology.
Yeah.
Can you comment on monopodal stapes?
I forgot
This
it.
is by Dr. Sandeep from Pune.
Admit. Monopolar?
Monopodal.
Monopod. Yeah.
That is an anomaly, you mean to say?
Yeah.
There are a lot of anomalies, they are very uncommon. Some anomalies you will find a different, architecture of the stapedial arch. Sometimes both screws are very close to each other.
Yeah.
Yeah. Sometimes the includo-stapedial joint completely, fused. Sometimes the neck is absent. Sometimes all these are, they can happen.
Typically, the stapedius is also absent, and maybe the pyramidal process is also.
Yes.
Usually, monopodal will be accompanied by also an absence of the stapedial muscle.
Yes.
Another question is from Professor Sunil from Jaipur. Comment on malignant autosclerosis.
Malignant autosclerosis, I don't know what it is.
You see, the malignant autosclerosis is probably
Maybe advanced autosclerosis.
yes, yeah, given the term to the far advanced autosclerosis by some people.
Far advanced autosclerosis.
So the definition of far advanced autosclerosis, by definition, it is when the air conduction threshold is above 85 dB with no measurable bone conduction, and on CT scan you will find lot of confluent lesions on the in the cochlea of cavitation of the autosclerosis involving the otic capsule.
Yeah.
We will
that is-
discuss now FAO in more detail.
Yeah, we'll discuss later the indication of cochlear implant stapes in detail later.
Where is the surgery now, Satish? Where are you?
This is beginning, boss. This discussion is going to go long.
No,
Yes,
no, the
animal.
surgery is
Yes, question, boss.
So the next question is from Dr. Jagdish from Oman.
Yes.
What is your in your series? What is the incidence of round window obliteration
by autosclerosis.
by autosclerosis?
Ashiv or Satish take that.
I would say
You can take
Repeat the
it.
question, boss.
Dr. Ashwin.
I would say less than 1%.
Boss, can you repeat the question?
What is the incidence of round window obliteration?
Because of the sclerosis.
yeah, up to 1 to 2%.
Less than 1% in my
Yeah.
series.
Obliteration is asking, not just presence of the focus. That
Whatever incidence reported in the literature is underestimation because of not getting CT scan done so frequently. The actual incidence is higher, though it may not be contributing to the hearing loss in all cases.
Correct.
The round window involvement of the autosclerosis is whatever reported as compared to that is quite high, but not giving problem clinically.
Not giving a clinical, yeah.
Yeah, इधर लाना mic. Mic इधर लाओ. Yes, any more questions?
Yeah, there are few many more.
Go ahead.
It is related to CI, again in advanced otosclerosis that we will discuss, I think, later on.
Yes.
Just a minute. So this is from Ahmedabad, Dr. Jain. In case of subclinical endolymphatic hydrops, will
Yes.
vein graft interposition help?
Yes, always.
The problem here with subclinical endolymphatic hydrops is at the point of fenestration. There can be an issue with a dilated saccule. So that is what we are afraid of more than anything else.
Yeah, but still vein graft will help to prevent fistula.
Having said that, assuming that you have no damage to the saccule at the point of fenestration, vein graft is always preferred. So in those cases, even with non-endolymphatic hydropic distension of the labyrinth, of the saccule, even in cases with otosclerosis with vertigo, which is non-Meniere's,
देखते हैं,
those
वो दे देना,
also
propofol
vein
दे देना.
graft is important. Because otosclerotic vertigo is a well-known clinical entity in and of itself.
There is another question from Dr. Ravi Mayer, New Delhi. The role of CT densitometry in otosclerosis.
Yes, CT densitometry is another investigation. The reason is, though it is not very useful in a regular practice, but yes, it gives information about the density of the bone to diagnose otosclerosis. Can you hear me?
Yes.
Yeah, we can.
So, as I mentioned, this otosclerotic bone is relatively hypodense to the normal otic capsule bone.
Yes.
So, by means of densitometric changes, you can pick up the involvement of the otic capsule wherever it is because of this otosclerosis. Normally, what happens? Normally, whatever our otic capsule is formed in the embryo, finally, it never goes any changes throughout the life. Never. Whatever it is, it remains like this for life, and it is not vascular. In otosclerosis process where it starts, it leads to these changes of spongiosis and sclerosis all the time. Bone resorption, bone lamination. That is what going on, and that you can pick up by bone densitometry wherever it is going on.
Yes.
So
coming to
another
the surgery.
question is,
Sorry.
Yeah.
एक साइज बढ़ा दे.
Yeah.
Excise
From
बढ़ा.
Dr. Ramkesh from Savai Madhapur. If HRCT is not available, can we check this malleolar ligament fixation?
हटा उसको.
Clinically, of course, at the time of surgery, that is the best way to check it any which ways, because even
Yeah.
It is per operative.
Boss,
even
Ashim,
there's no
Ashim.
other way of doing it pre-operatively.
Ashim,
Yes.
can you tell in detail about this annular ligament? How do you check?
Okay, fine. So what happens is that when Satish will take the incision, Satish will not take that standard 12 to 6 o'clock incision, but he'll go anterior to about 2 o'clock.
2 o'clock, yeah.
This concept of checking the anterior malleolar ligament has been brought into vogue by Professor Hugo Fish because of the work done by Fish, Alex Huber, and Carl Bernd Huttenbrink in Dresden at that time. So what happens is that he will then expose the anterior malleolar ligament at the primary part for the incision
उसको
itself.
बोला. वीरू
Because
को.
that is part of the checklist of exposure.
वीरू को बोला लाइट आ रही है.
Now, when
कहाँ
you
चल
want
जाता
to
है ये?
check the anterior malleolar ligament, the way to do it is after disarticulation of the
लाइट बहुत जा रही है अंदर. हाँ.
because you want to take away the movement, the rigidity of the stapes when you are assessing the malleus.
वाइट बैलेंस करें क्या?
So after you disarticulate,
Can you please repeat this?
yeah. So after you elevated and observed it, the anterior malleolar ligament by elevating up to 2 o'clock in this case, for example, what you need to do is after disarticulation of the incudostapedial joint, then and only then can you truly assess the movement of the malleus. And assessment of the malleus is to be done at the neck, not at the handle. Most people press on the handle of the malleus, but what we recommend is touching the neck of the malleus in order to judge how flexible that part is. Now, when you, by touching the neck of the malleus, you see adequate excursion of the long process of the incus, then you know that it is not fixed. Now, what we do is sometimes you have hyalinization also, not real fixation, not real ossification, and we do intraoperative audiometry in each and every case. And at the end of the procedure, if I find that the intraoperative audiometry is not up to mark, I will go ahead and cut the anterior mallear ligament any which ways. And later on, if I have the opportunity, I will show you a couple of slides in which I have seen a 5 to 10 decibel improvement on table itself.
After
So it is
cutting that
something
ligament.
that it is underreported, underestimated, and most of us who have a 5 to 10 or 15 decibel residual airborne gap at the end of the procedure, by far, I'm sure it's due to the anterior mallear ligament.
Boss.
Yes, boss.
But this incidence is relatively high, particularly in autosclerosis situation or in general?
No, it is relatively high in the otosclerotic situation, and the reason given by Hüttenbrink is the disuse atrophy, disuse hyalinization of the joint. It's just like having a stiff joint in arthritis.
Yeah. Yes. Are you getting the picture?
Yes.
Microscopic?
Yeah.
Yes. Absolutely.
Glare is there. Some glare is there.
Glare. Now?
Yeah, it's okay.
Okay?
Yep.
Yeah.
Let me know if the picture deteriorates. We'll do something.
No problem.
ये ना ये सफेद वाला ला छोड़ा. I will change to a different बड़ा ला. This thing speculum later.
Yeah.
Okay. So
what about using endoscope in Stapes surgery?
Yes, endoscope use, and nowadays a lot of people are publishing about the endoscope, quoting the advantage that you get a on-site magnification, good, I would say the picture better than a microscope, good maneuverability, reaching access to the difficult areas. What the advantage they say? You don't need to drill the overhang so much, you can protect coda better, you can go to anterior crus, all these are advantages. But the issue is the depth perception. What you see with the endoscope and camera is not the binocular vision. That is not the depth perception. You cannot think of that, what you get with the microscope. So in certain situation, definitely it has an advantage if you use the endoscope in certain areas. But it's not that, I don't believe the endoscope can replace the microscopic surgery with.
He said about the heat generated that can fry the coda also. That is
Yes.
And we had actually, Sanjay, we had requested Moaz Tarabichi to make a presentation. It was more about access to the anterior crus.
Yeah.
He said yes, of course, because he's the master of endoscopic ear surgery that we know.
Yeah.
So we had told him to actually make a presentation on what advantage we can get specifically for the anterior crus. Unfortunately, he could not join us today, so we were also looking at that. But
okay, so contact him anytime. He can make the point if he. Ashish?
It is a tool like every other, and it should be used judiciously. And I don't think it is a substitute for microscopic manipulation.
But it's very combined anytime.
Absolutely.
But I want an honest opinion. I want an honest opinion from anybody who had been doing microscopic stapedectomy earlier and had totally switched over to endoscopic for certain advantages. I really want to see someone. It's not that someone who is good at endoscopic ear surgery is doing endoscopic Stapes surgery for the reason he is good at endoscopy. That is different. Any significant advantage of the endoscope to the level that the entire microscopic surgery is replaced by endoscope, I want to know. So far I don't know to the level any significant advantage. What do you say?
I don't know basically.
What is your opinion?
Yes, Dr. Ashim and Dr. Bhumkar.
Like I said, it's a good tool. I do not know of anybody who shifted over from the microscope to the endoscope, but it's a good tool.
Boss, how is the picture now?
Excellent.
It is good.
Okay,
just
to orient you.
Is required. Slight focusing is required.
Focusing?
It's focusing on the incision, not the drum.
Yeah.
Okay, I think let's elevate it and we'll do inside.
Yeah.
Now, to orient you, this is posterior, this is anterior, this is superior, and this is inferior and operating on the right ear. Okay?
Yeah.
Now, the first thing is the exposure. My majority of the time in this surgery will be spent on exposure. And my exposure most of the time is transmeatal, which I am going to show here as well. And the exposure, what Ashim does, what ABR sir would do, I have seen them couple of times, is a mini endoral, very small endoral, with the advantage that they can reach anywhere 360 degree in the middle ear, as well as if they want to go to the mastoid. That is amazing approach. So that is exposure part. If you are good at the mini endoral, you can go about it. But it is the way you are trained, where you are used to, you can go about it. But certainly both techniques are good. Mini endoral definitely has a more, versatile approach to give exposure in case needed, extended, you can easily get. So my first part is the incision.
Ashim wants to make a comment.
Yes.
No. I just wanted to say that I use, if I can get in a 6 millimeter or larger speculum, I don't go mini endoral. If I narrower than 6 millimeter, I will definitely.
But still you don't do transmeatal. You always do mini endoral.
No. I always do transcanal.
Now, really?
Just like this, yeah.
Just
really?
Same, exactly the same. Yeah.
For Stapes.
For Stapes.
Okay.
And mastoid.
Okay. So now my incision, I want to comment something about it.
Yeah.
My incision, this incision should be adequate in the length from the tympanomeatal angle, in the sense that your flap should be adequate in the length. Adequate means it should not be too short. This is my level of the annulus.
Yes.
This is roughly 6 millimeter lateral to the annulus. You know?
Yes. So
and
inferiorly you go closer to the annulus.
Not really. Inferior is not my area of interest actually.
Yes, so you go closer to the annulus. Don't elevate too much there.
See, my area of interest is posterior superior.
Yeah.
So what I will do?
Overhang removal, the flap should not fall short. That is what he's trying to
say.
Yeah.
It should be adequate in the length. Because if the flap falls short, you have to curate sometime more posterior superiorly, and if your flap falls short, you may have to use some graft addition or something to prevent the perforation.
That is something which how much overhang you're going to remove also has a implication.
Yeah, implementation. Yes. So like you mentioned, inferiorly. Yeah. Inferiorly is not my area of interest. So I will limit my inferior incision by means of putting this vertical incision.
Centering is required, Dr. Satish.
The other, Satish, I want to add, sometimes you have these little narrow tortuous canals.
Yeah.
So the flap should be such that it should not occupy too much of the canal.
Yes.
One, of course,
yes.
the priority is to the
it should not be too cumbersome
and too bulky. So
yes.
then you take the incision more medially so that it does not.
Yeah. Yes, you are right. Canal. See, no, what Ashish is trying to say, to get adequate length, it doesn't mean that I make it too laterally to make it too bulky to handle.
Correct.
It should not be too laterally as well. So now what I am doing, I am raising my flap inferiorly, first inferiorly, so that this area.
I strongly recommend that the round window gets exposed, because sometimes, especially in obliterated order, you have spontaneous resorption of the arch, hypermobility. It's always a good idea in any conductive loss.
Yeah.
For your
visibility of the round Ashish, window. Earlier people would always expose the round window and do additionally with curettes in this region, because they never knew what is going there in the round window, if there is autosclerotic foci or not. But now with the CT scan we know the round window is clear. Yeah. You don't need to really go in all cases there.
No, in case of a hypermobile, sometimes if the crura is resorbed, then you need to see the round window. So it's a good idea to plan. Some people make the incision too small.
Yes.
And I think as a rule, the round window, if you need to look at it,
it should be available.
Yes. Now see, my inferior part of the incision little elevated, the flap is elevated. Yeah. And now superiorly I will make it a little curvilinear, tilt to the incision to go more and more anteriorly.
It starts to get little thicker. Inferiorly the skin is much thinner, in fact the thinnest.
The way I limited my incision inferiorly, I am not going to limit superiorly.
Yeah.
Because superiorly, like we discussed, if we have a, the malleolar ligament, suppose fixed and you have to resect it, I should have that much exposure to go there. Correct. So what I am going to do the superiorly, see this flap is little thicker.
Yeah.
Yes.
By multiple goes, not in one go to tear the flap. I am making it curvilinear, see this?
Yeah.
To go more and more anteriorly in case needed. in case needed.
Yeah.
I am not elevating far anteriorly right now.
Yeah.
In case needed, in case I find the slightest doubt in the malleolar ligament, I can immediately extend it anteriorly. Okay?
Yeah. The other thing I do more practical is I take the incision with a Karl Stoll's knife and the elevation. Then I don't want to spoil the edge of my knife. I take an Indian circular knife and start elevating, scraping the. That way, the cutting part remains really good for many years.
Yes.
Nowadays, I have started using an angled tungsten carbide, the Colorado tip, to actually take
Oh,
most of the
really?
incision.
Really?
Yeah.
Inside?
Inside, yeah.
Oh, great. I would love to see
I
that.
used to do that sometimes.
Yeah.
Yeah.
So you get a 45 angle fine blade,
But
fine needle tip.
I would love to see that using inside. I've never seen you doing that
Yeah.
before. See now, I am
Dr. Satish,
reaching to
what
the
about
level of the
infiltration
annulus.
part?
Pardon?
Hello? What about infiltration part?
The infiltration we have given in the 4 quadrants, 0.25 ml each, and the incisura anteriorly 0.25 ml additionally. That's it. Nowhere else.
The infiltration, the only important point is in revision surgery. You have to make sure that your xylocaine adrenaline does not go enter the middle ear. Especially if you are doing
Focus kar.
revision surgery where there's been giddiness or there's a mixed component.
Yes.
That's about the only thing about an infiltration in an autosclerosis.
Yeah. See now I am reaching the annulus.
Yes.
Yeah. Nicely we can see.
You're doing under local, no?
Yes, always. And that is added advantage. I have seen people doing under GA as well.
GA.
But if you are doing under GA, you lose a very important feedback from the patient sometime.
Yeah.
You know, under local,
So my
if you are
standard answer to that is I don't even know whether the patient is under local or GA. That my anesthetist decides. But I don't want the patient to move.
Okay, just one caveat for those of you who are interested in anesthesia is that we try to avoid propofol as far as possible, because propofol causes relaxation of the hypopharyngeal musculature, and what happens is that we tend to snore a lot and heave a lot. So propofol is avoided. What we like to do is give dexmedetomidine, which is much better than propofol, and the patient is very easily arousable, and I get good bradycardia along with it, which is more important than really reducing the blood pressure.
oh, that's an important point. No
Wonderful
propofol.
point,
Yeah.
See now, I have reached the annulus.
I don't know with the CO2 whether they get that sting, or sometimes when you drill, some people get the jerky. They just they wake up. So I
Ashish,
yeah.
see this?
Yes.
I
now
have
the
just
medulla.
entered the middle ear.
Yeah. We can
Just
see
underneath the annulus
Annulus.
to make an entry inside. And what I will do at this point of time, I will work first inferiorly and push my flap completely anteriorly.
Yes.
So it doesn't come my way.
Just one more point to avoid discomfort to the patient. In addition to the 1.1 or 1.5 ml 4 quadrant infiltration that Satish spoke about, I also like to infiltrate a little bit in the incisura and a little bit at the anterior junction of the tragus and the bony cartilaginous junctions, in order to make sure that the patient does not feel pain during manipulation of the speculum.
Speculum. Good point.
Now see, can you see the chorda coming in the picture?
Yes.
Beautiful.
That is chorda.
Yeah. Can you reduce the light a little bit?
Okay.
Yeah, it's glare is more.
Now, typically at this point, you have to train your eyes to start looking for the autosclerotic focus between the malleus and incus. This is again a play of colors. And if I get a glimpse of an autosclerotic focus, I'm into an easy sort of a situation. I am concerned, or I am in a heightened state of alertness when I don't see an autosclerotic focus.
Good point.
This is where my chances of a floater are increasing. If I have the standard anterior focus.
Boss, how is the picture now?
Yeah, it's nice. Just when the promontoral glare is what we are concerned.
No, how is the picture now? Better than before?
Picture is good. Picture
Very
is good.
nice. Yeah, you
You can just magnify it.
Okay.
I think we are already seeing a certain discoloration
Yes.
Anteriorly. We are
I
able
hope
to
the
see.
overall
Focusing
picture
is
is
required.
okay.
Yeah, very nice. Satish.
Focusing
Carry
is,
on.
yeah.
Beautiful point made by Ashish. You can already start seeing the difference in color
Sickle.
Yeah.
between the Malleus and the Incus.
See now what I am trying to do here right now.
Yeah. So now
This
from the
chorda is very
notch.
important. Unlike the CSOM condition, where the chorda is involved by the disease itself having neuritis, this virgin chorda tympani, not involved in any pathology, should be respected. Here in this,
Worshipped, not respected.
huh?
It should be worshipped, not respected. So embryologically, there is so
Yeah.
much premium on the chorda. It is the first branch embryologically to come out of the facial nerve. And I'm amazed at this nerve. It is actually flying through the air of the middle ear. What a marvel again. Can you
Yes.
imagine a nerve which is so important
Now
flying through
see,
the
now see
Just
the overhang.
center the
can see
picture.
you can see the autosclerotic
बड़ा वाला.
focus. I can
जी,
see
बड़ा
it
वाला जी.
right there.
Yes,
Huh?
very clearly.
See now, this overhang, I can see just the glimpse of the long process underneath the chorda.
Yeah.
Can you see?
Yeah.
Yeah.
Nothing much. There is huge overhang, you can say. See this chorda, the long process of the incus underneath.
Yes.
So I have to remove. Ashish, can you see the autosclerotic foci?
Very
Yes,
clear.
yes, we
Yeah,
can.
it's
If you don't mind the superior flap, if it can go a little bit more anterior inferiorly.
Yeah, I can see the foci there, right there in the depth. You can see.
Yeah.
Very clear?
Very clear. Yeah. Beautiful,
Now,
yeah.
in order to remove this, in order to remove this overhang, there are many ways. See, the direction of the curate is away from the chorda.
Always.
I have seen Ashim and Ashish using that micro gauge,
Gouge and hammer, yeah. That is.
and I have seen them removing the entire thing in one go. It looks so fascinating sometimes. So,
The one go is not important.
other is you can use a curate like this. The poor man answer is curate, or otherwise you can use the drill as well.
This is the rich man's answer. You're going to buy many curates. The gouge and hammer does a more efficient job. While the curate is preserved for the bone around the chorda.
Yes,
You're
yes.
really micro curating.
And this my curate, I am so fascinated about it from the
Yes,
Carl
you showed us
stores.
the
I
other
told
day.
you last time.
Carl
I've been
stores,
using it for so many years,
Yeah.
and it is still as sharp as ever. See this?
Yeah.
It cuts the bone like butter. See this? So I'm trying to uncover the caudal canal.
Here
See
his
this?
strokes are so small when he's close to the chorda versus when he's stroke. This is very important to notice. And that is how he's preserving the, making sure that he doesn't traumatize the chorda. So
See, the important thing
micro
is
movements at the elbow.
the chorda comes out through a bony canal here,
Yes.
and I'm uncovering this bony canal so to shift the chorda inferiorly. As I go
With
behind,
minimal stretch, yeah.
I will keep shifting it
This is
inferiorly.
important. What is doing inferior to the chorda, that canal, that bone also needs to be taken out to really hypermobilize the chorda and get it out of the field, surgical field.
Especially important.
Just center the picture. Yeah.
Sorry, Ashim, I didn't get you.
It's especially important when you are using a laser to get it really out of the field.
Yes, laser and also the drill, the shaft of the drill can.
Yeah. And also to prevent desiccation under the xenon light, it's always good to keep it after it's exposed properly, to keep it soaked with a saline or steroid soaked gel foam.
Yeah, I use a steroid. Yeah.
Now the question is how much of the exposure is required and why this exposure is required.
Yes.
Number one.
The most important step is this in Stapes surgery.
Yes.
Posterior superior overhang removal or exposure
If
to
this is not adequately done, the underlying work in the depth cannot be adequately done.
Correct.
Now see what I have exposed. The inferior most aspect of the incubomalleolar joint. Can you see that?
Yes. Yes.
This is my superior exposure.
Correct.
Just the inferior view of the incubomalleolar joint. Can you see that very clear?
Point it out. Yeah, you can see it clearly. With the pointer, I think you should.
Yes.
For the juniors, you can point it
Sickle.
out.
So the body of the incus has to be not exposed.
Yes,
So
that should not have.
Center is when you see the body of the
See, this is incus, this is malleus, and this
yeah.
is incus, and this is the joint. Can you see the joint movement?
Absolutely.
Yeah.
Let me show you under magnification this joint. See this joint now, proper joint.
So the sharpness of the image is not there, but
Yeah, focusing is required.
Just focus on the joint, Satish.
See this.
yeah, we can see it beautifully. Yeah.
See this?
Yes.
This is one of the most important joint contributing to the impedance. And at many steps in the Stapes surgery, if you are not careful, you can damage this joint. Number one, while disarticulating the incus from the stapes, you can damage this joint. While crimping the piston, you can damage this joint if you are too hard, you know.
Yes.
And that is a disaster if you damage this joint. Now see, tilting my patient's head towards me, I can see the glimpse of the foot plate coming into the picture. Can you see? Little bit.
We can't yet see.
Yeah, okay. Okay.
Satish, a gentle suggestion. Can you ask somebody to adjust the brightness on the camera? You're using a Stapes, I know that. So
Yes.
there's a brightness setting to low. Set
Low.
it to low and see.
Low कर दे. Now better?
Reduce your own light. Just reduce the aperture of the camera. That's it.
Okay, okay, okay.
Ashim is our official cinematographer, by the way. of the India. Sometimes we call him Ashim Dila Bansali also.
Wireman is more like it.
Now better?
No.
It's better. It's
much
better.
Much better.
Okay.
Yeah.
Let me focus now. हटा हटा.
Yes.
Yeah, I hope it is better now. अब focus कर दे.
No, focus.
Focus.
अरे इससे छोड़.
Wow. Perfect.
Better?
Perfect.
Yes.
Excellent.
Okay. So now this is my beginning of the curettage. I have gone superiorly up to the level that I have exposed the inferior most part of the incudomalleolar joint. That is my superior limit. Superiorly, like Ashish said, we are not supposed to expose the body of the incus.
Absolutely.
Just where the funneling starts from.
Yes,
long
where the
process,
broadening of the incus starts.
body. Yes, that's it. Yeah. And now the rest of it is all here. Actually.
Yeah. Sometimes you have a thick canal wall, you know, very thick canal wall sometime.
Oh yeah.
So you have to go layer by layer curating the bone rather than the entire bone in one chunk.
You can remove it with a drill also.
Yes, I can use the drill also.
Yeah.
Drill is a very useful alternative.
When you use the drill, you have to keep the flap parked with a gel foam or maybe a cotton ball, because inadvertently with the irrigation, it should not come into your drill.
Butler.
So you have to tuck the flap so that it does not float back into the canal.
Or even a thick piece of elastic.
Elastic, yeah. Those who don't want to use a cotton.
And speed of the drill should be as minimum.
Yes.
See, now we can see part of the foot plate.
Yeah, coming into the picture,
I'm
not
wondering
much.
whether it is going to turn out obliterative.
Yeah, it looks like
It looks
yeah.
thick and white. It looks
white.
I'm getting a feeling, yeah.
Yeah.
So far. And
You know,
these,
you're going to find it superiorly very thick and inferiorly slightly thinned out.
Wow, good.
and you know, this has, yeah, it's okay. This has a very important implication, you know. You know an Italian surgeon, Melafronte, if you have heard of. I am amazed by
Sophia Loren.
huh?
I only heard of Italian Sophia Loren. No.
So, Melafronte is an otolaryngologist there in a university hospital. And you know, he categorized the foot plate into 3 or 4 categories according to the case given to the residents or not.
Oh, really?
Really, and that is very practical.
It's a practical thing.
And you know what he did?
he categorized foot plate into category 1, absolute blue foot plate. Blue foot plate means the foot plate is of good quality, elastic, strong and completely welded all around to the annular ligament. You know, and that is good fixed foot plate. And in that, those are the cases he would give to his residents. So that the chances of foot plate complications are less, mobilization are less. Second category is a white foot plate, wherein the otosclerotic foci covering the foot plate variably, making the foot plate more brittle, more soft, brittle, easily damageable. And those are the cases he would never give to residents. Because those are the foot plates are not completely welded all around to the whole window. Third category is a biscuit foot plate, wherein the annular ligament is distinct.
Yeah.
Foot plate completely occupied by the otosclerotic foci, he would never give anybody. Because if you are not careful, it may easily, mobilize. So he categorized into these categories. Every blue foot plate he would give to residents. And the same thing, then he applied that principle of reverse stapedotomy as well, which Fish has invented earlier. Reverse means before doing anything, you make a fenestra, then put a piston.
Superstructure, yeah.
Yes. So what he did, he would advocate reverse stapedotomy only in blue foot plate. Because those white foot plates are brittle, even after a reverse, the foot plate can easily crack,
Yes.
and mobilize. So that is how his observation are, and very, very practical. See now the foot plate coming into the picture.
Yeah.
Yes.
Yes, yeah.
Just the fine focus is, I don't know whether it's me or.
Yes, now my focus on the
One
foot plate.
question.
Now my focus is on foot plate. Let me
Yeah,
focusing on the camera. Yes. Can you see the foot plate better?
Yeah.
Better but not fine.
It's not super fine focus.
Okay. Let it be.
We want to see the RBCs.
Oh, I don't know why this camera is not showing today. Better.
Yeah. That's
Yeah.
what.
Now we can see the
Now
blood.
we can see the foot plate.
Now, but I will focus now on the canal first. And I will remove more and more overhang here.
This is important, otherwise it comes in the way of your instrumentation. And Satish uses the titanium clip, so it has a slightly more posterior, the loop is more posterior.
Yes, yes.
So there you have to remove a little bit more than what you would for a Teflon piston.
No,
So
you
what-
can't ever overemphasize the value of exposure. I mean, I have a series of more than 900 revision cases, and the most important cause for revision is poor exposure.
See, on revision, you can get to know the quality of the surgeon by means of exposure only.
Yeah.
Absolutely.
So, no?
There is, when you're
What is-
young, you are, the foot plate attracts you much more. So you tend to rush the moment you see. So this is, I think with time you learn that the real significant steps are this is the most important step.
Yeah.
Exposure,
See,
because then
exposure.
everything else is that much easier.
And the same principle is everywhere, man.
Everywhere.
That day we did the angiofibroma,
Yeah,
90%
width
time we
before
invested in
depth.
exposure.
This is where I came out with the concept, width before depth. Don't look inside only. Just go wide. Don't try to.
If
See-
Coda is damaged here, Dr. Satish,
Not really.
if damaged.
Huh?
So there is a question from Dr. Prabhakar Jain.
Yeah, please.
If Coda is injured, can we repair this?
Not really.
Better to cut it sharp.
Cut it sharp. Allow the, the other adjacent nerves to take over the function. Cut it sharp. I've seen the publication where people have published that rather than manipulation, cutting the corda sharp is a better overall outcome.
No, but I still would feel intuitively and practically that keeping anatomic continuity is good,
Yes,
provided
none of that.
it is not totally just a
Totally.
very small strand. Ashish, any opinion from you?
No, I think a stretched corda is better than a cut because it still has a chance or a hope. If
Yeah.
we say neural integrity is the most important thing for the nerve healing, then I would like the integrity to be there. If it gives trouble, and I've never had a problem, I've had only a problem in two cases. With 3 or 4, 6 months down the line, they still had taste disorders. But most of them recover. And in those two patients, I did actually intratympanic steroid. For whatever reason, I thought, let me put in steroid. And one of them recovered and one
Ashish,
did not.
Ashish,
Yeah.
the reason people recommend cutting sharp is to allow the compensation to take place.
Yeah. But
You
will
know,
the nerve not heal if it is
not
injured?
really. I don't think. Once you have damage, a little bit of the continuity, probably it doesn't.
No, not continuity. If it is stretched, I don't know whether stretch is the same as.
Can you see the glimpse of section?
Yeah,
The
now we are seeing the head
tendon
of the
coming into the view.
stapes. Yeah.
Yeah, we can see.
There's a thick posterior crust,
Yes,
and I yet can't see the stapedius, but yeah.
I can see the beginning.
I know, but
But
it's
the
just
posterior
as
crust,
And
I'm
see,
noticing a very,
see
very
this
thick.
morphology of the incus bent.
Yes.
This is not a regular, normal
Yeah.
incus.
Yeah. It is more posteriorly oblique. And I think the posterior crust is very, very strong, and the crura footplate junction,
ऐसी
I
वाली
think
पतली
once
है.
you laser, that also is very strong here.
You see, Ashish, I told you that inferiorly is going to be thinner, superiorly.
Yes. The superior 2/3 is very, very thick, and there's a thin inferior 1/3 towards the
Yes,
promontory.
yes.
That is thin.
Yeah, I
And there's
can
a
make out this is not
progressive
morphologically normal.
Yeah. Also a very bulky head of the stapes.
See, this is a typical case where these perforators are not going to work.
No,
And
they should not be.
Saucerization is the order of the day.
Yeah. And now I
This is
would
the-
drill away, almost half of the posterior crust. I would drill away a little bit of the head of the stapes, create a lot of space, because those are overhangs for me. My
Yes.
target is the foot plate, and anything that comes in the way of the foot plate or the access to the foot plate is an overhang. Besides the posterior superior overhang, which is removing, this is an important step. See, what he did just now was the bone deeper to the corda that he's removing.
And see which curate I'm using.
It's
Yeah.
This is
double
a
angled
special.
curate.
Yes.
a
Can you
double
see the tendon now?
Yeah, we can see.
Better?
Yes, nicely seen. Yeah.
What I am looking at, whether my anterior-posterior, the area is adequate to maneuver my piston.
Correct.
Why we need such exposure? So that we can maneuver our piston better. We can see our foot plate better all around.
Wow.
And see, there are a lot of
Really?
abnormalities I can see.
Yeah.
Number one, this tendon is little shorter. Number one.
Very, very short. Yeah.
Number two, the posterior crust is so stout.
Huge elephantine. It's like
Yes,
large. Huge.
yes.
Yeah.
This
And
is
number-
a case worthy of you, Satish.
Oh.
The case worthy of you.
And see,
But
to go to the depth, my corda is the biggest obstacle. And
I would
third,
still remove
third
some
is
more.
I can see the partial white foot plate. I can see blue foot plate at
it's
some
a nice
places.
challenging. Yeah.
So that is a challenge in this case.
Yes,
Wonderful. Good.
it's a good case.
Yes,
Worthy of you.
worthy of
But I
you.
would still remove a little more overhang, buddy.
Yes, that's what bada bada.
Yeah.
I know.
Little bit more sure. Yeah.
Just maybe a millimeter or so. Yes.
There are times when the pyramidal process itself is also an overhang, and you should never hesitate to drill away the pyramidal process.
Yeah,
I think I've had a chance to do that in one or two demonstrations.
yeah.
Yes,
Ashish,
it's perfectly fine to go down to the
yeah.
in
I
the,
routinely
you
do
know,
that because I always indicate that my axis of drilling is in the axis of the foot plate, from
Yes.
Ashish,
posterior to anterior. Never anterior to posterior because of the reason of the impaction of the posterior crus.
Yes, and that drilling of the pyramidal process allows you, especially in tympanosclerotic cases,
Yes,
getting that pyramidal process out makes life so much easier.
absolutely.
Ashish,
Yeah.
then recently in the autopathology,
Uh,
what an interesting finding I observed,
mm,
the Shuknets, in the autosclerotic ears, he
yeah.
studied the microscopically the architecture of the stapedial
Microscope, the artery of the stapedial tendon.
tendon, and what
Uh-huh.
they, because there are a lot of debate whether to preserve it or not,
Mm,
and what they observed is in autosclerotic cases, whatever tendon you see, you know, because the same region unused like anteromalleolar
yeah.
ligament,
Yeah. Hyalinized.
yeah, the collagen fibers are less, elastic fibers are less, and it becomes more and more non-functional as compared to the normal situation. Number one.
Oh.
Number two, even if whatever the function it is,
Vascular.
it functions on the annular ligament to bring the foot plate back and out. You know.
Yeah. Yeah.
Yes,
Now in the autosclerosis, the annular ligament is already affected. That is the main thing
Mm,
which is affected.
correct.
So that it clearly mentioned whatever we talk about preservation, you have to think it functional preservation. How much it will remain functional.
Okay, now I have my little contribution to this in that those cases in which the stapedial tendon is long, those are the ones in which I would like to either preserve or reconstruct. The second point is that
long. The length, you mean?
the length. If it's very short like this one, there is no
Ah.
point in preserving it. Okay. If it's a very nice and long one, I'll show you a small clip later on if I have the chance, in which I've reconstructed it. And actually, after 1 year, you get the stapedius reflex back. More important, even than the protective function,
Vascularity.
it is a vascularity of the end of the incus. There are multiple ways of preserving the vascularity of the end of the incus, and even if you have a thinned out incus, maybe later on I can show a quick clip of that in which I use a superstructure of the stapes on the end of the incus, like a gola.
Create a lenticular process out of it.
Angle, whoa,
Just put the
joint knife.
superstructure on that, hold it in place
Hello?
with the cord,
Yeah.
and
I
that
understood.
sort of reconstructs the
Hello?
Yes,
Yes,
sir.
yes.
Satish, your audibility is little low.
Low?
Get the mic closer.
Can somebody? Hello? Now?
Yes, boss.
Now much better. Yeah.
Now I want to show at this point of time when we have seen the
See, now my assessment, I'll say how much of the crura is superior to the stapedius tendon.
yeah,
That
that is
much I will drill away to get a good access to the
exposure of the foot plate.
Yeah. This is a
Now
very,
see,
very strong.
let's check the mobility first.
Yeah.
Yeah.
So what I will do,
Here I like to bring in the incurostapedial joint
hmm,
into my focus when I am doing the mobility.
mobility,
Because
yes,
the
yes,
incus also slides. You can make an assessment of the mobility on the sliding movement.
yes,
The capsule of the incurostapedial joint is a wonderful structure by itself. It's much
Little
thinner
though.
towards the head of the stapes.
Yes.
And as it goes over the lenticle, it
Yeah,
starts
let
getting-
me focus you where you exactly are saying.
Yeah,
The capsule of the incudostapedial joint, number one. One by one I will focus everywhere.
yeah.
See this, if I
So you
mobilize
can
this,
move.
can you see?
Yeah, there. We see
Yeah.
the gap.
Here is the joint, here.
Yes.
Exactly.
So
See
it's very
this?
important to sort of memorize that spot where you will eventually puncture the capsule.
Otherwise you will end up injuring the lenticular process.
Exactly.
Correct.
Yes.
Correct.
Number one. Number two, see my needle. Underneath the malleus, can you see?
Center,
Beautiful.
please. Center, please.
Internet, please.
No, so no, the focus is on the incurostapedial. He's moving the malleus but looking for the movement there.
Yeah, yeah.
Now see all the way.
Yeah, better.
I am lifting the malleus,
See, he's at the neck. That's the right place to be, at the neck.
Yes.
And you're watching.
Okay.
The
Yeah.
the incudoseptal joint is also very very special joint, and the capsule is very very
But
special.
I could see even I mobilize the stapes, the foot plate is completely fixed.
Rock hard it is. Yeah.
Absolutely. So my next step here, now, once it comes to the surgical step, I know my this tendon is still a biggest obstacle, but still I will be able to do it keeping that in place, because my tool which I am going to use now further would be the laser. Now there are two steps in stapes surgery which I call the most vital steps, where laser has an immense value. Your mechanical instrumentation, however good you are, a human being, exerting movement at a nanometer level cannot be accurate, you know. So it may be good by and large. Exceptions are there, but still there are two points or two maneuvers, two steps in this surgery which are vital. Number one, while removing the crura, particularly the posterior crus which is quite stout, while removing the crus, you may mobilize the stapes, and that can be a disaster. Number one. Number two is fenestration. Again, during fenestration, if you mobilize the stapes with your, if you are doing with a mechanical instrument, there is always a chance of mobilization unless it is completely fixed. Number one, and your movement is absolutely accurate. Most of the time it goes perfect because the foot plate is adequately fixed. In situation when the foot plate is not completely fixed and a movement, a slightest of the aberrant movement can lead to mobilization, and whatever accidental mobilization happens to occur will leave some sort of inner ear trauma. Happy you are if it doesn't leave a too big a sensorineural hearing loss, otherwise it will leave some sort of inner ear trauma. Okay? Hello?
Yes, Satish. Yes. So
So-
I'm here with you. We are watching very carefully.
Yeah. So those two steps are careful, and to prevent that problem from happening, the tool I am using for last almost 13 years or more is this particular laser. You know, I was looking for this for many years before that, something that I can remove, I can execute these two steps without mobilizing the foot plate. Crurotomy and fenestration. I tried so many things, so many lasers, tool, drills, but nothing was perfect, and this was the tool. You will see how accurate it is, how precise it is, and it gives you a sense of security always that you are not going to mobilize at all. And that is what this luminous laser is.
It brings precision and predictability to
Yes,
the movement. That's what
absolute
it does.
precision.
Because it is a non-mechanical.
Yes. So will not, this is absolutely atraumatic, non-mechanical. Once it comes to laser, we tried so many lasers, you know. I tried diode also, you tried KTP also. You
I
mean,
have the KTP, yeah.
Yes.
With the fiber. Because at
yeah,
that time when I bought,
and you
there was
see,
CO2.
we extensively review the literature. You know, this laser story started with a Perkins with argon laser in 78.
Yeah, I met Rodney.
Then Jovanovski and all, they propagated this CO2 after this luminous came in as a one shot, and this is amazing. We reviewed almost 100 publications on various aspects of the laser. There are many lasers, you know. KTP, argon are visible lasers, the wavelength around 50, 500 or so, but they are used by pigmented tissues. They are not absorbed by water. So like if I am using KTP, it can pass, the energy, laser energy may pass through the perilymph and damage the membranous labyrinth if it is little bit than required. In contrast to that, the CO2 laser, which is considered to be the best one, it absorbs whatever laser energy goes, it will be absorbed by the foot plate, then by the perilymph inside the foot plate, and that laser energy which is absorbed by the perilymph prevents the energy being transmitted to the membranous labyrinth. That's how the perilymph acts as a shock absorber, you know.
Yeah.
And many of the cases, you know, many of the publications we have reviewed about the perilymph heat which laser contributes to when you use the CO2, and it has been very clear up to 6 or 7 centigrade rise in the temperature in the perilymph doesn't leave any permanent damage to the membranous labyrinth. And if it
6 to
is,
7 degrees.
yes,
Yeah.
and that too, if it is the exposure is for a lesser time, that is important in laser, the exposure.
Duration of time.
Yeah, I will show the exposure time should be minimal to give
Therefore, the
minimal
pulse
damage.
mode- Okay.
That's why the super pulse mode.
Yeah.
There is a greater
Ashish.
off time than on time.
Yeah.
Since then, I have done over 4,000 cases.
Hmm.
Believe me, this has changed the life.
Yeah.
I was otherwise always scared of mobilizing floating foot plate, submerged foot plate out, everything, anytime. But now with this, there is no question. This is what the sense of security is, and that too without giving any additional sensorineural hearing loss.
Yeah.
So now my first step would be, I would disarticulate this joint. Okay?
Yes.
I can use many things. I can use my joint knife. I can use my angle pick. Anything, you can use anything you are good at.
I very strongly recommend a very graded puncturing of the joint. Of course, from here, Satish and I, we change. I do the sort of the reverse fish with, yeah. So now, okay.
Can you center the picture, please?
See, what I am using is a joint knife.
Yeah.
Those little bigger with the angle.
So I like
I have
to
already
use-
punctured the joint
Yeah.
with a joint knife. See this knife?
Yeah, yeah. It is important to realize that the superior surface of the head of the stapes
Can you see?
can also have its own
Center
temperamental.
the picture, please.
Yeah.
Can you see?
Yeah,
could
now we
see,
can
we
see.
could see the blade of the knife going.
Yeah, this articulated. Okay. My next step is the tendon, and with the laser I can vaporize this tendon. Here I am. What thing which is worrying me is this chorda. See now?
Just focus it. Yeah.
Yes.
Yeah.
Would you like to put a small piece of gel foam? on the
Yes.
border?
Yeah, छोटा gel foam there. See, my laser fire can take the chorda. That I am concerned because chorda is little bit bothering, you know. पहले मेरे को focus करने दे, then you focus.
This is really a very, very wide posterior crus.
अब तू focus कर. नहीं नहीं
This, if you
tendon.
try to just crack it with your pointer in the routine suprastructure removal,
Yes.
for sure you're going to land up with
ला
a
छोटा
foot
gel
plate
foam there.
It will end up in your hand.
problem. So,
See now I am focusing on the tendon.
Yes.
That is a gel foam to cover the chorda. You know, to cover with the wet gel foam at the same time to retract a little bit as well if possible. Because this chorda is really for me bothersome here.
Satish, can you read out the parameters for vaporizing the stapedials?
Yes.
Using 5 watts, the single pulse.
Yeah, single pulse. See, for tendon you can use from 3 to 6 whatever. It works very well. It doesn't need much. Hey, कहाँ है मेरी beam?
Dr. Satish,
Yes.
can we have few questions?
Yes,
Yeah,
yes. Please. नहीं दिख रही यार.
There is a question from Dr. Saurabh Pachauri from Indore. At this step, if we can get a persistent stapedial artery, how to overcome? And if you are having a video, there is another question. If you are having a video or a picture of that, you can show us later on.
Okay, we will. कहाँ है
See,
यार?
generally the stapedial artery is passing through the obturator foramen. So the thickness of the posterior crust in such cases is enough that by just drilling out the posterior crust from posterior to anterior, what in this
Light
case,
बढ़ाना
you
यार.
drill out the pyramid completely. Once you drill out the pyramid completely
Light
from
बढ़ाओ उसकी
before
लाल.
from posterior to anterior, you drill out the posterior crust and level it flat with the foot plate. You will find enough place to make a 0.5 millimeter hole. Leave the stapedial artery as it is. Disarticulate the superstructure and
For
go
section
ahead
there.
into staped artery.
Boss, can you see my laser beam?
Yes,
Yeah,
sir,
yeah, we can
absolutely,
see.
very clear.
I can remove this tendon by means of scissors as well. This is not a very important step, you know.
Yeah.
But I want to prime with the laser here. See
You're
this?
just having fun. Yeah.
वो किधर है मेरा?
So the persistent stapedial artery is always in the anterior half. That's what we were trying to say, because it exits anteriorly, just posterior to the pyramidal process, to the cochleariform process.
See Ashish,
Always enough. Yeah, beautiful. We are watching. Yeah.
that is gone.
Yeah.
Once
gone.
the stapedius is gone, we'll see the entire width of the posterior crus.
Yeah, and see how broad the posterior crus is,
Huge elephant's foot.
Yeah.
and abnormal as well.
Very good. Yeah.
See, there are some publications which relate. एक साइड छोटा दे. Relate the dimension or the morphology of the posterior crus to the inner ear abnormalities.
Oh, really?
Really, there was a paper I heard wherein the morphology of the posterior crus they related to the incidence of gusher, and that was a good number of cases. It's not a one case.
Thing, the crust, both the crura are typically thinner in the center. They're thicker superiorly and much more thicker as they join.
Now, can you see the crus better?
Yeah, very nicely.
And you know, this facial nerve is far off from our field. There could be micro dehiscences. So what I do at this point of time, I cover the facial with this wet gel foam. See this?
This is so your beam does not accidentally
No,
hit.
beam is not going to go. That I will align properly.
No, but that
Even the heat, the laser energy, because there could be sometime micro dehiscences. Okay? At same time, I will cover a part of the foot plate also, so my beam doesn't pass through beyond. Now look at this angle of the stapes, you know.
Yeah. So let's say the short stapedius is already telling us a lot of things.
Yes.
All the action is more posteriorly. You know, the
Yes.
length of the stapedius is telling us a few things here. The anterior crura is going to be much longer than the posterior crura. The posterior crura is going to be more vertical than the arch that it generally is. And therefore, your piston fenestra is also all going to be much more posteriorly.
See now, I have covered the foot plate with a gel foam,
Yes.
keeping my posterior crest in view.
Yeah.
Now why I am using laser? Because if I break it, I have a fear that I may mobilize the foot plate.
Yes.
So now I will vaporize it completely.
Here you will need to use a slightly larger,
Yeah.
higher wattage.
Yeah,
Yes.
this is
Now at this point, this angle of the, I will make a point, stapes. There was a publication from our own Dr. V. Anand from Polachi in JLO about the angle of stapes, this medially directed angle of incus.
towards the promontory or
This angle of incus which is medially directed towards the promontory. Can you see this?
yeah.
And that is a classically something seen in the stapes because the foot plate is fixed. It is pulling the stapes is fixed and pulling the incus medially. And what he observed and correlated with the finding that once you remove the suprastructures, when you do a stapedotomy, put a piston, this incus is released from this medial pull. Hello?
And it goes back.
Yeah, it goes back, and so whatever piston you put may fall short.
Pulled superiorly.
May fall short. It may fall short.
No, the point here he is trying to make is once the superstructure is removed, only then the measurement should be taken.
No,
So
I am.
the point I will
Yeah. That is right. But it goes back in position slowly. So what he says, you have to take additional 0.1 or 2 millimeter minimum to prevent your piston coming out of the vestibule, to prevent the piston falling short. In cases when you find the incus medially rotated a little bit, which you can see here, and he termed this as a Pisa sign, Leaning Tower of Pisa, you will all know.
But that is exactly why we say that you should do the hanging and bending test, because when you do the measurement and where the piston ultimately hangs from is going to be slightly different.
That's right. But the memory of the incus goes back. It doesn't go immediately. It goes with time. Whatever you measure, that is immediate one.
No, agreed. But that is why we say कि go to, should
एक
go
size
to
बढ़ाना इसका
0.2 and
0.4 कर
0.3
दे.
inside.
Now
So
see
it
my
is
laser.
Yeah.
See my laser, and now I am going to vaporize the. See what I am doing? I am keeping my section to keep the tendon away, the cord away.
Corda.
At the same time, keep the fumes sucking.
But in other middle ear disease also we find the stapes more promontorily inclined. I don't buy the thing that the autosclerosis is causing a pull on the incus. I think it's just an anatomy.
Maybe.
So I don't believe there is a recoil. If I
And
may
not
use.
only that, I've never had, and in thousands of cases, I've never had a situation where there was a shortfall.
See how thick this thing is.
Very, very thick.
Very thick.
Lage raho.
Now, if you don't have a laser, the same thing you can do with a micro drill as well.
Yes.
And if you don't do completely through and through, at least you weaken it. At least when you weaken it, the force you use to, break the foot, this thing, crust,
The
will
mechanical
not
force
mobilize the
will be
foot
there.
plate. The force required will be less, and the chances of mobilizing will be less. Okay, yeah. Got my point?
Yes.
Yes, sir.
So, Dr. Satish, if somebody is not having laser,
Yeah.
what to do at this
I
point?
told you, I have already told micro drill.
Micro drill.
Micro drill and thin out this posterior crust. Weaken this posterior crust. See this. I weaken to some extent. Can you see?
Yeah.
Yeah.
Much
Yeah.
more is needed. Much
Yeah.
more.
Yeah. वो देना right angle. Now see.
So, in next case, can you show this micro drill?
Right angle दे यार. जो मर्जी देता है.
He is now too addicted to the laser. That's a pity now that I and Ashim are not there.
Now I will show with a micro drill as well.
Really?
Yes, but I always have an insecurity. I told you.
So, there is a question from Dr. Samir Bhargav.
Yes, champion.
How does Roteville classification change your surgical protocol in advanced autosclerosis?
Yes, Roteville classification is very, very important in taking a call for cochlear implantation in far advanced autosclerosis.
Yeah.
See now what I am seeing, that how much it has weakened. See this, I can easily break this now. Could you see?
So
Yes.
it's almost at the
Nice.
middle third that. So there's a stump of the posterior crust that is
Yeah.
still lying there.
And the anterior being fragile is already broken. And you can assume most of the time the anterior is fragile. The thick anterior crust, what Ashish was mentioning, is a very rare situation, but it is a very difficult situation to handle if it is. See this now, the suprastructure broken?
Yeah.
And the next thing is I have to bring out See, when we break the suprastructures, particularly the anterior one, little bit of the bleeding comes from there, base of the suprastructure. Base of the anterior crust always bleeds. Base of the anterior crust always bleeds because there is a plexus,
That's where that real fistula antifenestrum is there anteriorly.
Yes.
That's where the real action is.
Yeah.
Now see the morphology of the foot plate.
Yeah.
Variable whitening of the foot plate because of autosclerosis. Variable whitening. Can you see?
Yeah.
Such a difficult foot plate,
Very, very difficult. Very thick. And there's one thin area, yeah. Very
and this incus is also difficult.
difficult, yeah. It is.
This is medially rotated, rounded shaft. This is not the regular incus,
It's pretty stout, not excessively, but not a slender one.
Yes. Now my next step is fenestration. So coming to the Samir's question, Roteville classification. So we take three things into consideration in taking a call of selecting approach in far advanced autosclerosis.
speech discrimination score, the CT scan rotoville's classification, and the third one is the level of hearing loss. So those who have on rotoville, according to the rotoville classification, grade 2C or 3 kind of involvement of the cochlea, diffuse cochlear otosclerosis, whatever is the situation, I would prefer to take a call of cochlear implantation. Otherwise, we may lose the opportunity of implantation in future. We may not find the lumen in future. Otherwise, in rest of the situation, whatever it is, I will do a stepidotomy. In spite of a profound loss, my first surgery will be stepidotomy and then give a patient hearing aid, because it gives, not only gives good hearing, it gives acoustic hearing, which is more dynamic than a cochlear implant. Number one. And number two, there is no harm in doing it. Stapes is a small procedure. Even if it doesn't work in long run, you can always do a cochlear implant later. It doesn't affect the outcome of the cochlear implant. But yes, if according to the rotoville, if there is grade 2C or 3 kind of otosclerosis already involve the cochlea, diffuse involvement, you cannot take a chance of buying the time by means of stapes or anything. Otherwise, you lose the opportunity for future.
Again,
Now,
you do speech discrimination, and if it's less than 60, only then you can implant.
now the
I pay a lot of
question,
attention to speech
yes,
discrimination.
yes, keep the speech discrimination, yes. If it is poor, then the question rises on the stapes surgery. Sometimes if the speech discrimination is poor than 30, then better is to implant.
Then 50, I would say.
Yeah, then there is no point
less
in
than
doing
50.
it. Now, boss,
Yeah, point.
see the situation now, drill. See the situation, I have a very small blue footplate area, rest is all white. Can you see?
That inferior thin, yeah. In fact, 1/4 only, not even 2/3.
Yeah.
Just a 1/4 of
And-
the
and
inferior is
the-
the blue.
yes.
You can already see a little bit of.
But
yeah.
only thing which is favorable here is, this area is the inferior part of the central part of the footplate, where I am likely to make the fenestra.
Correct.
Reason is, this part is farthest from the inner ear membranous labyrinth. You know, if you go to the Hugo fish study, the saccule is anteriorly 0.76 millimeter below the footplate, and utricle is posterior superiorly 1.18 millimeter above. It is the central inferior part of the footplate which is farthest from these structures, and that should be the ideal site for fenestration. Ashish, can you see little bit of the promontory bulge as well?
Yes, yes,
Yes, yes, we can see.
Sometimes if it is too much, you may have to drill the promontory.
Yeah.
And then you have to be careful about the cochlear endosteum. So when it comes to drilling the promontory, my favorite site is this posterior. The reason is, here posteriorly the thickness of the bone is more than a millimeter, which you can drill. Otherwise, anteriorly the bone thickness before the endosteum is 0.2, 0.3 mm, and you can easily damage the endosteum.
Is there in the literature, is there a millimeter dimension definition of
Sorry,
a
बहुत मोटा है,
narrow
पतली,
niche?
0.6. Pardon?
A
Pardon?
narrow and a deep niche we call. In
Yeah.
the literature, does it have dimensions? Or when do you call a niche narrow and when do you call the oval?
Yes,
niche?
yes. If the vertical height of the niche from the from the facial canal to the promontory, if it is less than 1.1 mm, it is narrow.
1.1 mm.
Yes, it is narrow then.
Okay.
That is the definition. Can you see my micro drill?
Yes, we can
Yeah,
see
yeah,
it.
we can see.
See now, although he has a laser, he is not using it.
Oh my God. I may mobilize.
You are a laser man now.
Yeah, I may mobilize. You know? See, this is why Melafonte would not give such cases to the, you know,
Sophia Loren.
Sophia Loren. Because these are never adequately welded to the,
So the annular ligament is not
yes, yes,
fixed.
patla de section. So I will use my laser only.
Hmm.
Now the fear is how to get rid of this thick bone. That is a challenge, you know.
Yeah.
See, I am bringing my beam in focus. Can you see?
Yes. Yes.
Yes,
Yes.
yes, yes.
Suction.
You're waiting. Shoot. Oops.
So
Oh,
in a blue
beautiful.
foot plate, it's like a magic. In one
Yeah.
shot, you get a calibrated hole of whatever size you desire, you know. But here, let's see. Ready? Oh, come here.
Hill riot. Guy. Microscope is moving or what?
Ah, yes, yes, yes.
Yes, now. No, I was looking at the laser parameters that time. Okay.
27 watts.
Can you see the fenestra?
Excellent.
Yeah.
Hata de. See the fenestra.
Excellent.
Beautiful.
Yeah, yeah.
And the beauty is, see inside it is full of fluid.
Yes.
I tell you, the biggest reason for the post-operative sensorineural loss, vertigo, whatever, is when you suck the labyrinth when it becomes dry.
Absolutely.
Second thing with this laser, the beauty was one shot. See that? Completely full of perilymph. Can you see?
Yeah. Yeah. Yeah.
Absolutely.
You are not supposed to use a second fire.
Absolutely.
With
Never
this
fire
open
from
labyrinth,
that.
if I make it dry, it's a disaster.
Yeah.
Single most common cause of post-operative problem is aspiration of perilymph. Now, if you don't aspirate, the pressure inside the inner ear, the vestibule, is more than the pressure in the middle ear. Always it is the perilymph pressure is more, which is going to come out. You know,
Yeah.
even if there is a bleeding, even if I pour blood here, if I pour literally, it is not going to go in vestibule. Because the pressure gradient is opposite. Got my point?
Correct. Yeah.
So
Then
lot
you
of
feel
people
some
talk about
sensation. Yeah.
lot of people talk about blood going into the vestibule.
Yeah.
It's a
Yeah.
disaster. I tell you, it's a disaster.
Is the suction taking it out? That's a disaster.
Yes. So blood, if it goes inside, is a disaster, definitely. But it is 100% preventable. What does the blood do? Because the blood has ferrous component in the heme, that makes ferrous oxide, and it is a free radical. Blood, the erythrocyte disintegrates and the potassium is released, and which is deadly to the perilymph. Perilymph is
Yeah.
not rich in potassium, and both are
Call it
toxic.
an ionic riot.
Yes.
What happens is an ionic riot. Yeah.
Yes. Chota de, patla de.
This is the Gurudev. This is the Gurudev at work. Lovely.
See, I can little bit enlarge
It's
it
widening. Yeah. Fantastic, Satish.
Fantastic. Brilliant.
because of the surrounding bone, the widening was not perfect, you know. And I don't want to use the laser again. See that?
Oh,
Yeah.
beautiful.
Many people were asking to do you perforator. Now you have done that thing also.
Now my last
Use
part
the
is the
drill,
piston.
The laser, the perforator, all three over.
All the
That was the angle pick only. Now my
it's
last
only
part is the.
Huh.
Oi, blood nikal. My last part is piston. Now see, whatever the surrounding blood, see this. This is not going to go in the vestibule. See, it cannot go. And I am sucking in the surrounding, not right on the.
On the, yes.
That is the most important reason
Yeah.
for problems, you know.
Although we don't see it, again, embryologically speaking, just like you have a round
No.
window membrane, there is also an oval window membrane which never gets discussed.
Now my last and I call it as, for me, the most fascinating part is the piston. And the piston, again, I was looking for something which can avoid problems, you know, for long. Forget about Ashim, I know he is deadly using two hands to crimp the piston. Deadly.
Boss.
See, the piston is again a very important thing. The reason is, I want whatever sound going to the incus to be transmitted to the inner ear without losing the sound, number one, for the ideal piston. Second thing what I want is a biocompatibility. See this little bit of the more perilymph coming out. Can you see?
Yeah.
Yeah.
It is more than usual, like, oozer, not gusher.
Perilymph weeper, it weeps.
Yes, weeper, you can say. The reason is, I could imagine looking at the morphology of the posterior crus and the.
Oh, you are thinking there is a possibility of this happening?
Yeah. I told you,
Yeah.
morphology of the posterior crus and the incus, they are not normal.
Whose observation is that?
Yeah, there are many papers.
Many. Okay.
That's why I mentioned.
Rahul, hi.
Now see, I am leaving it for a minute here behind, not on the fenestra at all. Now I will measure my piston, and the piston I am going to use, I will tell you the advantage. Ashish,
Yeah.
this evolution of the piston is again is so important to understand. The piston which was initially used, when this modern stapedectomy started, the Johnson 56 removed the entire stapes along with the footplate and suprastructure, and he used the replica of the Teflon. You remember?
Yeah, it was a Teflon replica of the
Complete replica of the suprastructure and footplate. No. Yes. And then after, who revolutionized was the Jain market. Hello?
Yes.
Yes.
Yes,
Jain
of Antwerp.
Jain market revolutionized by using the piston for the first time. It was the Jain market, rather than a total stapedectomy, rather than a platinectomy, he used the piston. And now what I am trying to check is, this I am going to use a titanium piston. The desired length of the piston, there is the same company, I am using this so that this bar, hello?
Yes, we can hear you.
This bar coincides the opening at the footplate to the incus. Can you see? That is the desired size of my piston, and now I will see what is the desired size on this. See this. There are a lot of, see what is there. Can you see the lot of markings?
Yes.
Yeah.
Yes.
See what I am trying to. Whatever piston you are using, you must use the same company measuring gauge. This is not always millimeter, this is a parameter. See, this much of the piston was out, length was out to measure from the footplate to the incus, Could you see inside? This was.
Yeah.
And this coincides to what length? See this, so clear. See this. 1 mm, 2 mm, 3 mm, 4 mm, 4.25 and 4.5. Can you see here exactly?
Yes.
So I will use a 4.5 size piston. It doesn't mean 4.5 millimeter. This includes 0.25 mm piston underneath the footplate. So this is 4.5 size. If I keep it on the footplate, keeping it parallel to the incus, and this much size piston I use, that automatically goes 0.25 millimeter inside.
Dips inside, yeah.
Yeah, it is not the millimeter I am measuring.
Yeah.
Now my last part, I am going to tell you this my favorite piston for years now. And favorite for the reason, it is so easy to use. I will tell you, it is like a video game. I have seen people playing with the Teflon piston for half an hour, 45 minutes many a time. End up giving sensorineural hearing loss.
Never.
And
But it's okay.
not for you, man. But second thing is the adequate crimping onto the incus. See, this word I am using, adequate, believe me, by means of human efforts, our goal is whatever sound coming to the long process of the incus should be transmitted to the vestibule without wasting the sound energy. And when you crimp with a Teflon, there are so many things associated unless you are very good at it. I am not talking about you, I am not talking about Ashim. Ashim, I have seen he crimples with both hands. I fail to understand how one can use both hands through the speculum.
He cannot do with one hand. He needs both hands. Just joking.
I'm not as good with you as you are with one hand.
No, using both hands is so difficult. It is not possible to use two hands through the speculum inside using two instruments together. It's not.
That is when the incus and malleus are crowded. When
Yeah.
you don't have your
No,
possibility to
Ashish,
do
the question is why the crimping is required.
Yeah.
Because you need adequate connection.
contact. Yeah.
If it is loose,
Do not lose any.
if it is loose, is a disaster. I tell you, loose piston is a disaster.
Decoupling.
It will keep hitting the incus and it will ultimately erode the incus. Then secondly, a tight
You
fitting,
will see.
tight fitting piston, that to a Teflon loop circumferentially again can be a problem. I told you one problem earlier.
You will always see.
Yeah, I know you do. I know we'll see your video as well. You do it so well, it is so difficult. I've used this. But the question is, I want to have something which everybody can use it without any issues to simplify it. Everybody cannot be Ashim Desai.
You will always see in the revision that the under surface of the incus is eroded. That is what I'm trying to say.
Yes. So, I was looking for some piston, and I tell you the piston, the answer of my problem, which I've been using now for several years. In last probably 10 years, I rarely use the Teflon.
Clip piston. Let me reveal the mystery.
I rarely use a piston in last 10 years. Believe me. See this, Teflon.
Yeah.
I have not used Teflon. This is my piston. Can you see this?
Yes. Yes.
This is so sleek. So sleek, the weight of the piston is equivalent to the weight of the Stapes superstructure. It is extremely biocompatible. You know, out of all pistons, there are a lot of studies done with the external surface of the piston. The Teflon is very good in terms of the roughest of the piston, which is required for the connections all around with the membranes. The gold is the smoothest of all, which is the worst. And this platina, this titanium, is best of all because the surface is scaly. So after the insertion, when the fibrous membrane surrounds, it sticks so well to the titanium. It is extremely biocompatible, better than Teflon, I tell you. And secondly, it is so sleek. It is so, I would say stiff. The gold is bendable. You can bend the gold anyway. You cannot bend the Teflon so easily, this titanium. And that is what a tough assembly we want, So that is the beauty of this piston. I have used Teflon earlier but the problem is the crimping. If I try to do over crimping to get good assembly, I may dislocate the malleoinguinal joint. Number two, a tight crimping 360, there are a lot of studies, then I don't know how correct they are. The vessels onto the incus coming to the medulla of the incus are antero-inferior through some foramens. It may compromise that. It may strangulate that. I have no evidence, but still it is mentioned and we cannot ignore this fact. I know you would not agree to it.
No, because the main vascularity is from the body, it's from within the incus.
So those vessels, Ashish, at the point 1.5 millimeter from the tip of the incus are very superficial,
Yes.
because they ultimately have communication with the vessels coming from below. I will tell you. Let me put the piston. I will tell you something about the vascularity of this region.
Yeah.
Now, the last part is the piston insertion, and believe me, it is like a video game.
So what make you use?
Length is what length is?
Make company.
What make the
This
company?
is Kurj. We went to the company. See now, first of all, let me see how to apply easily. Can you see this? Can you see the lower end of the piston?
Yeah.
And I am leaving this mouth of the piston open. Can you see to the incus?
Yeah.
Yeah.
And now this is the bar behind this to push, and this middle slot takes the long process of the incus. Can you see this?
Yes, yes.
Yes.
See, this is, now see, there is no play between the incus and the piston. Can you see?
Agreed.
Absolute tight connection, but like a clip, it is holding less than 30% of the circumference of the incus. It cannot
Yeah.
strangulate any blood supply for that matter if it exists, that concept. Secondly, there is no play between the incus and the piston at all. This is extremely biocompatible. And fourth is the ease. The ease with which you can put this piston, like I told you, it's a video game. It doesn't take more than few seconds. And
At least
fifth,
if at this point of time the patient says I'm feeling giddy,
yes, you have to remove it.
it's for you to take it out and
Yes,
put a short over.
yes, I will again measure and put a one size shorter.
No, so
And that is the advantage of doing under local anesthesia.
to unclip it, to remove it is not,
Easy, easy. See this bar.
Don't remove. Just
Okay, not removing, just telling you. See this bar. See this bar.
Okay.
Just push it, it will come out.
Just push
So
it,
the,
okay.
see, it is a spring action.
Ah.
The mouth of the piston which I initially placed along the long process, it is not as big as the size of the incus, little shorter.
Yeah.
The moment I push this bar, that clip opens and the middle slot tightly takes the piston, the incus.
I am convinced about the merit of the clip, the way it very snugly it
Boss, it doesn't need crimping at all.
problem is I would like to be in control of the length. The Teflon, the only thing is I can go on making it thinner and thinner. That is the only, otherwise we are very happy to move on to this.
See,
I need that hanging
Ashish,
test and bending test of
Ashish,
mine.
Ashish, two things in the step is, I am so happy convincing Ashim Desai. Well, I consider them the best, no doubt about it. The experience is unmatchable. One thing about the use of laser, and Ashim is well convinced and he bought the laser.
Yeah.
And this is something traumatic without mobilizing everything. You see, I made the fenestra, I removed the suprastructure without mobilizing anything and put the piston. One shot and let's put the piston in few seconds. That's it. That is the beauty of titanium piston.
No, boss,
And the second
I'm
thing,
convinced about this. I'm totally convinced. My
second
only
thing, I have been able to convince him with the titanium piston as well. I don't know he's using that much or not, but he has used.
I'm using the clip piston
Love.
for the Melius to Stapes assembly.
Pardon?
The hinge clip piston for the Melius to to foot plate.
Now, boss. Hello.
Yeah, yeah.
Hello.
Before
Yeah.
closer, see what I'm doing.
Yes.
I'm placing a drop of blood. Drop of blood. Can you see?
Yes.
Yes, yes.
I am literally, see this, my drop of blood on the oval window. Can you see this? This is my going to be the seal. Hello?
There is
Yes,
a
yes.
background. Someone is talking in the background. We cannot hear you.
Can you mute Dinesh all? Dinesh, can you mute all?
Dr. Rajeev?
Hello?
Yes, yes, we can hear
Yeah,
you.
can you see the drop of blood I poured?
Yes.
That is my seal. And now we'll discuss various issues of piston, fenestra, vein graft and other things. Now we'll close it. जब बंद कर दे बहुत देर होगी. We'll close it. My associate will replace the flap with the, and put the gel form. हटा दो, इधर ले आओ. Now, the most important thing is certain issues which have a great impact on the outcome once you are using this piston, using this technique. Number one, इधर लाना इसको, इधर लाओ, पानी देना. Number one, एक मिनट, is this one. Hello?
Yeah, yeah.
Yes, yes.
Number one for the audience, the size of the piston. The single most important determinant affecting the entire outcome, I believe, affecting the entire outcome is the length of the piston.
Absolutely.
If your piston is overlong, this will not allow the endosteal membrane to form inside. It may damage the membranous labyrinth in extreme pressure change conditions, and it is going to be proving to be the ultimate disaster. So single most important thing is the size of the piston length. And
Yes.
I would like to know from both of you about how you measure the Teflon accurately. And Ashim, can you show the video of that hanging and bending test?
Yes, I will do that. That's a very important point. I completely, and Ashish also completely are in agreement with you that length is the
But
most.
both of you measure the length differently. I have seen him differently, you differently. Can you tell us?
Can we take few questions, Dr. Satish?
Yeah, after this point you can take, boss.
Okay.
Ashish, you go first.
Yeah.
Yeah, so I kind of take the Teflon piston and keep it where it is supposed to be. The only important thing is I will always glue line the foot plate before I make the measurement, and then I actually take the piston, place it there, and then if this is the incus, I like the loop of the piston to match the middle part of the long process of incus, if this is visible.
Okay.
And then this is what I seek to achieve, and then
Yes.
it just goes in a little bit like this and goes.
Okay.
This
Let
is
me let me tell everyone what he's trying to say. He keeps the piston on the foot plate.
Before I have made the fenestra. So
Yeah,
I
before
the foot plate,
yes.
not made the fenestra yet.
And
Now I
then
make the measurement.
he keeps the angle of the loop at the middle of the thickness of the long process of the incus. Correct?
Incus, yes.
Correct? Like this.
Correct. Yes,
Like this.
Correct.
So that what happens, once he pushes the loop below the incus, only this much of the length of the piston will go in.
Go into the vestibule.
You know the beauty is he is ensuring now 100% that the piston is not going to be overlong, because that is a disaster. This is one of the ways, because the thickness of the incus is variable between 0.6 millimeter to 0.9 millimeter, and that too at a place, the ideal place is 1.5 millimeter from the tip of the lenticular process. So that if he keeps like 0.45 millimeter in the middle, that much going to go below. That will cover, that will take the thickness of the foot plate as well as the depth in the vestibule. So that way his piston is never going to be more than 3.3 millimeter deep in the vestibule. That is most important. Even if
Satish, this step also allows me very early on, before I have made the fenestra and opened the vestibule, I call it the piston rehearsal step.
yes,
It allows me what difficulty I am going to get placing the piston during crimping, is my overhang removal adequate or not adequate, the perpendicularity of the piston, how it is. It tells me a lot before I am committed to the fenestra, because
Yes.
I like to keep the open vestibule the shortest possible duration of time. I don't like it to be open and then play around outside.
yeah,
So
that's
this
great.
step gives me the length, plus it is a rehearsal for the other steps that are going to follow.
Super. Ashim.
Okay, so now the way I look at it is after using the standard measuring device, and remember that the cutting jig and the measuring gauge has to be absolutely coordinated from the same manufacturer. That's very important. I also do what is known as a hanging test and bending test. You see, sometimes what happens is when you are taking the measurement, the piston is sometimes extremely inclined, as Satish was discussing earlier. So if
The
you measure
incus.
from here,
The
foot
incus.
plate, from the incus to the foot plate, it would be a little shorter than where the incus would, the stapes would hang from. Or if you take it from too proximally, the length, it would be too long when actually the prosthesis will hang. So once you measure it, you do a practical measurement of whether it is in place or not. So with your permission, Satish, I'd like to share my screen.
Yeah, please.
Okay.
We would like to see.
So I do the bending test.
Okay, you got the screen?
So,
You started.
Is there a screen?
Yeah.
yes.
Now, what I do is a slight lateral traction should allow me to get the prosthesis lodged on the edge of the foot plate.
So
Then I
that
put it
to
back and then
so
I
that
push
you
it against the edge of the foot plate.
so that you ensure that
So
it is
this
not
is-
overlong.
So that ensures that it is not overlong. And when I push it against the edge like that, that ensures that it is not too short. So just a slight lateral traction, and
Yes.
then that is a hanging test, and then the push on the edge, that's a bending test.
So
So
that
this
is
is a
amazing.
practical way of measuring.
So
See,
one important
yeah,
point, Satish, and for all audience, he has done this test before his vein graft is in place.
Exactly.
For those who use direct piston, this is not the hanging test will not work.
yes, that
No,
is
no,
that is
it
that is
works.
Yes,
amazing.
it works. I'm sorry, it works for the direct piston also.
Yeah,
Completely for
yeah,
the
yeah,
How
Ashish.
do you then justify the extra thickness of the vein?
Yeah,
If
see,
you
Ashish,
left
um,
let me put it. See, the value of vein is different here. Value of vein is it will prevent using an overlong piston.
no, it adds to the length of the
Yeah. So see,
but it is only zero point 0.1
yeah,
millimeter.
let me put
point one.
forward to the audience in the simplest way what he has shown. What he is trying to say with the hanging and bending test, that the piston should be adequate in length. It should neither be overlong not short. So he is doing an hanging test, means it is hanging the piston little bit out and it is coming to the edge of the foot plate. That means it is not overlong. And
Yes.
the moment he is trying the side movement, the piston is hitting to the edge of the foot plate. That means it is not too short. The idea what I am saying is, it is not the fixed length of the piston people are using which is important.
You have to customize,
You have to customize, and it is not the length that this much millimeter. It is for the required situation. You have to customize. So he's
The
putting the
anatomy
piston
dictates it,
properly, adequately giving it a length that it doesn't come out, and at the same time ensuring that it is not so deep. It is hanging to the edge when it is pulling out.
So
So that is amazing.
the take-home message from us today is that the length should be measured in each and every case, and it should be precisely measured in
Yes.
each and every case. One should
I
not
have
follow certain authorities who say
I
that we
have
will
I
use
have
only
seen
one particular
people,
length.
Ashim, I am sorry to say, seen people having dogmatic approach. I use 4.25 piston in every case. How
Yeah.
can it be appropriate in every case? We have seen in a practice, I have used many a time piston length more than 4.75,
Yes.
sometimes 4.25. So it is depending upon the anatomy of that particular individual, you have to customize it. Otherwise, you cannot give a proper outcome. So
Just
now,
I'd like to share one case
in my
emphasizing
style,
this.
I ask, so Ashim, sorry.
Yeah, please.
In my style, I ask which organ of the human being is the same size in every human being. I mean, I'm referring to the fingers. And not all, nobody has the same size of any organ. Why should the distance of the between the foot plate and incus be constant in every human being?
absolutely, absolutely.
Can I
Now,
use one case presentation to just emphasize it, just 3 minutes?
yes,
Okay, I'm just sharing again.
yes, yes, please.
Okay. So can you see this?
Yes,
Okay, so now you will see on the left hand side, on the right hand side, there is a good closure of the airborne gap. Left hand side, this is a piston. Now the right hand, I mean, this is a mixed hearing loss out here on the left hand side. Now this was done, the right hand side was done in our clinic by my father in 1984, and beautifully the hearing is still maintained after all this year is 2010. The left hand side, the patient, we had advised surgery, we had advised the left T-plasty, Teflon piston, and they went to another center and got themselves operated, followed by immediate total subtotal sensory neural hearing loss and vertigo. So this was immediate onset SNHL with vertigo, and when you go back to our old operation notes, we will see that we have used a 0.6 millimeter piston of length only 3.0 millimeters.
oh my God.
Now, the other side, the person had a dogmatic approach of using 4.5
Ah,
millimeters.
the
in each
fixed
and
size
every
piston, fixed size piston is a
The
disaster.
piston was too long, perineum fistula and medial. So this is just to emphasize again and again that don't have a dogmatic approach to the length of the piston. It has to be customized to each and every case. Thank you.
Yes, Ashish,
Yeah.
Ashish, can you see my slide?
No, not yet.
No, wait.
Boss, मेरी slide लगाना है? Yeah, now,
Yeah, we can see.
now I would like to have your quick opinion separately on certain issues. We have already discussed make and material.
Yeah.
About the Teflon and all this. I will make a point here, the gold piston.
Gold piston is never in consideration these days, you know.
Gold is gone.
Yeah, but I tell you one indication that is very practical,
Gold is old.
and you will love it. No, for audience, gold is a heavy piston, you know, heaviest of all. Like the Teflon weight is 4 milligram, gold is 10 milligram weight.
Right.
Secondly, it has a, you know, it is known for giving granulomas and all those bad things it can give to the whole window. The best thing what I have seen with the gold, an indication for it is in a difficult anatomy of the oval window. Like sometimes you have a short incus. Sometimes you have a, you know, a fenestra going far anteriorly or doing a malleostepidotomy or something. To give an inclination, to give an alignment, the gold is malleable. If you have a short piston, I will align it right angle, then again right angle and put it to the fenestra, and it works very well. That is the beauty, that is the only
But
piston
that
which
you
can
can
work.
do with titanium also. That
Titanium
you
cannot be done. Titanium is too stiff. It will break.
No. The shaft can be done, Satish.
No, it is not as malleable as gold. That is the only thing I find an advantage. And there are situations when you come
I have
across.
seen granuloma at the lower end of a gold.
I know, this is worst of piston otherwise.
So no. I don't think we should give the message. Gold is not.
No, I am not saying message. That's the only positive point in the gold I have seen. Otherwise, it is worst of all pistons.
Yeah.
Then,
No, for
Ashim,
the short incus, you can use a bucket handle prosthesis.
Ashim, you have changed from the past some time from the Teflon to the this titanium. Ashish is, I think, using all the way Teflon.
Only Teflon. Only.
Never use anything. So,
I mean, only for malleostepidotomy I use a titanium.
so we'll take Ashim's opinion about the difference in these two. What's the person who has used both?
See, for malleostepidotomy, I will use the hinged titanium prosthesis. And for a regular piston, because I use a vein interposition, I prefer to use a Teflon because I will do the hanging and bending test, take out the piston, then put the vein and put the piston right.
I beg to differ with you here.
So,
Boss.
No, listen to me. Let me finish.
Yeah.
And I have changed over. I often use a titanium piston for the obliterative focus now because that's a direct
It's a direct piston.
Yeah.
See,
So
I agree with you.
obliterative focus vein is contraindicated.
See, when you are using vein, practically you don't need to do hanging and bending test, I tell you. Practically, for an experienced person like you. The reason is, your concern is not to use an overlong piston, correct? With a vein which is interposed, can you use an overlong piston? You tell me. The vein itself will invaginate like anything. It will warn you, you are using an overlong piston.
Agreed, no doubt. But call it my psychosis. You see, surgery is habits, passion, preferences, and prejudice.
Yes, that I agree.
I would like to measure in each and every case for the only reason that if it was my year, I would want it measured in each.
Okay, I will put it other way around. Anything, any disadvantage or anything you find negativity or anything about the titanium piston, or where a Teflon is better than titanium?
No, titanium.
No.
Besides the cost.
No. It is about customization of the length.
Huh?
No. You cannot customize the length to between
Boss,
the point.
Ashish, there are two ways.
There are the titanium cutters from Castro.
Yes.
Yeah.
It is available. Number two, these pistons which I am using, they are available from 3 mm to 6 mm at 0.25 mm graduations. So once you are using them, like I have the stock of all varieties, whatever is required, will open up that. Yes. So that is not a big issue. Any major thing which you find against titanium?
What diameter?
0.4.
0.4.
0.4. Okay.
Yeah. So my next question is,
the biggest advantage here of the titanium clip, which I have to confess, is in the piston, the loop, the incus has varying anatomy and varying dimensions, but the loop comes in a very standard size.
yes, but I told you that this has a spring.
So correct, the clip takes care of that anatomical variation
Yes.
of the dimension of this. That's the biggest advantage. because the Teflon people have to make loops of different diameters actually. So yeah, so
Yeah.
there I give you the
But
thing that
believe me, I have seen all these pistons, and there is not a single disadvantage of this piston against any other piston. I've seen it thoroughly.
my only concern was the length, but yeah,
What the length? Length is
but
no
the
issue.
length,
I
right?
mentioned. I
Yeah,
mentioned length is not an issue. Secondly, the kind of clipping it gives,
yes, no,
it
that I'm
holds the
convinced.
incus so tightly.
Yeah,
In my own case series, I never had to revise this, this piston. For the matter, the piston has slipped from the incus.
slip.
Never.
Yeah,
It cannot. And second is the bonding. You know, when you apply this piston, over the period of time, the fibrosis and the membrane forms around this bonding of the incus and the piston. This piston having scaly in nature from the surface, that membrane and bonding that forms, it is best and more stable and durable than it forms anywhere around. Though the same thing is advantage with the Teflon also. Teflon is a rough piston, and because of that the bonding is also very good. The problem is the crimping. The major difference is the crimping between the Teflon and this titanium. Now coming to the second point, the size of the piston. Like you said, I use 0.4. Some people use 0.6. There are a lot of studies done, and the idea is very mathematics is very clear. The larger the piston you use, more the perilymph will be displaced, and the better would be the hearing. But
so
it is
I
not
don't
all
know
that straightforward.
I don't know the last part of your statement. More fluid, yes, but better the hearing, I think, is a questionable statement.
Yes.
I've got many theory, I've got a lot of papers saying that it is better. And the second part is our own practical experiments of doing
Yeah.
the 0.4, 0.6 and 0.8 fenestras have shown that it is better here.
So what is your take?
But if it was
I
better,
think-
then everybody would use the largest fitting diameter always. Why would you not then? Because then it would not. Because I use a 0.5 diameter in a 0.7 diameter fenestra.
See now,
the closure
if
is-
Ashish, if you
Yeah.
go to the evidence long term,
Hmm.
the difference between 0.4, 0.6, 0.8
Hmm.
and below 0.4, 0.3, I mean,
Hmm.
overall hearing results
Yeah.
are equivalent from 0.4 onwards.
Yeah.
Below 0.4 is worse result. There is no point in going beyond 0.6. Otherwise, you are making a bigger fenestra and you are inviting high frequency problems. So the best is
No,
0.4 and
0.8
6
fenestra, there is no high frequency problem.
piston.
When you
Yeah,
use-
0.8 fenestra because you are using vein.
Yeah,
You are covering the 0.8 fenestra with the vein.
correct.
So
But the point two is this the so-called annular ligament. So
Yes.
your actual vibration is only 0.4.
yes, 0.4 and I think he is using 0.6. What size you are using? Ashim,
Sorry?
what
Yeah.
size piston you are using? 0.4.
0.4 piston, but the whole moving surface is wider, no?
Okay, that is cost
So the
technique.
piston, the whole entire 0.8 millimeter moves.
That is cost technique, you mean to say.
Yeah, the cost technique.
The
That's
cost-
why I
Dr.
prefer
Satish, can we
technique
have
for
questions now?
Yes, yes, sir, we can have questions, please.
Because there are so many thousands of questions.
Sir,
Dr. Girish from Birlai, he's having so many questions regarding this gusher and what is the minimum and maximum diameter of the fenestra, which we were talking about. And
Yes.
is the diameter of fenestra to be changed depending on the measure of the conductive loss?
yeah, I tell you.
No, the measure
Yeah,
of the
yeah,
sensory
yeah, yeah.
component-
This was the belief earlier that larger the size piston you use, better the hearing in lower frequencies, and more the improvement in patients who are having bone conduction loss. This was the belief. But see, the disadvantage is when the moment you use larger piston, bigger fenestra, you start losing hearing at the higher frequencies. That's why this technique of stapedectomy has gone disrepute, and that's why the technique of stapedectomy has become a technique of choice because of preservation of higher frequencies and almost equivalent result in lower frequencies. What is your take, Ashim?
Yeah, agreed.
Yeah, same.
I completely agree. Staped partial or total stapedectomy is not the aim for procedure nowadays. What you want, the maximum diameter that you can do is a 0.8 millimeter fenestra stapedectomy. That means that you have your fenestra is surrounded on all sides by the foot plate. So that to me is what we call a small fenestra stapedectomy. Small fenestra does not necessarily mean 0.4. It means that the fenestra is surrounded on all sides by the foot plate. Once you cross that size, then you have got a partial platinectomy. And the risk of partial platinectomy is one, high frequency hearing loss, second, loss of discrimination. Although your pure tone profile will be much better, the discrimination will be lost.
So
Yeah, great.
the question is,
should not override the annular ligament. That's the key.
Yeah, you
Yes.
should not scrape off the annular ligament. I mean, remove the entire foot or
Yes.
even part of it.
Sir, next question.
this is for the panelists or all the three persons. Can you comment on stamp procedure? What is this?
That Satish is going to show some
Pardon?
Stamp procedure, stamp.
Stamp. Okay, let me show. Let me tell you. That is a wonderful procedure which was devised by Silverstein. And you know, the idea behind the stamp. First of all, what is stamp? Step is stapedectomy minus prosthesis. That is a stamp, and that is done by laser. So the entire terminology of the procedure is laser stamp. Laser stapedectomy minus prosthesis. So what is the idea and what is the advantage? Can I make a diagram? Give me a paper and pen. So what did Silverstein did? What did he do? In patients, knowing that the earlier lesion starts from the fistula anterofenestrum and rest of the foot plate annular ligament is not fixed in the earlier stage, you know. It is only the foot plate is fixed at the fistula anterofenestrum, and that is how the Shuknet has proven in the orthopathology. So what he did, in certain situation when the situation is favorable means when there is no overcrowding of the structures in the oval window and he can see the anterior crus easily. So what he did, keeping the anterior incudostapedial joint intact, keeping the tendon intact, keeping the posterior arch of the posterior crus intact, he divided the anterior crus and divided the foot plate just behind the anterior crus from the rest of the foot plate. Got my point?
So only posterior part is left.
Only the anterior part of the foot plate along with the anterior crus removed by dividing with the laser. Let me draw a diagram. Can you come here? See this very simple way. You can understand. I have done when I bought the laser. I have done a few of laser stamp earlier. I will tell you why I am not doing and what exactly it is. Can you see this diagram?
Yeah.
Okay. This is posterior crus. Suppose this is anterior crus. In laser stamp, what he would do? He would divide the anterior crus here, and then behind the anterior crus with the laser, with a small, wattage of the laser fire, he would slowly divide the foot plate here, linear division of the foot plate. So now what does it give you? It takes away the anterior crus and the fistula anterofenestrum along with the anterior foot plate which is fixed. The moment you remove it and keeping the incudostapedial joint intact, tendon intact, posterior crus intact, rest of the foot plate intact, keeping the natural, transmission intact.
So that
only
becomes mobile now.
Yeah, now it is completely mobile. Yeah. Now it is completely mobile, and this cover with this fascia and a glue, and this part of the foot plate becomes mobile. So it gives natural, transmission of the sound like the original foot plate give rather than a piston. No need of piston. It preserves the higher frequencies best than any other procedure, even better than stapedectomy, and this gives you the hearing more natural, closest to the nature. But this can be possible only in those percentage of the patients when you expose, you have a very good exposure of the anterior crust, you have a blue foot plate completely, and you have a laser to divide just behind it. And in those patients, it can work.
And the focus is absolutely limited to the
Anterior, because according to the Shuknet, in those situations, the posterior part of the foot plate is not fixed because of the focus. It is because of this focus the rest of the foot plate is pushed posteriorly to the posterior stapediovestibular joint. And secondly, according to the Silverstein in his series, because this has gone to disrepute because of the refixation, in his series and other series as well, as up to 9% of the patient resulted ultimately in refixation, for which he had to revise and do a stepidotomy. So now his version is 90% of the patient has retained almost natural hearing, up to 9% he revised, had no contraindication to revision. They can be revised to the same stepidotomy like a primary stepidotomy with no disadvantage, and ultimately his majority of the patient could get good hearing. The only thing is a 9% revision rate which took this procedure to disrepute. Otherwise it is amazing.
9% of those highly selected ones.
Yes.
If you take 100 cases,
Yes.
this category of presentation would be less than 10% of
Yeah,
those.
less than 5%.
That, yeah.
Yeah, because this favorable anatomy, you will never find in more than
the today's case that Satish has just done, the first
impossible.
one, impossible.
Impossible.
This is not
Stamps is
possible.
a contraindication for this.
So only in a favorable anatomy, the blue foot plate.
It's okay. I mean, it is. It was.
So
a good
this was the proposition of Silverstein, which is named laser stamp. Next question, sir.
Yes. So,
Ashim, sorry.
What about,
Ashim, have you ever done Stapes mobilization? Have you seen Dad doing it? Stapes mobilization?
No.
I have done in 2 patients, and those were children, only children. It is indicated only in children. I tell you the indication. In children with congenital hearing loss. Because in children, you don't want to disturb the natural foot plate. You don't want to open the vestibule because they have a possibility of acquiring middle ear infections often.
Yeah.
So you don't want to make fenestra and all. So what you do in that situation, with your pick only, the bone is not very hard. You can make a trough all around the foot plate area and make it mobile. And make it mobile. And it works. And it heals by fibrous union, not by bony union.
Yeah, correct.
So it works. So mobilization is indicated only in children, that too in congenital hearing loss. And if the refixation rate is even higher than stamp, refixation is almost 20%. And those children, it happens after years together, and then you can carry out the regular
You
procedure.
can do a conventional.
Yes.
Ashim, there was, I know Dad once said the foot plate shattering, there used to be some gouge to shatter the foot plate. Is there something that I
Yes,
remember?
there used to be a little microcurate. It's a micro curate. A 0.5 liter curate. They used to shatter the foot plate.
Shatter
Just
means?
to decimate it and leave it in position. The cut the anterior crust with a crura nipper. So the anterior crust is cut and then the foot plate is shattered.
So this was the Stapes
But all of this
mobilization.
refixation was order.
Is historical.
Refixation was order of the day.
Yeah.
Sanjay
So
sir,
let me-
question.
so how to
Let me
another
yes.
question.
Sanjay, let me introduce our Dr. Kamini Shetty Chavan. She has done some work. She's been interviewing the other legends, the real legends, KKR and PGB. Since I'm referring, Kamini, welcome. So she's been doing some study on.
Hello, welcome.
We were trying to do this event in Taj, and she was actually going to present the history of Stapes surgery in India. And she was to. So Kamini, please join in whenever.
Thank you so much, sir. Thank you, Asim sir, Ashish sir, and Satish sir for organizing such a great webinar and giving us opportunity to absorb more and more knowledge in such pandemic situation. Till now, it has been great. You are sorting out all the doubts, starting from the students, postgraduates, and consultants. So it's been my pleasure doing this. Thank you.
Thank you. Okay, Sanjay, go ahead.
Yeah, this is a question from Dr. Deepak Dalmia.
Yes.
This is for Dr. Ashim, specifically for him. How to decide about posterior crus on perichondrium? Indication and how to perform it.
Yes. Hof technique. He is asking about the Hof technique.
Yes.
Ashim.
Ashim is asking you.
Ashim is frozen.
Okay, yeah, I think okay. When he comes, until he comes, let me tell you what is Hof technique.
Another question is, so we will ask him directly. Another
Okay.
question is how to decide about the diameter of the piston. Is there any difference in hearing outcome with different diameter piston? This I think
We have already discussed. This we have already discussed. To summarize, piston diameter is important. It should be adequate to displace adequate perilymph for a good hearing. And it has been proven that piston diameter 0.4 mm and above are equally good. Lesser than 0.4 mm are at disadvantage. And by and large 0.4 and 0.6 are the most popular piston with equally good results.
Having said that, the diameter of the fenestra and the diameter of the piston, they should also match. You should not have a 0.8 diameter fenestra and a 0.4 diameter piston. You don't want. Satish, correct me on this.
Yes, yes. So
another question is from Dr. Suresh.
Yeah.
From Ahmedabad. Can we reposition damaged chorda? And if yes, what are the chances of refunctioning?
Unlikely, unlikely. See, there are a lot of studies done on the chorda. It doesn't recover for that matter. No studies have shown recovery. But in majority of these patients, they like any patient whose chorda is injured, he will definitely complain of dysgeusia. Most of the patient will complain. They will never complain after CSOM surgery, but here they will complain. But if you see the long term, majority of the patient after 6 to 9 months stop complaining because of recovery of the chorda through the various interconnections in the infratemporal fossa with the trigeminal branches. Then in the tongue also, where the chorda supplies, where the supply goes, the opposite side recovers. Majority of the patients stop complaining. But yes, in the immediate sense, it is a real problem.
So where we can place this chorda if it is damaged from?
Where we can?
Stick it either to the undersurface of the drum, or you can park it just inferior to the piston that you have put on the lenticular process.
Okay.
If that's what, I don't know if that's the question, if it is cut.
Yeah, that's the question. That's the question. Yeah. So another question is how to manage gushers or peripheral fistula if it is there.
Yes, that is important. So first of all, gusher you can prevent most of the time by radiology. We have already discussed. Once it happens to occur, you don't have to be panic. It is just the CSF, direct connection with the CSF, which is coming out. So let it drain. You can, make the head end of the patient little lower and allow it to drain a little bit. In few minutes, keeping calm, the pressure of the perilymph or the gusher reduces. The important thing is here, we have to seal the defect properly, and we have to put the piston for sure to keep the seal in place. It's not that now we have a gusher and we are now not doing not putting a piston. You have to make the surrounding little bit raw. You put your fibrous seal, whatever vein along with the fat or anything, and then reinforce with the piston, which is attached to the incus. So to keep the fibrous seal in place, the piston is very, very important, and most of the time it works.
So what is in your opinion, what is the best material to use here
for
gushers?
For gusher, simple, any fascia along with the fat, no issues.
Okay.
Vein perichondrium is little too thick, but
perichondrium we don't use nowadays on the foot plate, and lot of papers have shown the chondrogenic potential of perichondrium. It may result into cartilage formation later on.
Okay. So this is a question from Dr. Krishna Kishore from Vishakhapatnam. Any chances of incubomalleolar joint dislocation while keeping the piston, titanium piston loop around the incus?
Yes, I have already mentioned this. That is the only thing I am scared of.
Yeah.
Crimping. When you are trying to crimp adequate, you try to do over, and over crimping can easily dislocate the incudomedial joint, and that is a disaster.
That is where actually, but the reverse stepidotomy comes in.
Yes.
The technique we follow is we keep
Yeah.
the incudostepidial joint and the arch, although drilled and weakened, we keep it intact. And when you have that, that is actually holding the incus like an
Yes.
assistant. And then when you crimp, there is no chance of any even minor subluxation.
Yes, the
Can you
incudo.
please describe this reverse stepidotomy?
Okay, let me see. This was initially described by Hugo Fish, and this is amazing technique. Still, those who are not having laser can use this technique. If possible, we'll show this also sometime. This is amazing technique. Why this technique was introduced? I mentioned in the beginning there are certain fears in stepidotomy of mobilization. Number one, the mobilization of the foot plate at the time of crurotomy. Number two, the mobilization of the foot plate at the time of fenestration. And number three, like the last question mentioned, the incudostepidial joint dislocation. All three things can be prevented by this single technique without laser. So how come? What you need to do is, first step in this technique is, first step without removing anything, is to make a fenestra. So that the beauty is, when it can be done, when you have a favorable condition. It was not a favorable like this for the reverse one, the last case. When you have a blue foot plate, that is a prerequisite. You have a good blue foot plate and a good space to work around. You have adequate space to make the fenestra and put a piston. So make the fenestra, keeping the stapedial arch intact. Your making the fenestra will not mobilize the foot plate. Number one. The next step is putting the piston and tighten it. Keeping the stapedial arch intact and tightening the piston will not mobilize the incudomedial joint. And number three, having put the piston and tightened it, when you fracture the posterior crus, it is not going to mobilize or fracture the foot plate because everything otherwise is completely secure. So that is the beauty of reverse stepidotomy.
So this was the classic technique that Fish described, and he's right that we could not do it in all kinds of anatomical situations. Therefore, we modified it into now drilling away part of the posterior crus. You keep it
Yes.
intact, but still you make it thinner
Yeah.
in the width like what he had.
Super.
Then you have a lot of access to the foot plate. Now, if the foot plate is irregular, and most of the times it is, you can still drill and make every foot plate a blue foot plate.
Yes.
And
You
then
know,
make a fence. These
you
are the
know-
modifications which
Yeah.
have improved our,
Yeah.
the ease of doing things.
Yeah, I always like Ashish your this idea. I followed this many a time. What he is trying to say,
Yeah.
expanding the indications for the fish technique. I mentioned in the beginning, reverse technique.
Yes.
You need to have a good exposure
Yeah.
to make the fenestra and crimping a piston. Now, if your posterior crust, that is the majority of the time, it is so stout and covers the entire space and make overcrowding. If you thin out the posterior crust, you get adequate space, and in more number of patients you can carry out the reverse stepidotomy.
And then you can do the drilling of the foot plate also. Make it, I like to think why in most cases you don't have a problem and in some cases you have a problem. So I like to think what can I do to make this some
Hey,
difficult
Ashwin ko phone
cases
karna.
into most of the simple cases. That is, so what is it that most often is, it's a very fragile crura, you just touch it and it goes, it's a very thin foot plate. Can you then make every case as a thin foot plate and a very fragile crura? These are the only two things that matter in terms of the surgical manipulations. So the thought and all the actions are going in that direction. Make keep them intact but fragile, the crura, and make the foot plate thin and blue line. That's it. Stepidotomy ends there.
Yes.
Ashim, there was a question for you.
Yeah.
Where is Ashim?
Sorry, I was offline for some time.
Yeah. Was it a quick lunch?
My net went dead. Tell me.
Oh, okay.
No,
okay.
no, no.
This is from Dr. Da.
Boss, there was a question for you about the Hoff technique.
Posterior crus on perichondrium.
Hoff technique.
Yeah, tell me.
Indications.
Indications in how to perform this posterior crus on perichondrium and how to decide about it.
Okay.
First of all, should you be performing?
Today we no longer perform this technique for the simple reason that, as we had mentioned earlier, the removal of
I think your internet is creating problem, no?
plate would cause perhaps a possible elimination. Yeah, my net is in a. Can you hear me?
You're sounding like
It is breaking.
You can repeat the same.
Your voice is breaking. I think your internet speed is the issue.
Too much of Louis 13, Ashim. You're sounding like you're drunk.
Boss, connect to Wi-Fi.
Go on your phone. Go on your phone. He's gone. Anyway, I think Deepak, they no longer do it. ABR used to do it for the opposite ear. Initially, he started doing it. If he did a Teflon on one side, the opposite side, he was doing the posterior crus on perichondrium. I think he did more than 1,500 of such cases.
Yeah. And Deepak, let me tell you.
As the sophistication.
I'm sorry, I have a very bad connection at this point.
Yeah. It's okay. Once your connection is good, you start.
Yeah.
So basically, what do they do?
So it's okay. I think it doesn't need any discussion.
Okay. In brief, what do? They keep the incudostapedial joint intact, tendon intact, remove the anterior crus and the part of the foot plate, put a vein graft, and the entire stapedial arch with the posterior crus then is used on the vein. So if you have an adequate length of the posterior crus, it may work or it works. Otherwise, you may have to convert to a regular procedure immediately. That is all about it.
I have seen ABR do this. I have had the privilege of seeing ABR do this technique. It is extremely difficult to try to
Very difficult.
Maximum length. Yeah. Because remember, the posterior crus is thickest at its base where it joins. It is thinner in the middle, so it's very easy for it to get fractured there. So very patiently with the hook, you have to go on trying to separate it from the way it touches the foot plate. I've seen him do it. Yeah.
Okay, boss, question next.
Another question is,
do you have any vein graft harvesting recording? Anything in your laptop if you want to see?
Yes, I have a vein graft. I'll show it later when my connection is better.
Yeah, okay.
Okay. Another question: how to decide about post?
Hi. Bol.
Hello.
Ho no wasta ho.
Which you have told me about.
Hello.
Ashish.
Ashish को mute कर देना.
There is disturbance from Ashish.
Yes, not at all. Absolutely.
Hello.
Hello. Boss, you mute कर देना बाकी.
Yeah. So question is, what are the causes of persistent conductive hearing loss in very few cases or not complete closure of AB gap? What about your opinion?
So there could be many reasons,
Can you speak a bit louder?
Yeah, there could be many reasons for persistent conductive hearing loss right from beginning. Number one, a misdiagnosis.
Who shot a piston? Sometimes because of the length.
Before that, there could be a misdiagnosis. You went on doing a stapedotomy and the diagnosis was something different. Many a times it happens.
Yeah,
Number two, once it comes to stapes, the length of the piston is very important. Adequate crimping of the piston is very important. There should not be a perilimb fistula. You have to ensure a persistent perilimb fistula could be a cause. Even for the conductive hearing loss, maybe fluctuating sometimes.
It would be a mixed loss.
Yeah, and your alignment of the piston to the fenestra is equally important. An angled piston coming to the edge of the fenestra is not going to work as efficiently as a piston coming straight into the center of the fenestra.
Sometimes a poorly saucered obliterative footplate will cause the anterior part of the footplate to rub against your piston and create some level of conductive hearing loss.
Boss, you come through the cell phone. You think the internet speed is the issue. The voice is breaking.
No, I am on the cell phone only. My internet is dead. I am on the cell phone only.
Okay. Yes, sir. Next question.
Yes, this is from Dr. Sohail from Karachi. If lenticular process is damaged, could it be possible to place piston between handle of malleus and stepidotomy?
Yes. See,
Of course.
this question is valid,
So this
but let me tell you something about it. This will be over treatment. If the lenticular process is damaged and you do a malleus stepidotomy, this will be too much. Yes, the question is valid in case your long process is necrose or eroded, whatever, shorter in length, what you can do. I have two choices. Number one, like he mentioned, malleus stepidotomy. Nowadays, in such situation, we have changed from malleus stepidotomy to lengthening the incus with a bone cement. You can easily lengthen the rest of the incus by means of putting bone cement. Bone cement is the easiest way you can do it, and you can do it intraoperatively, making sure that the bone cement doesn't fall inside, and you can apply it. It becomes harder in few minutes, and then you can use your piston as good as you earlier used. Otherwise, malleus stepidotomy. But lenticular process necrosis doesn't warrant directly to a malleus stepidotomy. You can use a bucket handle prosthesis. You can use bucket handle prosthesis if the lenticular is gone.
Yeah.
One more thing that I do when there is slight lenticular process necrosis is to actually use the superstructure of the stapes and put it on top of the end of the incus and anchor everything with the corda.
So
Yes.
you have a lenticular process in a Shirsasana now. The arch is now gone up.
Upside down lenticular process. That is right. That is right.
Yeah.
And
But,
Satish, I think you should show the bone cement, because I think, if you have the packet in the OT, which brand and what.
Yeah. I can show bone cement, Lana. I can show that bone cement. It is simple, a calcium tetraphosphate, powder, and you have to mix with the citric acid.
Packet.
Citric acid. You have to mix with the citric acid, and it becomes a paste. When you leave this paste, in few minutes it becomes hard.
So
Hard
this
like-
is not the one, Ashim. I think that's the. Satish, can you see Ashim's screen?
Yeah. Now I can see. I can't see.
It is Kitak. It's Kitak from 3M.
I can't see your screen.
Okay. It is KETAC.
Bone
Kitak
cement.
Cement from 3M.
What chemical?
Right.
This is glass ionomeric cement.
So that's
No,
Satish,
boss.
is that
Boss.
precisely-
No way.
This is
This
the way the mistake I did, sir.
No. This glass ionomeric cement is not safe.
Yes.
It is quite toxic
I
to
have
the
heard
surroundings.
earlier.
Yes, it has been proven, and it is no longer in use for the middle ear. The best is what I am telling you is a calcium tetraphosphate with citric acid. That is very safe and very quick and very economical as well, and you can use for multiple indication. Multiple means anywhere you want to make a bone. For cranioplasty, for your even in the mastoid, if you have a big defects in the tegmen or the sinus plate, anywhere you want to make bone, you can use it easily. For the frontal sinus, anywhere you can use it. It is pure bone, as simple as bone.
Anyway, you show it under the microscope or whatever, wherever.
Yes, I will. Yes, sir. Next
There is a
question.
comment there is a comment from John Shadow from Australia. Amazing dissection and work. It's like watching our artist painting a masterpiece. Absolutely fantastic. It's a pleasure and honor to watch a world-class surgeon at work. And also thankful to Dr. Pachauri for all the hard work he has done for this organizing the webcast.
Thank you, Dr. Shadow.
Congratulations to all of you, those who are panelists also. So another question is from Dr. Ravindra from Hubli, that since we are not treating the primary disease
Yeah.
and following stepidotomy, and also we are not giving any medicine to halt the disease, we know that. How do you know the progress of the underlying disease and regrowth of otosclerotic focus all around the
Yes.
stepidotomy site?
Let me tell you. See, this is a bypass procedure,
Yeah.
wherein we are bypassing the fixation of the stapes through a piston, and by means of the piston, the the sound coming to the incus is directly bypassed to the vestibule, leaving the disease or fixation or otosclerosis as such. Now what happens, and there are a lot of studies done even, I tell you, very practical. In the long run, those ears which are not operated have deterioration in the hearing as compared to the ears which have been operated, and they do well. Try to get what I am trying to say. The operated ears are faring well than the non-operated ears, and they are losing hearing. The reason is this otosclerotic mechanism by means of which it gives sensorineural hearing loss. So the majority of the times it is the focus which releases enzymes, hydrolytic, proteolytic enzymes in the inner ear, which are responsible for sensorineural hearing loss. After the piston transmission starts, these enzyme concentration dissipates away from the inner ear fluids and causing no longer any sort of sensorineural hearing loss. Otherwise, in the other ear which is otosclerotic, non-operated, and these enzymes in the exposed in the perilymphatic fluid for longer, they keep on giving hearing loss as compared to the operated ear. This is the philosophy behind it. This is proven and this is true. These otosclerotic ears, they do very well, and majority of these patients do not progress. But yes, if they progress, you have to do something to halt the disease, and that is how the role of medical management, the sodium fluoride and biphosphonate comes. Ashim, you want to add on something? It looks like.
Yeah, I think so.
Yeah, because I completely agree with you. We do, what we do is we try and differentiate the patient population in two. One is with absolutely no sensory neural component, and the other one with a slight high frequency hearing losses. Those with high frequency hearing losses with otosclerosis, we give 20 milligram on alternate day for a period of 2 to 3 years, and then reassess the bone conduction. If the bone conduction remains the same, we continue to give that for a long period of time.
Ashish? Yes.
I can see it.
Yeah. Carry on.
Last year or so, I started using sodium alendronate. So I'm using sodium alendronate, that is the biphosphonate, and this is supposed
Which patients you are using biphosphonates? Which patients you are using biphosphonates?
Extremely advanced cochlear otosclerosis, in which I have not operated on the other ear. I want to assess the condition of the other ear after 1 year of biphosphonate and then see how it's going.
What we do, let me tell you first, this is bone cement, Ashish.
Yeah.
This is bone cement, and this is medicated bone cement with gentamicin. You can see there, gentamicin with gentamicin.
Yeah.
And this is the citric acid along with it that you have to mix. So the moment this is pure calcium tetraphosphate, you have to mix this citric acid, and it makes bone paste, which you leave at some place wherever you want to apply, leave it and it hardens in no time. And then once it becomes bone, believe me, to remove that you have to drill it with a cutting bone. It is like any other bone.
It is like,
cutting burr.
Yeah, cutting burr. So like coming to the boss's point, what you were saying about the sodium fluoride.
Yeah.
What he's saying about the sodium fluoride, it's a good thing as a medical management in certain situations. Our indication for biphosphonate, what I was asking him, our first choice is sodium fluoride. No, by default. Those patients who are having allergic reactions, not tolerating gastric problems, or
gastric issue,
having far advanced otosclerosis with cavitating lesions, then we use biphosphonates. Earlier alendronate, now no more. These are third generation biphosphonate, and now with the risedronate and zoledronate coming up, you have to give injection once in 6 months. That's it. Alendronate, what you are using, either give once a day or once a week. You can give 70 milligrams a week. But this zoledronate, you can give once a month. Risedronate and zoledronate once a year now. 5 milligram injection once a year. That's it, and it works as equal to the what you give daily doses of alendronate.
That's true. That's true. I've started using this now, but I have no experience with it in the long term.
I
I've
have
just
no
started
idea
using it.
what you guys are talking, by the way.
These are biphosphonates to
Okay.
see. These are to promote. These are to
This doesn't
prevent.
come in my zone of Stapes surgery anyway. No, no, I'm just making it like
These are just used to
incredible
prevent
lines.
bone resorption. That's it. This is to prevent bone resorption, and there are certain indications. I tell you, you can use it judiciously if you are careful. Number one, in all patients presenting, autosclerotic patients presenting with tinnitus and vestibular symptoms, you can start using that. Then secondly, to the patients having family history, those who have started having developing autosclerotic, early autosclerosis, hearing loss, you can start from the beginning to prevent developing fast. And in those patients who have already developed extensive cochlear damages.
I think Satish, let's
What
under you and Ashim start maybe 20 centers where we could do this for the next whatever 2-3 years. No, I think this medical line of management. No, with our volumes, we'll be able to generate an international class data on this medical management.
Yeah, it's
I don't know
important.
which other country is doing this. Yeah.
So if we
Okay.
are not having any family history, what are the other factors that are causing this?
Autosclerosis.
Yeah,
Yeah,
there's
there are
a
so
few
many
questions
etiologies,
about
sir.
this.
So many
So
etiology.
many, yeah, environmental
Yeah,
factors also, and
environmental,
viral infections.
metabolic, collagen theory, measles. Measles is one of the factor. There
Yeah,
was a
this is
huge
true.
publication from Germany long back. They did a huge trial countrywide on all individuals up to age of 25, and from year 93 to 2004, they had a significant reduction in the incidence of autosclerosis after an intensified campaigning of measles vaccination. This was proven, and it has been proven this measles RNA has been extracted from the autosclerotic foot plates. Their antibodies to the measles have been found in the perilymphatic fluid. It's been proven, but there are so many theories.
अरे there is such a simple surgical solution. क्यों ज़्यादा इसमें जाए? Go ahead.
So we are looking at the high tone hearing losses.
It's not
And
so
I
simple
mean,
surgery.
even a coronary bypass graft after 10 years, but he has to be revised. ये
one
तो
more
lifelong
question,
चलता है.
Dr. Satish, one more question. This is from Dr. Kumar Raja, Vishakhapatnam. Hello.
Yeah.
Next case is ready. Yes, sir.
Yeah.
Your audio, Satish, you're not able to hear you.
Okay, can you comment on the use of chlorotomy scissors? Also, if you use piezoelectrical surgical handpiece for chlorotomy or fenestra making?
Chlorotomy scissors is one of the way to divide the stapedial crura. But that is all again a mechanical factor which is transmitted. So once you have a laser, you don't need all this. If you don't have a laser,
If one is not having laser, then
then microdrill. Microdrill is the best alternative than chlorotomy scissors, because chlorotomy scissors again gives a click. The one mechanical movement transfer can give problem. If the stapes is completely fixed,
Satish, I will comment on this because I have experience with the chlorotomy scissors. One, it is little bulky. The angle at which it goes, you have to remove far more bony overhang to engage the chlorotomy scissors. Chlorotomy scissors came primarily from fishes designed to get the predictability for the anterior crura. But for the posterior crura, now for the same catalog number of Karl Stoves, the chlorotomy scissor which I bought 20 years back and the one which I tried to buy 5 years back, for the same catalog number, the dimension of the scissor has changed. It has become extremely bulky. I did for a year or 2 years a technique called as Stapes head decapitation technique, where I would keep the cruras intact and only remove the head of the
Ashim ko phone
stapes.
kar.
And for that, I needed the chlorotomy scissors. So I did a lot of study on which other companies have. And like Satish said, they very quickly go bad because it is bone that you are cutting.
yes.
So the chlorotomy scissor starts to go bad. And when you do this and if it doesn't cut, it twists. So it is actually going to rock the stapes more.
And the Karl Stoves chlorotomy scissors set cost almost $1,000.
I forgot 40, yeah, correct, even more. And they go bad really fast. because you're cutting the bone. So it's not, so the drill is the better one to weaken the crura and then just do, and of course the laser. So the crurotomy scissor is not a substitute for a laser. Because I think that's what is going on in that person's mind.
Yeah. So we have been finished with the questions right now. You can go ahead with your surgery.
Hello?
Hello?
Yeah.
Yes, sir?
Yeah, we are ready to go to the microscope picture.
Yeah.
Yeah, we are all set almost. In 5 minutes we are starting. Meantime, are you getting the slide on the...
Oval window sealing is what we are reading.
Yes, this is a very important issue. I did a direct piston, without sealing the over window.
Yeah.
Where is Ashim? Where is he gone? And we have learned this from Ashim using the vein graft. Now, to critically analyze, it's not about what is good, what is bad. We need to know the advantage and disadvantage. So why we need a seal? First of all, the seal is needed to segregate, to segregate the inner ear space from the middle ear space, so the perilimb doesn't leak in the future and the complication do not happen to occur. Now, in a regular situation, see, the thousands or the hundreds of thousands of direct piston surgeries have been done, which patients are doing very well. Provided the only thing required is a adequate length of the piston. If the piston is not over long, the endosteal membrane forms quickly in 24 to 48 hours and segregates, and it works very well. If the piston is over long, whatever you put is not going to work. Agreed. Now the second thing is, if we are trying to put something to seal the oval window from outside after putting the piston, like vein, gel form, all that is, I strongly contraindicate, believe me, that is something not to be done. Only thing which can work or which works best is the vein. Then you better interpose the vein over the fenestra and put your piston. And the biggest advantage besides sealing this, lot of people who contradict the vein, is it may take away the impedance and it may increase the impedance of the piston. But it doesn't. The long-term studies with the Ashim are the proof that it works so well. So we agree it works so well. The best thing which I found about the vein is, you can't use an overlong piston once you are using vein. That is the biggest advantage, I tell you. You put the vein, the moment you try to use a long piston, the vein will invaginate inside and that will warn you that you are using a long piston. Cut down the piston size to an adequate. So if you are using vein, nothing like it. Not using, keep the piston size adequate, that is most important, and it works. But there are certain situations, yeah boss, we are coming to you. There are certain situations where I always encourage using vein, like in revisions. Revisions in patients who are more demanding. My indications for vein, I am a proponent of direct piston. So my indications in patients who are more demanding in terms of their work, like the pilots who have to fly frequently, divers, where the excursions are more, it is better to use vein to give a perfect seal, to ensure the seal perfectly. Now Ashim has been using vein in all cases, and he is going to tell us about the technique, and I want to know from him when he doesn't use the vein.
Okay, basically I use vein in all routine otosclerosis surgery, but in obliterative foci, I don't use vein because of the risk of it. Vein is after all mesenchymal tissue, and mesenchymal tissue, the reossification chances are much higher. The second place I don't use it is when it's an extremely narrow oval window niche. When if there is hardly any space, there's hardly any space, 0.4 or 0.5 millimeters of space, that is when a vein is not indicated. And the third one is when it's a very deep niche, in which the chance of stuffing that area with the vein is not is there. In such cases, I will not use a vein. Otherwise, in most cases, I tend to use a vein. But having said that, and having seen Satish, The important part is the length, and the second most important part is the diameter of the fenestra. The diameter of the fenestra should always be 0.2 millimeters more than the diameter of the prosthesis, not more so. Suppose you have partial platinectomy, or suppose you have the irregularly fractured foot plate, as in those people who use they use a perforator. In such cases, it is absolutely essential to use a vein in that scenario. There can never be a situation when you do a partial platinectomy or a total platinectomy, use a piston and not use a vein.
Yeah, that is
Hello?
correct. That is super.
Correct. So if there is a discrete fenestra, then there's an option. But of course, if a part of the foot plate is out, then you have to seal it, because now you have more tissues into discussion.
Now, can I ask one thing? Hello, can I add on one point?
Yeah.
Yes, yes.
Yeah. So there are studies done, lot of studies done histologically. The pathological studies, then I am talking about the autopathology Shuknet. The vein, as they studied a lot of material used to be, that is used to seal the fenestra. Vein, fat, fascia, perichondrium, other tissues, and they found the vein to be closest to the architecture of the, or the in terms of tensile strength, closest to the annular ligament of the stapes. So once you are using any sealing material, if you are, vein is closest to the annular ligament, because ultimately it acts as the annular ligament underneath the piston. Like,
Satish,
yeah.
tell me, is that not just a free graft? What is the fate of the vein that is kept
Yes,
there?
yeah. So you know what happens? Once you lay the vein, you make the under surface of the, the surface of the foot plate raw. You have to demucosalize the surface for the vein to be integrated, and then the middle ear mucosa grows over the vein to vascularize it. It works very well.
So the vein remains alive.
Yes.
Yes.
Yes,
It acts as a free graft.
Was the tensile strength of the vein is closest to the annular ligament. That way it is amazing. The issue is whether it is strictly required in every case or not. And what we have seen in our, I am finding a midway. I do use vein with certain indications I told. There is no harm in using vein in every case. There is no harm in using vein, I tell you. But, using in every case is something we learn from Ashim. Ashish, are you using vein?
No, I'm not. I went through a
You
small
can never
section.
use in every case. Yeah, we have the picture.
Yeah, just a minute, just a minute. इसको touch करना. So this case we have already started, and my associate has already raised the flaps, because that part we have already shown, so there is no point in going to that. And there is some interesting finding in this, some overcrowding of the oval window.
Overcrowding?
Yes, it's not like I was looking for some case where I could show the reverse stepidotomy of the fish, or something like laser stamp, which is not, this is not appropriate for that matter. I will show you.
This looks so the incus is slightly.
Yeah, see, you don't see the major part of the foot plate from the beginning. Can you see now here?
Yeah.
These are not the cases for all those procedures we discuss. Not the case for the laser stamp, not the case for reversal. Can you see that?
Yeah. In this case, the superior half of the foot plate is very thick, I think, and inferior is very thin.
So the visibility is the question.
Yeah.
So that kind of exposure.
Some more overhang removal, I guess.
Overhang is not a big issue. The big issue is the posterior crust is thick, the oval window is narrow, and you have hardly any space to negotiate
No,
your.
the stapedius is far more superiorly. The more of the posterior crust
Yes.
is inferior, towards the
Yes.
promontory, unlike the earlier case.
Yeah, and see the unlike
incision
the
of the
previous
stapedius
case,
is-
unlike the previous case, see the angulation of the incus, the difference
Yeah.
in the previous and this case.
Yeah.
In the
It's a
previous
relatively
case,
short, it's going to be a relatively short incus. The
yeah,
lenticular process is not going beyond the
yes,
inferior margin of the foot plate.
yes, right. This is left side,
Yeah.
and now first time what I am doing is improving my exposure. I don't think I need to remove too much of the bone in here in this case.
Okay. Okay. You are the boss.
You are the boss. See the man of the man. See the, I can see the glimpse of the corda.
Yeah.
Corda?
Yes, here it is.
Okay.
Deep inside.
See this?
What if we had allowed you to be parked there only?
Yeah, that's what I'm trying to. Curate. See, altogether a different situation than the previous case.
This, yeah. So the
See how variable is the enactment.
AP's suprastructure is actually running away from the incus. It's going more inferiorly. It's not a very perpendicular assembly.
See the fallopian canal.
Very good guess, Satish.
It is chosen well.
This length of the stapedius is quite good. Unlike
Yes,
the
yeah.
earlier one. This is
Unlike
average. This is
I
normal,
mentioned, I mentioned during the last case the stapedius was shorter.
Short, yes.
Short stapedius, abnormal morphology of the incus, abnormal morphology of the posterior crus, and we found a oozer. You saw?
Yes. The CSF, the perilymph kept coming towards the end also.
Yes. Unlike the usual situation, it was more.
Yeah, yeah.
That's why I
The
thought.
superior half of the foot plate is really very, very thick. And the inferior half is, these, when you use a perforator on such foot plates, they tend to crack along the long axis. And you get a sort of a flap door where, you know, the crack runs along the length because the two thicknesses are so different. We'll
Yes.
see once you remove it.
Yes, yes, I can see.
Yeah.
I can appreciate what you are saying. This
So
one, you are
therefore,
saying this one.
drilling that thick part.
Yeah, yeah, you are saying this
see,
one.
That's extremely thick, correct.
Yeah, yeah. I may not have to do anything. See the mobility?
That authorization is a must. Yeah.
You may not have to do anything means?
I may leave
I
it.
said
Let me expose after removal of the posterior crust the foot plate first. हाँ रोक रोक नहीं वो उठा दे फ्लैप उठा दे.
So I keep this the incudus tapetal joint intact. That also allows me certain extra leverage or a margin of error to go to the base of the anterior crura. See the way suction is going, the same way I take my drill and try to reach the base of the anterior crura. That's when I remove a little bit more of the posterior superior overhang. And I don't know if Vivek is watching.
See this, Ashish?
Yeah, yeah.
This
yeah,
is my
yeah,
joint
sure.
knife.
Yeah,
See this?
yeah,
Through and through.
yeah.
अल्लाह, वो दे मेरे को लेजर. See now more of the inferior part of the foot plate is under vision now.
Yeah,
Can you see?
yeah, 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 yeah.
Yes.
I know what you are asking me about drilling this superior thick part now.
You are going to make the fenestra in the inferior only.
Yeah, if I have adequate space, why to?
Yeah.
Now, first of all, using the laser. This patient, Ashish, had only 30 dB airborne gap. Hello?
अच्छा.
Hello?
हाँ मुझे शिंदे साहेबांना.
हेलो. पकड़ना इसको. यो पकड़ लो.
Ashish. Ashish. Ashish.
Yeah, Satish, he is busy. No problem.
Yeah, this patient has only 30 dB airborne gap.
Yes, sir.
Yeah. Tell me. Satish.
Yes. Hello.
Hello,
Yes, yes, we can hear you. No problem. You carry
you
on.
can hear.
Hello.
Yes, please. Hello.
Yes, can you hear me?
Yes, yes, we can hear you.
So I am bringing my laser beam. Yeah, can you see the beam?
Yes, yes, we can see.
अरे पकड़ना इसको यार ऐसे नहीं नीचे रख So now I am going to vaporize my tendon first. See this?
Yeah.
Okay.
This is done. See the tendon gone?
Yes, very, very clear.
Could you see the tendon gone?
Gone, gone, gone.
Now I am going to vaporize my posterior crus. बड़ा अबे Hello.
Yeah, Satish.
Yeah. Before that, I have already vaporized Ashish the tendon.
Yeah, yeah, I saw it. You 3 shots. I saw you. Yeah.
Yeah. Use a very low power on that because that is the first interaction. I have to see whether it is going proper or not.
Yeah. It is
That's
your
why
reverse.
only. That's why only I always use on the tendon. Tendon. Otherwise, I can kit. ये नहीं है straight दे यार ये देख उलझता है कुछ भी दे देते हो क्या Give me straight pick. See that I am pushing a little bit of the gel form over the foot plate as a protective measure, you know.
From heat, you are saying.
Yeah, because this laser absorbs with the water, you know. दूसरा दे. So if you put anything wet, that absorbs the laser energy and prevent it from passing through. दूसरा दे.
So in vein graft, which side of the graft you keep on that side?
It is always the intima that faces the surgeon and the adventitia that faces the vestibule.
Yes.
That part has to be absolutely sacred.
And what are the joint knife you use, Satish? Any specific?
Yeah, that is a very good angle. This is a good angle to separate the incudostapedial joint. You know, this movement, right angle, this movement sometimes, if you are not doing proper, you may disarticulate the malleolingual joint.
Okay. Any specific, any company or any brand or just it?
Pardon?
No, Karl Strauss also has it. Everybody has it. But honestly, a good long right angle pointer is also equally good.
Equally good, equally good, equally good.
And actually
I
the toughest,
use the right angled.
the toughest incudostapedial joints to be separated are the ones with tympanosclerosis. They really get fused.
Difficult, yeah.
You know, very difficult. And there the incus is also rock hard. So passing, so that times you can end up fracturing the lenticular process because the tympanosclerosis has demineralized that also. But in Stapes, in autosclerosis, it is not usually not difficult. Although
Ashim,
sometimes the superior surface of the head of the stapes can give you certain obstructions in passing the knife. Sorry,
you know,
Satish, you're trying to say something.
Ashim,
Yes.
boss, I have used in few cases,
Yeah.
rather than the vein from the wrist, from the same vicinity, superficial temporal vein.
Yeah, I heard this is the one which runs inferior to the fascia, no?
It's possible, yes.
Yeah, see this, the posterior crust vaporized.
Yeah,
I will remove this now and see this.
yeah. So now we are seeing a much,
Yes,
much
Hollowing of the posterior crust. Light say karna.
yeah.
Chhod de, chhod de.
So now he's going to get enough width of the blue foot plate,
Nahi.
and he's not going to need to drill the foot plate at all.
See now,
Yeah,
separated.
separated. Yeah. So now here it is almost 4/5 of the inferior is blue and 1/5 is yeah.
The anterior crust is fragile and broken. See this?
Yeah.
Anterior crust, anterior
In this
crust.
case, the anterior crust very thin.
Yeah, mostly. What is your incidence of a thick anterior crust, to be precise? Ashish, how many times you have seen?
Difficult to say the number, but enough for me to now not assume that the anterior crust. It's always something which I will
See.
look for.
Amazing blue foot plate. Can you see now?
Yes, yes.
Yeah, we can see.
So you can get up and what Henry Fontaine,
Perfect.
whatever you said, Italian man, give it to your resident.
But you know, I told you, right angle there. In the beginning, this patient had only 30 dB hearing loss.
Yeah.
Airborne gap.
But good fixation. Yeah, superior border is completely fixed. So this is not likely to get mobilized. This foot plate is a easy foot plate.
Yes. See this now. And you are right. See
Because
the
it's like
It
observation.
depends on the peripheral fixation.
But such a massive autosclerotic fixation superiorly, and he's going to be working inferiorly. There's no chance of any.
Yeah, I have adequate space.
Yeah. Lot
More
of
than
space.
enough. More than
But the
enough.
incus is short, Satish, definitely.
Yeah, that's what I was making the point. Your observation.
Yeah.
Incus is, see again,
The
morphologically.
lenticular process is almost in the center of the foot plate.
Yeah, not only
Between
short,
the anterior
morphologically is
and-
also not absolutely normal.
Yeah, there is a certain curvature to it. It's a little bit like this.
And now see the magic.
Now, enumerate the steps you will follow when, suppose at this level, floating foot plate to occur. Then what you will do? With all the steps.
If floater happens to occur,
Yeah, at this level.
suppose you develop a floater. I will show you a video of a floater after this. Remind me. If floater happens to occur, the best thing you can do is leave it. Don't try to do anything to it to fish out or do anything. Put a fascia graft, vein graft over it and put a piston over it and come out. If it refixes, then you go
Without
back and do
making
a step.
fenestra. He's saying don't make a fenestra. Just put vein, and then you have to put an incus. Put a piston between the incus and now the mobilize. That's a
Ashish.
little bit of a surgical. Yeah,
This time I am using less wattage because I can see a pure blue foot plate.
thin blue. Yeah.
पकड़ने इसको, patient.
So in a situation like that, the length of the piston becomes a critical issue, and because the lower end doesn't dip into the vestibule, you have to slightly elevate the incus to pass the piston
Yeah.
around the long process.
Yeah, I will. Now see, finally, my fenestra will be inferiorly in the central part of the foot plate. Okay?
Yeah.
पकड़ना इसको.
Rajeev, once his magic show is over, I will complete.
यार, one of the-
One second. Something is there? Yes, repeat, sir.
No, once
Hello?
his magic show is over, I will complete this part about the floating foot plate.
Yes.
Now, what I was trying to say, I will make my fenestra in the central part of the foot plate inferiorly. See this?
Yeah.
Yeah.
My,
3, 2, 1, shoot.
no, I will first adjust the focal length of the laser and focal length of the microscope should match. See this? Can you see the laser beam?
We can
Yes,
see.
yes.
Yeah, we can see. We can see.
That's it.
Big. Oh my. Big.
See this?
Yes, yes, yes.
That is done, and see the perilimb section there. Perilimb full of. See the perilimb full of fluid.
Perilymph, yeah.
Yeah, the vestibule full of perilymph. See that?
Beautiful. And
Now
it's
the
not
last
using
thing,
now.
last thing left is piston. What are they measuring?
Any experience with this piezoelectrical surgical handpiece for chlorotomy or fenestra?
Oh, come on. Piezoelectric. This technology has come. This is safer, I believe. But it is not for regular use. The idea behind the piezoelectric technique is you can drill the bone. The moment it comes in contact with the soft tissue, it stops. So it is very safe.
There is to the skeeter, there is a horizontal saw, a disc-like thing. I tried using it. Our friend Raman, he introduced me to this when we were doing a course in Calicut. Good, but I think the chlorotomy was better. So you can use the saw to weaken the neck of the head of the stapes.
Fix
Suppose at that
थोड़ा सा कर दे accurate, confirm बता.
plaster get down in the means hypertympanum or disappear somewhere. Means
Can I, Rajeev, if you don't mind, can I complete that floater thing?
Yeah, sure.
Yeah. So once you put the piston there, the piston has to be that little extra short. On a mobile foot plate, when you put a piston without making a fenestra, this guy is going to finish. And then you have to follow up this patient very intensely, because the patient will get, of course, improvement in hearing. And as the refixation starts, slowly the hearing goes down. So doing a serial audiogram becomes obligatory. But if you wait too long, the incus will end up getting necrosed, because as the foot plate gets fixed, the transmission start becoming less and less, and then the undersurface of the incus, which Ashim mentioned, the knot starts coming. That happens. So you want to monitor this patient very well, and as soon as you start seeing a drop in the increase in the conductive loss, you must re-explore and do the Otherwise, Ashim, they have a technique of putting a cartilage instead of a piston.
Ashish,
once Satish puts his piston in, I'd like to share with you my
vein graft.
Yes.
No, apart from the vein graft, my principles of handling a floater, because we have a little algorithm that I wanted to talk about.
Oh, lovely. Yeah. Okay.
Ashish.
Yeah.
For the audience, they need to know, after this surgery, whatever hearing result we get, this hearing keeps on improving over the period of time up to 1 year. Because whatever the condition now we have, it improves for the hearing transmission over the period of time.
Yeah.
The piston will anchor with the fibrosis better to the long process. The healing at the lower end, and then final scar will mature, and the piston will be more anchored at the lower end with the to the vestibule, and then final hearing will be much better than what we have immediately. So we need to tell our patient the hearing improves over the period of time.
Even beyond 3 months, the improvement is there.
Yeah, up to 1 year. Up to 1 year.
1 year. Up to 1 year.
Okay, sorry, I thought that the best comes 3 months, and then that's where it is.
No. So our definition of a success is airborne gap closure within 10 decibel at the end of 1 year. That is the definition.
Then when would you do the second year?
I would do
So
second
I do it
year.
after 3 months.
See, second year I have certain reservations, I tell you. I will do only in certain patients second year. First of all, only those patients whose first year has gone uneventful. Just a minute. Only in those patients whose first year has gone
Uneventful.
This is going to be a difficult piston to put. It's an
yeah, I know the direction is not good.
Yeah,
because I have to do something for the length.
you have to correct. And
Yeah, that's what,
probably
that is
you
the only
can
issue.
bend the titanium. You
No,
can
no,
make a
no, no,
L.
it will break. हाथ हटा लिया कर ऐसे तो
It will break.
See, this particular Ashish, this particular titanium is extremely rigid. The type of
Oh, okay.
titanium used here will break.
So with the one which fish had given us, those we could
The
play.
fish has a flexible shaft.
Shaft, yeah.
That shaft is a ribbon. It's not a cylinder. That's why it's flexible.
Okay. So
This-
I haven't used it because those one could change any at will. In fact, they were more delicate.
Yeah, this one is a cylinder, so it won't bend.
Yeah, this doesn't bend at all.
Okay.
But somehow I will able to make it.
Now it is okay. Yeah.
Now it will
Not
latch on
okay.
without difficulty.
So your question of the second year, I tell you,
Yeah.
in the first year, if we have found difficulty, anatomical abnormality, difficulty, some type 2, 3 foot plates, all those we will never do a second year so early. Or rather, is an indication for us. Secondly, the patient should come for second year.
I'm
Those
not going to
patients,
their house. They are only coming.
it is not that you persuade the patient for the second year.
Here, maybe.
Can you see now?
Yeah.
Snugly fitting.
In this case, would you put a small seal of blood?
Yes, yes.
Blood.
I would have thought that even a vein would have worked here.
What vein?
Yeah, because there's a slightly larger fenestra.
How about some yellow
No, no.
fat? Because the
Boss.
anterior the gap.
See now, the piston is so snugly fit
Yeah.
in the
Size is
middle.
very big. But,
And
this
see
is
now,
very big.
see now movement. See this. The beauty of this piston is this advantage of holding the incus. And now I will just throw a drop of blood.
So that much gap between the discrepancy between the fenestra diameter and the piston you are okay
Yeah,
with,
that will be covered by the endosteal membrane. See, as long as your piston length is good,
okay. It's
never a
on the
big
surface
issue.
of the piston that has to, yeah.
It is the length of the piston which
Important part
matters.
is the formation of the endosteum.
Yes. See now my blood.
Why don't you just scratch a mucosa there and cause some bleeding there? No, I mean, I do that. I mean, when that is there, then it just goes into the wound.
I don't want continuous bleeding, man. Why to? See now, that is his own blood occupying the oval window. That's it.
I know.
Yeah.
See now. So the incus, the dimension of the long process was not normal.
Hello?
Incus was short.
Hello?
Hello?
Yes.
And now it is snugly fitting. Can you see this?
Yep, absolutely. Beautiful.
Okay, band kar dena. Now the question of the second year will not do like as I mentioned for the years we had problems. Let the patient come to you, and those patients having any post-operative vertigo after the first surgery. This is very important. Those who have had post-operative vertigo after the first surgery, we should avoid a second year surgery to prevent vestibular differentiation. The reason is, 1 year you have given some vestibular damage which patient suffered post-op with vertigo, and ultimately it leads to compensation. And if you try to do the other year and injure the vestibule of the other year, is a disaster.
No, you're right.
So before second year, we must do the vestibular test.
Yes, you must do a proper video and nystagmography as
Yes.
well as a vestibular head impulse testing to ensure that the labyrinth is a good
Yes.
functioning labyrinth, because if the same thing happens on the other ear, you will end up with bilateral vestibulopathy.
Yes,
hypoactive
complete
vestibular.
differentiation. So vestibular testing is necessary. Number 3, you must look at the test sensation on that side if it is good. If you have damaged the cord on one side and now trying to operate on the other side, that will again be a big problem. So second year, there are certain reservations. You have to fulfill those criteria before taking up that case. And secondly, there are a lot of studies done. Lot of studies done. Whatever findings you find in the first year, they are likely to be seen in the other year as well. Like I tell you, majority of the patients who have had, obliterative autosclerosis in 1 year are likely to have the obliterative in the other year as well.
Absolutely.
Majority of the patients having had facial, prolapse on one side are likely to have the facial prolapse on the other side. So if
Even
you
the
ask
length
me,
of the piston, even the length of the piston is similar on both the
yes,
sides.
yes, everything corroborates. So if I do a obliterative autosclerosis on one side, for me, I will not operate on the other side. Ashim is definitely going to operate. I am sure.
I would operate for sure.
Because obliterative on the other side, I have a reservation. I may not give that good result as opposed to the blue foot plate. And once you have done on one side, this is not as something any malignant disease. Why to give him an opportunity for radiation? And anyway, by and large, I am telling you, the results of the second year are always inferior to the results of the first year. This is always true. Always true. This is always true.
No, sir.
Even satisfaction maybe, but not the result.
Satisfaction, yes, not the result. And the reason that I would choose you to, I mean, you're a very, very skillful surgeon, Satish. So I would choose to recommend that you operate on the other side for obliterative autosclerosis for two reasons. One is that, as you know, in obliterative foci, the bone conduction tends to deteriorate over time. The disuse atrophy of the nerve function, the reduction in discrimination due to a disused ear, unused ear, that should be avoided in obliterative autosclerosis. So yes, the interval of time between the 2 years should be minimum of 2 years, but certainly you should consider doing it. So normally I take 1 year between the 2 years, but in this case I would like to take 2 years.
Yeah, 2 years time.
So when you recommend to use bucket ender processes, what are the indications?
In the very short piston, when the lenticular process is more or less above the center of the foot, that is when you use a bucket handle. But remember one thing, it's very important to measure that length.
This was a borderline indication.
Yeah, it was an indication for this bucket ender.
Yeah.
Yeah, but 1 millimeter less than your measured length. Remember.
Bucket handle is a very good prosthesis, you know. If suppose you have a little bit of a long process necrosis, lenticular necrosis, whatever the long process will be taken inside the bucket, remaining long process, and the handle of the bucket will be flipping over the long process again. So it takes away, it covers pardon?
So you can't crimp it. So it's the chance of it slipping. So I don't like the lenticular process is absent. I don't think it's a good idea to use a bucket handle prosthesis.
Bucket handle
essentially the bucket is meant to fit into the lenticular process.
Yes, sir, lenticular.
So generally what people do, Ashish, what do they do? They flip the handle of the bucket over the remaining long process, and there they create, some groove with a laser. So that invites fibrosis in that place to keep the piston in place.
Yeah. I think Ashim has a technique. Ashim, you all put a cartilage strut from the anterior, not a posterior inferior to the
anterior annulus to the lenticular process.
Yeah, that's something which is the most sure shot way to manage
just holds the piston in place like that.
So
what is the means? How do you assess the hearing on table in this doing other test?
We do a whisper test to start with, and then we do an audiogram also on the table. So what we do is
that I think it is all the whisper test is all drama.
Yeah, that's drama because but it's good for the patient's psychology.
For psychology, because at least on table you can point out that you at that time you were a good.
Absolutely, but for me, intraoperative audiometry is the gold standard.
Ashish.
But I will tell you the trick, other practical trick. I don't pack the external canal completely with the gel foam. I leave a small gap
Always,
So
always.
I don't do the whisper test anymore on the table. When the patient goes out, it is actually even the relatives are talking, and until the gel foam swells and blocks it, for that 1 hour or so, the patient is hearing very well.
Yeah,
So no problem in taking the bill.
Rajiv boss, are you getting this slide?
yeah,
Yes.
getting interrupt. Yeah,
So what I'm going to show you two slides. These are the situation you can read out where the SNHL is likely to happen. If
Yeah.
any of these things happen to occur, maybe aspiration is number one. Now
yeah,
it depends on your luck how severely you have aspirated the perilimb to the level that damage the membrane labyrinth or little bit. Floater, any accidental complete removal of the foot plate, submerged, laser fire on the open labyrinth, blood gone inside the labyrinth and gusher. Any of these things happening are likely to result in SNHL undoubtedly, depending upon how massively you have damaged and how lucky you are. But
Yes.
these are the short situations which are going to give you SNHL. Now, this another slide. This is to show there are certain regions for the unidentified SNHL, unpredictable SNHL, which are beyond the control of the surgeon's, limits. You have done a good stapedectomy, everything went off well, and then you see afterward the patient is having vertigo, dizzy, and it is persisting, the hearing is, gone down, SNHL is there, and these are the regions where there is no control of the surgeon. Because once you open the inner ear, the sequence of events starts because of the many regions like electrolyte disturbances, so many other things, whatever. The blood lymphatic barrier breaks and so many things. Enzymatic process, blood supply, so many things. And this is something which is beyond the surgeon's control, resulting into up to 1% of the situation can lead to SNHL in spite of having done a good job. Anything, boss, from your side? Any comment?
Well, in whenever you feel that you slightly created inner ear trauma, massive doses of steroids and N-acetylcysteine should be given.
Yeah, that is right. To cover up, we have to do all that.
Yes.
That is different. But this is something which gives trauma and we have to do something to avoid that situation. Now, can we take some questions or discuss these certain issues?
I just want to go over a floater once, if possible.
Yes, please.
Okay, so
Yeah, show your algorithm. Yeah.
see, there are certain, sorry.
Slide share.
You were about to show something, no?
Yes, I am. 1 second. I'm just trying to switch on my slide share. Just bear with me for 1 second. Okay, do you get it?
yeah. Now, yeah, we're getting it.
You're getting I go principles of handling a floater. Okay, so first scenario is that you have a subluxated with an intact ossicular chain. Okay, so when you just started work and you find that suddenly inadvertently your hand is touched, and this is for the juniors, then with an intact ossicular chain, I would recommend that we would leave it well alone. Now, the second option is that you have fractured the crura and the foot plate has started floating. In that scenario, I would want to consider placing a vein with a piston of the appropriate length. And of course, if I have a laser and the foot plated blue, I would go ahead and fenestrate it and go ahead with the procedure also. Now, assuming that the foot plate has got subluxated. Now, if there is a slight subluxation,
It's something there's overlap at least with my
Yeah.
the
In my
clarity of the go back and go again forward.
some issue with the
Yeah, some
transmission.
overlapping
Okay.
of slide.
can you see this now?
No,
No, there is overlapping of slides. It looks
it's
like.
एक के दो के चार मुझको तो दिखते हैं.
Well, I don't know what to do then.
No, go back. Yeah, and now
Okay, I'll share
try
screen
again. I think it's the low, whatever it's called.
Yeah, the low bandwidth.
The low bandwidth, yeah.
Okay, can you see now?
He just started screen sharing. Not yet. It's not coming across.
It seems that I
Okay.
started screen sharing.
Now is it coming?
Not really.
Okay, well, I'll just describe it.
Yeah.
Assuming that you have a subluxed foot plate.
Yeah.
If it is light subluxation, of course, you can put a vane and a piston of the appropriate length. As Ashish very rightly said, it has to be not too long so that you don't push the edge of the foot plate inwards. But assuming that it's really gone deeper inside, the possibility would be to extract the foot plate and then do a vane with a cartilage interposition. And of course, if you have a laser and if the foot plate is blue, you can fenestrate it and then do a standard piston technique. But the important thing is that in order to extract the foot plate, the idea is to use a micro drill to
Now we
create
can see you, Ashim.
Yeah.
Your screen is seen. Yeah.
Okay. So the idea is that you create a small pothole inferior to the foot plate and then use a small right angle hook to extract the foot plate completely. But if there's any chance that it's difficult extraction, the best option is to cover it with a vane and put an appropriate length piston and come away from it.
So
The
when you,
idea is,
can I ask, when you advocate extraction?
if it has gone inside,
Okay. And
if you know,
can't
sometimes it
can't we leave that whatever has gone inside?
No, now what happens is if it's gone inside, you'll have a persistent perilymphatic leak.
No, then you have to
Generally,
cover with the
you have-
vein graft. Obviously, you have to cover with the vein graft.
Satish, again, if you have the crura, how will you cover it with the vein graft?
No. No, once
If
it
the
has,
crura are intact, how will you
Yeah.
cover it with the vein graft?
or you mean to say it has gone inside along with the crura?
Along with the partial part of the crura, you know.
Then
Sometimes what
obviously,
you have a varying length of crura. The anterior and the posterior crura are not fractured exactly at the base. If that has gone inside, you cannot just stuff a piece of vein out there. So the best option would be then to extract it. You understand?
yeah.
Yeah. Because if the crura are there, how will you place a flat vein? You can't. So this is the basic algorithm. If you have a flat foot plate, put a vein, put a piston. If you have a total platinectomy, not a piston, but a cartilage. If at all we have time, I can show the cartilage on vein technique at a later date.
So cartilage when there is a total platinectomy.
There's a total platinectomy because you remember that the foot plate is 3 millimeters by 1 millimeter.
Yeah.
So there is no piston that is 3 millimeter by 1 millimeter, right?
Yeah.
So as you know, there will be late bulging of the oval window membrane.
Yes.
Why does it bulge? Because of the pressure of the perilymph building up over time.
Yes.
So in spite of the fact that you have a proper length of the piston, the bulging perilymph will perforate through that piston. And you will have the problem there. And you will have a perilymphatic fistula.
Yes.
So in that scenario, you are better off with autologous cartilage, which is live tissue, which is soft and which is of the appropriate size.
Obviously. So see, can you see this picture? Anybody?
Yeah, we can see.
Persistent stapedial artery.
This is Ashish's picture I have screened. Ashish,
Yeah, I have sent
this
it.
is, see the
I can see.
big persistent stapedial artery. This is not a small one. Sometimes you have a small one and such big arteries, there is always a debate. There are a lot of papers debating whether we can cauterize it safely or not. For a smaller arteries, yes, nothing happens. For a bigger caliber artery like this, I would not advocate without doing an MR angiography. Because some publications have reported these arteries are destined to supply certain intracranial areas, particularly lateral lemniscus and the internal capsule areas where it can lead to hemiplegia even, partly.
There are four anatomically described destinations of this artery.
Yes, so always better to do MR angiography. That will tell us where it is going to, how important it is in numerous interconnections or not inside or what. So before taking a call, but bigger arteries should be avoided
But
for
note that
cauterization.
the artery is so much anteriorly. The posterior entire half or more than half is, Satish, if you can run that video where we make a fenestra. It's very easily possible. It's not a
Yeah,
contraindication
yeah.
for surgery.
Many a times you can carry out a fenestration and piston application with the artery in place.
Yeah,
But
now I think here you can see. Yeah,
those
yeah.
patient who
See how it
present
is
with
coming out
tinnitus,
from the promontory. When I
Yeah,
retract
yeah, yeah.
the chorda, how it is. Yeah,
yeah, but those patients who present with a tinnitus are not going to improve unless
yeah.
you cauterize it.
I still don't know, Ashim and Satish, tell me whether the artery itself is causing the conductive loss or there is an autosclerosis. I
Yeah,
don't know.
both have been reported. Artery itself can immobilize the
In this
stapedial
case, yeah.
movement,
So this is my technique of drilling the posterior crus. I think so. Yeah.
weakening the posterior crus.
Yeah, drilling and weakening, or maybe I'm gone straight to the. I've already drilled a part of the posterior crus, and now I'm making a hole. Yeah,
This is a skitter or this is a
this is a
Microdrill,
regular
microdrill,
micromotor
micromotor.
yeah.
because
Somebody
their
asked.
their bursts are more robust and more predictable than the skitter bursts.
Yes,
I
sir.
have the skitter, but I use it only in situations
This
where
microdrill is always good.
Somebody was asking if can we use marathon drill. I think we can use it because we are using for the
you
implant.
can use
So we
it.
are we are using for the cochleostomy. Why not for this thing?
Yeah. The only challenge here is again the anterior crus. So in this case, I had done a decapitation. After doing this, I put a pistol and I only took out the head of the stapes.
Yes. So decapitation is another technique. There are many techniques. Let me put
But
this
I
one.
gave up it, Satish. I did it for a year or two. No real benefit.
That is Takashi's technique. In the literature also, people started, but now they have given up. So this is an overview of the various techniques people are using to address this issue, autosclerosis. Earlier started with a stapedectomy. In the present context, I don't find any indication for stapedectomy as such, except in certain situations of tympanosclerotic, fixation, where a platinectomy and you don't have the malleus as well as the incus removed during the previous stage. In that situation, you can use a TORP directly from the foot plate to the tympanic membrane with the cartilage interposed. Stapedectomy is the regular standard one. The reverse we have discussed. Decapitation is what Ashish is saying. In that situation, you put a piston, you don't need to remove the entire suprastructure. You can just remove the neck of the lenticular process and the neck of the stapes.
No, keep the lenticular process intact.
Keep the only
Just
neck.
remove the head. Disarticulate the incudostapedial joint and only remove the head of the stapes.
Head of the stapes, or you can interpose some silastic or something as well to prevent refixation.
Yeah, and interpose silastic.
Yes.
Yeah.
Laser stamp we have discussed, posterior crescent perichondrium discussed, tangent preservation no more, fenestration no more, middle implant no more. Lasers we have already discussed. The next important issue to be discussed, our next case is also ready.
I think what I have one video of the vein graft.
Yes. Is Ashim running? Who is running?
This is not running, so I just got from my laptop.
Okay. Please.
You use the vein, Rajeev?
Sometimes, like this case, when it was subluxated, I had to take out the foot plate. Then, in that case, I had to use it.
Okay.
So, just how to take it a little bit.
You ready?
Can you see it?
उसको बोलना वीडियो दिखाए.
Yeah, we can see it very well.
दिखा मेरे को.
So, is it visible over there or not?
It's visible. Yeah.
Visible.
We
We're
are
getting
seeing.
it. We're getting it.
Yeah, okay. No, so, because otherwise.
Fix है ना?
This is the vein harvesting here.
Centralize.
The old recording actually.
लड्डू बोला आशिम को फोन कर. कहाँ चला जाता हूँ?
So it's not a very tough job because I take from the non-dominating hand, like left hand usually, wrist actually, and so it's just take out almost 4 to 5 millimeter length and take it out. And how to prepare? Main thing is how to prepare it. That is a more
अरे यार वो
important
है ही
thing.
नहीं क्या डिस्कनेक्ट हो गया
That is more technical point. Just make it a round one, either needle or any suction tip, and take out the extra tissue from the vein.
Yeah.
And it was a case where the foot player I was totally out, and
There in the third circle we see it. Yeah.
yeah. In fact, it was a revision case. Some primary surgeon that something was there that he had to take out the piston, and along the piston the foot plate came out. So I had to put the graft, and I think just point Dr. Ashim just told regarding the if I put a graft and the piston, the chance of perilymph means leak are there afterward. So that thing I thought at this point cartilage could have been a better option, and instead of
A piston.
putting cartilage on this vein graft, like he showed just now. So I just kept it was a nice, and hearing wise absolutely fine. He is doing very good.
Very good. Congratulations.
Fantastic.
So I just put a piston, but I think now I am thinking that cartilage could have been a better option, as you told just now.
That's more for the long term, so it's okay. You can watch.
No, if you want, I can share the cartilage.
Yeah, that's because some net issue was. That's why I just took out from my left. I just made this slide just now.
It's very important. What you have said is very important. One is what you have demonstrated is that you should not use gauze for hemostasis on the hand or anything like that.
Yeah.
And the harvesting has been precise. What you did was correct, and it's very important for the intima to face the surgeon, adventitia to face the vestibule, and that is sacred. You know that it should not be reversed.
Yeah, sir.
Hello.
So just since your net was not working, that's why I just made this slide just now.
Perfect.
Hello.
Yes. Yes.
Am I audible?
Yeah,
Very audible, sir.
Ashish, the next case I can think of doing a reverse stepidotomy by regular instrument without laser.
Okay.
There are a lot of requisitions to show without laser as well.
Yes.
So and you know, I always have a insecurity in the mind when I'm doing without laser. So in case anything I find not going good, I will convert to laser. Okay?
Yes,
but this looks like a good case for the reverse stepidotomy. And the case
this year in Agra, we kept him handicapped. We didn't keep any laser, didn't keep anything. He had to use perforated for the staplectomy. And he did wonderful.
So I think, do I go ahead with the surgery, or are we taking any questions before?
Surgery.
If you are ready with the surgery, go ahead.
Okay. Connect.
I don't know how practical it is, but I think it's time when every city should have one person at least or few people coming together and investing in a laser, if not everybody. I think that's sort of a practice and that sort of a cooperation, which is what Europe did. Like the clinic and all.
बोल के तो हटाया करो यार, बोल के तो हटाया करो.
Hello Satish, hi.
Hello.
चालू करो.
Are we starting surgery, or do you want to show a clip or something, Ashish?
Drill.
You can show. I think Satish is having some technical difficulty there.
Okay, fine. So I'm going to share the screen for a moment. I'll just show a cartilage.
मैंने भी देखा है. अरे हो गया.
Okay, can you see?
Hello?
Yeah,
Yes, boss. Am I audible?
you are audible, but I am screen sharing, so I will stop my screen sharing.
Okay, you continue. Hello?
Do you want me to continue?
Yeah, what are you showing?
Cartilage on vein.
Cartilage on. Show. I will
Okay.
do later.
Am I visible?
Yes, yes.
Yeah, very
Yes,
clear.
yes.
Okay, fine. So now this is a kind of tympanosclerosis kind of case with a concomitant otosclerotic fixation. So you can see that this cartilage is the incus is not very healthy, but it is fully mobile. This is the second stage. We always mobilize the malleus and incus in triple ossicular fixation in the first stage. At the second stage, we go ahead with the stapedotomy. You see, it's extremely mobile. Now I'm using
Drilling the posterior crus.
I'm removing the posterior crus. I'm using the drill for that. Once the entire superstructure comes out,
The crura or along with the foot plate?
no. The foot plate is intact. You can see that. Then I would measure it, and with the measuring gauge, make a Y-shaped cartilage. The midpoint of the slit in the Y. Can you see the slit in the Y?
So you are placing the cartilage over the foot plate.
Over the foot plate, but it's a fixed foot plate, mind you.
And from foot plate to incus.
Yes, from foot plate to incus. Then once I have fit it in position,
No,
just observe.
but once you have a foot plate and incus, why not a piston?
Because this foot plate is partially mobile. So observe this.
And it is a...
And it's a tympanosclerotic partially mobile foot plate. So I am putting the cartilage first on the foot plate to measure it in situ. Once I measure it in situ, I know that the cartilage is not too long. Okay? So this is the precise length. You can see that there is no chance of a perilymphatic leak because of the dimensions of the cartilage.
Okay, good.
Okay. Now
I
will remove this and remove the posterior 2/5 of the foot plate. I'm just smoothing the edge. There are a lot of discussions about drilling on an open oval window. There is no problem if you are slow enough with your burr.
See the way he's using the drill. He's not putting any pressure. He's not sucking anything over it.
Yeah. Now see the anteriorly, it's so hard and fixed. There is no reason to remove it. Now I'm measuring the diameter of the fenestra. You can see that this is a 1 millimeter fenestra.
That is the measuring disc that they use always.
AVR sir had gifted me this measuring disc once.
Yeah, he's gifted me also.
Never used. Okay, then you put the vein in position. And perfect in length.
So first vein graft and then this.
Yes, and now this fits snugly.
Now my point is, you have a foot plate, you have a fenestra, maybe partial removal, you have a vein graft over it with the incus there. Why not to use a piston in all these surroundings?
One is that I was not able to make a discrete 0.6 millimeter.
So what you have covered with the, so what is still you have covered with a vein graft?
No, second point is more important.
The second point is that the incus was of a very poor quality. The incus would have given way in the next couple of years or so. So I would not take that risk.
Okay. Had there not been any incus, what would you do?
I would have done a malleus stapedotomy.
Okay, here the malleus was intact, no?
Yeah,
good.
But then he could not have used the cartilage.
Yeah, well, for me, this was more physiological and it works extremely well in my hands. I get
So-
a very good airborne gap closure. So then for me, a triple ossicle assembly is always better than a two ossicle assembly.
Okay. And sometimes I have seen you have advocated making a neo-malleus and then put a piston through it.
Yes, I've done that on many occasions.
I have done that too early in my enthusiastic
So,
days.
so
No,
can,
no.
can you explain a little bit in brief?
See, the neo-malleus is something that Professor Fish prescribed to way back in the early 2000s. In that, you shove the neo-malleus in two slits of the tympanic membrane graft and then do a standard tympanoplasty procedure. And at a second stage, make a connection between the neo-malleus, which is a titanium product, it's made by Kurz, to the foot plate. I've done a few of those, not very, very exciting.
I have used a homoossicle to do that, and then put the piston on the homoossicle, but a titanium piston at that time.
Yeah.
But those are more of the to-do list. You just tick mark. These
Yeah.
are not your standard care procedures at all. It's just that you want to feel more complete and whatever.
It's not a standard of care at all. Absolutely. Satish?
Yes.
Surgery?
Yeah, absolutely.
Yeah.
Are you getting the intraoperative picture?
Yes,
Microscopic?
I am. Absolutely.
Now see in contrast to the previous two cases.
Yeah.
Now very nice. You already have a
Okay.
foot plate on platter.
This
Yes.
is your junior's case now.
Look. So it is a cakewalk for the laser, I would say.
Yes.
Ideally
But now doing anything else is making your life difficult. For me,
do a proper laser.
for laser, it's a cakewalk. I tell you, you don't have to do anything much. And now see the exposure given to me by Dr. Ayub, my colleague here. Ayub is an extremely good pathologist.
Master is.
He is a gifted guy and a great person.
Yeah.
Ayub, very warm regards from me.
Yeah, and Ayub has been with me since 2001.
Yes.
He has done more than 20,000 ear surgeries here. Patla.
Ajuba.
Now see, the things are so favorable. We have such a great exposure of the foot plate,
Yes, yes.
and that's why.
90% scenario.
Pardon?
This is the 90% scenario where
Yeah, that's
everything, yeah.
that's why people don't want to discuss much about the stapes.
Yeah.
Now my first step would be to make fenestra. Okay, let's go reverse. Microdrill.
Arey karo laser karo, don't worry.
Huh?
We know you can use your laser.
Laser is ultimate boss. लंबी वाली थे लंबा वाला था.
So I have the KTP fiber laser, and until CO2 came with the fiber, I used to call CO2 the Karna and the KTP the Arjuna. Karna means when you want it the most, that is when it fails you. When the anatomy is crowded, when you have a Dyson facial, you cannot use a beam laser. So therefore I use the guided, because you cannot bend a beam, but you could bend a fiber. But now the CO2 guys also have a fiber. So. And see, in this case, you can see the base of the anterior crura. Just
मोटी नहीं
beyond.
पतली चाहिए भरतू हुई 0.6 mm.
They forgotten. They only know the settings of the CO2 laser now.
Pardon?
They forgotten the burr sizes for drilling the foot
They
plate.
only know the CO2 set.
Yeah, it's been long I have done this.
Also, there are, I think, if I can take a few names who are brilliant surgeons, just like he mentioned, Ayub, the other friends of ours in the group, Dr. Vivek Jadhav, a brilliant surgeon overall.
Yes.
Arvind Patil, Amol Deshpande,
Maruti.
Maruti Kalyankar, master In
Yeah.
fact, he has shared some slides and videos with us. But if and when we get,
ये आ रहा है बीच में यार.
Boss, laser kadal.
That
Arvind like Satish is a gadget addict.
देना क्या हुआ? हाँ दे. Just a minute, boss. We'll do with the
Laser करो.
no laser तो कभी भी कर देंगे, but let's try.
We've seen you deal with the carotid. इसमें क्या दिखाएगा तू? क्या what show off?
Could you see the fenestra?
Yes.
Beautiful. I thought it was better.
बंद
than
कर
the
दिया
laser.
यार.
Huh?
Pardon?
I thought it was better than the laser.
See the fenestra. सबसे पतला वाला देना. I am showing the reverse one now.
Yeah.
पतला दे यार.
So you
Why
should use a suction cannula, definitely not lesser than 24, 25 or
yeah,
26.
that's what I am asking.
Yeah, I understood. That's why I'm making the point. Yeah, and go around. Sometimes if it's a problem, then keep a gel foam and suck on the gel foam. So it's an indirect suction, not on the foot plate, on the sides. Yeah.
Now, give me the
Beautiful.
measuring.
Now, Ashim, I want your thing. There's a tiny bit of a very thin foot plate or a flap that is going inside.
Yes.
What's your take on that?
I would remove it.
You would remove it?
Yes. What about you,
What?
Ashish?
Can you repeat what?
There is
The
a little
small
anterior inferiorly, there is a little bit of a tag, a very thinned out, like a bone dust, which is stuck to the mucosal. I don't know why your thing is becoming smaller for me. I can see Ashim bigger and the surgical film.
Pin the video.
In the video.
Pin the video means what?
The video will be bigger. उसको बोल दे video को बड़ा रख दे.
Now I can see.
Okay. Now see the fenestra. Now to the piston. 4.5.
Okay.
Now I'm using the piston first,
Yes.
and then we'll remove the rest of the things. This I could do because of this blue foot plate, which is extremely good in terms of fixation. Give me the straight pick there.
You see the anterior inferior border of the fenestra?
Very well.
Yeah, it's all good. See this everywhere. And now I'm using my 0.4 piston, and then I will do the rest of the procedure steps later. This way, the advantage I have already mentioned, 3 advantages of this. Number 1, I could make the fenestra keeping the entire ichthyostapidial arch intact without any mobilization of the foot plate. Second thing, I can put the piston, and if you are crimping using Teflon, crimp it, keeping the entire arch intact, so least possibility of malleoinguinal dislocation. And third is, when you remove the suprastructures, see this
Yep.
video game.
The laser is a video game.
This piston also, see this, my one end, I can see the shaft of the piston going to the,
Into the fenestra.
yes, and just
जोर लगा के.
no jor.
No Joe. What?
See this,
Yeah.
the middle slot is taking it so easily.
Yeah.
See my lower end.
Yeah.
And now the reverse step is going to be scissors. No laser.
So now if you cut the stapedia, there will be some bleeding that will happen. Now when you...
Now, okay, section there. I was telling that time about the blood supply of the incus. Can you see the vessels along the
Stapedius.
Yes.
Yeah.
These are one of the principal blood supply to the incus, and that is taken off, and majority of the time who are preserving the tendon, I believe this is the biggest advantage, keeping the blood supply to the long process intact.
But that is precisely why I like to preserve the tendon.
Yes.
Many
Yeah, that's
cases.
the only reason to preserve the vascular
सीधा दे वो सही नहीं है
advantage.
लंबी.
Absolutely.
So that is the best reason. Now number two, this step is gets the blood supply. See the posterior crust behind, deep to this,
Yeah.
and some vessels over it. Similarly, some vessels over the anterior crust ascending to the neck. Some vessels along the posterior crust, some along the this tendon. The vessels along the tendon are the branches of the stylomastoid artery. Vessels along the anterior and the posterior crust are the branches of anterior tympanic artery that is coming from the internal maxillary. And
Yes.
then the vessels running along the core of the incus, long process, are coming from above, and all these make the plexus at the level of the incutostapedial joint. So once you disarticulate, everything goes off.
There was a time in
See now?
history. I don't know. Yeah.
Can you see?
Yeah.
The tendon I have cut. Now is a very important movement.
I think you should take a finer thing. You're going to disarticulate. No? Yeah. Okay. Did you disarticulate the joint?
Oh, forgot.
Forgot. No.
But then, that's why.
Now this is what Ashi was saying. He does this ulta when he makes the Shirshasan from the stapes, residue of the stapes, when the
That is when it's thinned out. When it's
thinned
not
out,
thinned
yeah.
out.
See, I am not used to this. Doing after long.
Long time.
Remove this. See this?
Yeah.
Perfect.
And the surgery
There's
done.
always
Blood,
a blanket of mucosa which goes over the arch.
The
If you look
blood,
for
blood.
it, you can see it and push it back under the oval window niche.
See now? My
Yeah.
piston in place. This is the tendon, absolutely perfect. Oh, sorry, the chordae tympani. This is the posterior crust. Stump of it.
Yep.
Man of the match. And surgery done.
Super.
Suppose the suprachal fell down in the hypotympanum or in the tube, and suppose you cannot find it out, then what you will do? You leave it
Leave
inside
it.
or
Leave it. Many of the problems have solution. Leave it. Suction. And this is what the blood we pour. एक size बढ़ा दे यार. This is the blood in the oval window. See that? That's it. So this was classical fish reverse stepidotomy. Those who are not having laser and get this favorable
This is
situation,
the safest way of doing it. You have to only
yeah,
we
but
can-
only in favorable situation. And if it is not so favorable, what Ashish has mentioned, you make it favorable by drilling the posterior crust. Acquire more space. It is the matter of the space, whether you can do it or not. So by weakening the posterior crust, you can further make your life easy. You can carry out this procedure in many of the situations.
I call it the zebra crossing.
बंद कर देना,
technique.
बंद कर देना.
Safest one to cross the road.
Pardon. So it didn't take long. Once you have a favorable situation, for laser this would have been straight away like this. ये जोड़ना.
Yeah.
So now, before we go to the question, first do we go to the question, then or I will start this important issue of revision stepidotomy. Sanjay sir, सो गए.
hello.
Sanjay is somewhere else. Yeah.
अच्छा, Pachauri boss, any questions?
Questions, as such, no questions, because last point was that I am asking all these points actually been asked by many people.
So
So I think questions.
we can move on to the next important issue, that is revision stepidotomy.
Yes.
Out of the most challenging things in the stapes surgery, one of them is the revision surgery. And this slide is
Hello,
very
Dr.
important because
Yeah,
we
hi.
need to.
we need to know when to do revisions, when not to do. Because there are by and large certain indications for revisions. Like if the patient and I tell you the best candidate for the revision is one who had undergone Stapes surgery, had good result, improved the hearing, and afterwards developed conductive hearing loss. Is the ideal candidate for revision. Ideal. Other indications are patient having vertigo, patient having distortion in sound post-operatively, and very rarely for the patients having sensorineural loss. Yes, there are indications for that, even for the SNHL, even though the hearing is not going to improve. But the best candidate is one who had improvement with the previous surgery and then further developed conductive hearing loss. That is the ideal one. So, there are certain issues we are going to discuss about the use of laser. You saw the use of laser since morning. Believe me, the biggest use of laser is in revision.
Yes.
More important than a primary.
Agreed.
If I don't have a laser for the revisions and I need to work at the oval window, I will better abandon. Without laser working in the revision situation at the oval window adhesions, it is something like inviting problem. And secondly, when not to revise, there are situations like patients who have been operated by an experienced surgeon. You know, when we take up revision cases, I always would like to talk to the previous surgeon, whoever he is, to know the real-time difficulty he has faced, if he has faced during the previous surgery. Because sometimes you don't have adequate notes, and this is one of the indications when not to revise, when a person who is very experienced has done with a good complete notes, with a good satisfactory intraoperative findings and all, and yet patient is not having improvement, then you have to think twice before revision. Like for example, if somebody is operated by Ashim Desai and come to me for revision, I will think twice. Because now I told you there are certain things which are beyond your control in terms of giving results.
Factors come into play. Yeah.
Yes. And second is, in situations like in the previous findings, if the patient had a huge obliterative autosclerosis, and now again coming back for the revisions, again I have to think twice. Because those are the patients which are otherwise most difficult to treat. And third is the pure SNHL cases, because the hearing anyway, even if you revise, the sensorineural component is not going to improve. The only indication in those situations where sensorineural component is and you revise is when there are other things associated like granuloma, post-operative granuloma giving this distortion of the sound and giving vertigo and all that along with.
So can we differ? Can I get Ashim's opinion on a revision in an obliterative case? Is it not that it reoccludes and it just becomes like a primary?
It can reocclude. It can reocclude.
Among the things that Satish listed, I would not, a revision for an obliterative would not deter me.
Yeah, I would not mind going ahead with revision for an obliterative focus. Most of these times, what would have happened is that because generally people don't saucerize very well.
Yeah, they sort of tunnel it in. Yeah.
There's a funnel inside.
No, I am asking you, boss, you have done an obliterative focus. You have done. And patient coming back after 2 years with the same obliterative focus, would you revise?
Boss, if I do a CT scan, I find obliteration, I will definitely revise.
See, why my reservation is, obliterative is something you cannot always expect a good result like, the blue foot plate, number one. And number two, revision at the same time you can't expect as good result as a primary one. Having both the factors together, a revision and obliterative, and that too done earlier in the best hands, is something you have to think twice.
And one more factor is consider the opposite side also.
Yes.
That's another thing.
So,
but obliterative is always bilateral, no? If it's a unilateral conductive loss, by rule it's never obliterative.
But what is the extent of the loss on the opposite side?
That is also a determining factor.
You would be forced to operate on this side. Or you'd have to end up with a hearing aid or Baha or whatever.
Okay.
Yes.
Okay, sorry, Satish, continue.
So once it comes to revision, before planning and having said that you are going to revise, we must have a CT scan. Because in revisions, we get variety of findings, These are the common situations you come across when you explore. And majority of these things can be picked up by a good CT scan. And for that, that makes you more, ready to handle the situation once you are revising something. Revision stapes is one of the most difficult surgery, believe me, in otology. Most challenging situation you come across are in the revision surgery. And the first revision, if you compare with the second and third revision, is even more difficult. So CT scan is must, and once you come across any of these findings, you have to handle and address at the same time. Out of them, the biggest issue is at the lower end. See, at the upper end you can find incus necrosis, maybe partial, total, because of the fixed piston below can keep on hitting the incus and can lead to necrosis. A loose crimp piston can keep on hitting, can give incus necrosis. Incus dislocation, a dislocation of the foot plate from the piston from the foot plate also. There are a lot of fibrosis, fibrous tracts, narrow oval window area, piston long, so many regions here listed you can see. Out of them, the most problematic ones are when there is a lot of fibrosis in the low oval window area and the piston is going through that. And more on that, if the previous surgeon has used some oval window seal onto it, that is something which makes your life more difficult. Yeah. The reason is, in order to remove the piston with the oval window seal in place because of the previous surgery, whatever was done, it invites adhesions to the vestibular structures inside, and if you try to remove the piston, can be a disaster. So in these situations, laser is amazing, is most useful, and in a lower wattage defocus laser, you have to vaporize all those adhesions one by one around the piston. In the low wattage, around the piston completely to delineate your foot plate, and then you remove the piston. If you try to otherwise without delineating foot plate and try to pull the piston, it can lead to a disaster with a damage to the vestibular and organ receptors and can lead to a permanent sensorineural hearing loss.
Because here the enemy is, if you get oozing, if you get blood, you cannot use gel foam adrenaline.
Yes.
That's a complete no-no. So what you would use in a primary, the thing to do hemostasis without laser.
Here bleeding is a big chaos then. Big chaos. So without doing a laser, without using a laser, you cannot justify dividing all the fibrous tracts.
So the precision cannot be achieved without the laser.
Cannot be. And if you try to pull the piston with so much of fibrosis at the lower end, it's a disaster. You are going to end up complete hearing loss.
Then you cannot proceed with doing the job on the foot plate. Getting the piston out is not a problem.
Yeah, you don't know what to do next.
What to do next?
Yeah,
right?
because many a times when you remove the, when you vaporize this, you get to know the exact dimension of the fenestration done earlier. If there had been obliteration completely of the previous fenestration, if the piston was going in the foot plate inside or not, you never know. So all these things are obvious once you vaporize all the adhesions around the piston.
And in fact, the sequence is even before you remove the piston, try and get maximum of the adhesions vaporized.
Yeah.
So that you can assess the lower end of the piston much better.
Yeah. Now in this situation, if the previous surgeon had used the Teflon piston, is an advantage. But if the previous surgeon used a metallic piston, again a big problem. Because any single fire on the metallic piston is going to transmit the fire energy to the vestibule. If it is a Teflon, it melts. It doesn't transfer the sound energy so easily. Though even you are using a low wattage, but if it is a Teflon, it is an advantage. Here something, if you are using a metallic piston, is a disadvantage. This is one clear disadvantage over here. Ashim, you have an experience of 1200 revision stapes.
900.
900. Can you point out what is the commonest situation you have found?
The commonest situations are the top two, incus necrosis and dislocation of the lower end of the piston. The third commonest is the narrow stapedotomy.
Okay. Now, for the audience, information, and there cannot be a better person than you to tell. If there is incus necrosis you have found on revision, quickly we have to answer all these situations. If there is an incus necrosis, what would you do?
Okay, so let's start with.
Ashish, we need your comment if you do something different.
Yeah, I will come in. Yeah.
So we'll start from the distal end more proximally. Now, if you have a slight necrosis of the lenticular process and the piston has slipped off, the best option is to slip it back on and put a Y-shaped cartilage from the inferior annulus up to the edge of the incus. Now,
Okay, can you repeat from the incus to the inferior annulus?
I'll show a diagram in 2 minutes.
Okay, I got your point. From the inferior annulus to incus.
Yes, to the incus.
And then?
Now that is when there is thinning and slight necrosis of the lenticular process.
Okay, and
now
then?
You have more necrosis. If the long process is partially or totally necrosed, then obviously you need to do a Malleus stapedotomy.
Okay, can I interrupt?
Yes,
when you put a cartilage from the inferior annulus to the incus, what you do afterwards? Use a piston?
Use the same piston, put it back on.
Okay, and secondly,
And
don't
this cartilage will hold that piston in place.
do you ever think of lengthening the incus by using bone cement rather than Malleus stapedotomy directly?
You can do that if there is partial. If there's only a slight amount, you can do that.
So I will come in instead of so the issue is if the lenticular process is necrosed, can we offer an extra stability to the piston, to the loop of the piston, so it does not slip away? That is the surgical situation we have. So what I do is I actually use the ear-lobule fat and I go across from the long process of the incus across the loop towards the lenticular process, and I sort of promote fibrosis there.
Fair enough.
Are you getting it,
Yes.
Satish?
After putting the piston?
After putting the piston, yeah.
Okay.
So because there is no lenticular process there on the.
But
on the
Ashish, I have seen you use bone this thing.
And so the bone cement also, of course, yeah. But this is what I used to do, and there have been times when I have used either a fascia or a perichondrium like a strip, which goes and sort of wraps some part of it superiorly to basically make some connection, a fibrous connection between the loop and the long process of incus. This is what I
Do
used to
that
do.
for a thin incus. If
Bone cement has actually taken away now. That challenge is no more there.
Okay. So now coming to the second situation, dislocation of the foot of the piston. Your piston is out of the oval window.
Yeah, this is a short piston. That is what led to this process.
One thing I'll always mention, whatever you do at the lower oval window in the revision situation, you always advocate a vein graft. You agreed or not?
most of the times, yes.
In revisions. Yes.
99% of the time.
In a situation like the number 2, if the piston, this was a short piston, therefore it came out with the perpendicular movement. It has come and rested on the edge of the fenestra. I would simply
you don't need.
No, it's not always the short piston, Ashish. Sometimes even an adequate length piston, which is placed in an angular way, not straight piston, it comes to the edge of the foot plate and ultimately, stuck to it.
Unless it is short, it cannot come to the edge. That is why that hanging test is important in Ashim's thing.
Yeah.
It has to be at the, not in the, so the diameter of the fenestra is also important. If the diameter is too big, then it can, with the perpendicular action, come to the edge.
So straight away your answer is you will just clear the area and put a longer piston.
Clear the area.
Or just adequate size piston, whatever it is.
Correct.
Okay, fibrous text we have already discussed. We will vaporize with a laser.
It's
Narrow.
the equivalent of a debrider on a nasal polyp. Yeah.
I'm going to interrupt here. Going back to your point of dislocation of the end of the piston, assuming that you put a slightly longer piston, Ashish, would you desecrate the endosteal membrane or would you put it on top of the endosteal membrane?
So it's always a dilemma, and I always end up breaking the endosteal membrane and having my own surgical trauma for a predictability. I don't know why, but I always keep on, and I remember the discussion I've had with ABR Desai sir, where actually the endosteal membrane bulges out. And I
Yeah,
think it was in Pune, BJ Medical College,
yeah.
that he was being
That is
so
true,
treated.
Ashish.
And I think 3.5 millimeter piston length he put on a bulged endosteal membrane. I remember that.
Yeah,
But
that
I
is true
also
because the pressure inside the vestibule is always more than the middle ear.
That
middle
is
ear,
where we come in with the cartilage, which is a larger diameter. If
So
it's a
if you
very
use
much
the
bulging,
piston, if you use the piston, it can perforate or it will perforate.
it will
yeah.
perforate.
Yeah. So I actually perforate it and I allow a new one to form. I mean, if it
So that is right in the when the fenestra is appropriate size. But if it's a subtotal platinectomy, my
ah,
general suggestion would be to use a cartilage on top of the endosteal membrane.
okay. So that
Okay.
And the
those
second
are
thing,
words of experience and
So
wisdom. Yeah.
if you have
and
done
the second suggestion
the
would be that before we go through that endosteal membrane, if
yeah.
possible, you use a disc to press on the endosteal membrane, because when the endosteal membrane is intact, you will get a round window reflex.
Ah, okay.
So
So that, because sometimes what happens, bone dust causes multiple little partitions forming under the foot plate.
yes. So bottom line is when there is a platinectomy or large defect, it is better to avoid using a piston and use a cartilage to prevent future problems.
If it's too large, yes. If it's
Yes.
a subtotal platinectomy or platinectomy,
Now
yes.
situation piston too long a piston you have to remove, put a vein graft and put a next piston of
Absolutely.
adequate size. Perilim fistula, anything. Okay, can I ask one thing? How do you suspect post-operative perilim fistula?
When the bone conduction of the operated ear is poorer than the bone conduction of the unoperated ear after an initially good result.
So that could be because of many reasons.
No, but this is the most important reason.
Many of these patients I have seen, they have a typical, complaint of distortion of the sound.
Yeah, see, I'm not looking at the classical indications.
Yeah.
Classical indication of post-op vertigo, Tullio phenomenon, distortion of sound, poor word discrimination scores, or sudden loss of hearing, a loss of hearing after barotrauma. All of these are indicators. But I'm talking about the subtle indicator of really nothing except a slow, gradual deterioration of the bone conduction of the operated ear vis-a-vis the unoperated ear.
Yeah. And how often it is fluctuating?
It does fluctuate. It is I would say at least 25% of cases it fluctuates.
And we have seen a patient who was operated, for a Stapes 5 years back somewhere and came with a fistula. So it can
How was
happen
the hearing initially?
Pardon?
How was the hearing initially?
Initially was good. Had a deterioration, fluctuation, and was a classical fistula.
Long piston.
Yes. So it can happen anytime.
Yeah.
Your
Now-
experience with bone dust, because sometimes we cryptostomies use a drill at the time of curating that attic area, and then bone dust goes inside, and if we don't wash it regularly, clearly, then after sometimes, or in second, it's a recent case, have you found any evidence of that bone dust?
Not really. Not really. Not for the.
I tell you one thing,
But of the foot plate, yes.
boss, regarding the bone dust, I tell you,
Yeah.
Yeah.
if the bone dust goes inside or your any instrumentation which if traumatize the vestibular end organs, the next problem which is imminent is the BPPV. That is not uncommon. The reason is all this bone dust settles down in the vestibule, and the most dependent part of the vestibule and the vestibular system is the posterior canal. It settles down in the posterior canal. Utricle, if injured, the otoconia released from the macula of the utricle settle down in the posterior canal, and ultimately they give rise to BPPV. It's not uncommon. So in any given situation, if there is trauma happens to occur to the vestibule, you can expect the patient having vestibular disorder, and BPPV is amongst them the commonest one. Now coming to the next situation, incurs this.
But no, to answer then, does he need to be cleaning the bone dust that is generated by drilling the foot plate?
No,
is that
no.
your question?
No, nothing is required to be done. Nothing is actually required to be done. The
Because
more you
like he
try
said, the
to,
pressure in the vestibule is
yes, leave it. If you try to fiddle out anything there, you are trying to
more
worsen the
dangerous.
situation. Yeah.
Yeah.
Now that this is an important incus displacement, can I ask one thing? In the primary situation, like when I was operating, if somebody happens to dislocate the incus, what is the primary thing you would do there? What is would be the overall your scenario management?
Ashish, you want to take that?
No, you take that, yeah.
Okay, fine. So there are two aspects of incus displacement. One is subluxation of the medial incudal joint without much displacement, and the second one is a very gross displacement. Now, in both these situations, you will have a place situation where the superstructure has yet been disturbed or been undisturbed. Now, if there is a minor subluxation and the entire superstructure is undisturbed, you can continue with your surgery as planned, leaving the superstructure intact and doing a reverse tapedotomy as far as possible. If there is no superstructure and there is a gross displacement, the better thing would be to put a cartilage or a piston connection from the repositioned incus, put it back in its normal anatomic position, step out, put a piece of silastic separating the long process from the drum without entering the foot plate, and then enter the oval window at a second stage.
Second stage after?
After 6 months.
So you will expect this joint to be back
there will
in.
be a pseudoarthrosis. Many times I've seen a pseudoarthrosis. I've seen cases done elsewhere who have been referred to me.
Or if in the primary situation, if it is completely dislocated,
then you would need
to still it will come to, still you will be able to place back into the proper place?
If the superstructure is intact, absolutely.
Okay.
But if the superstructure is gone, then I would go ahead and do a Malleus tapedotomy.
At the same sitting?
At the same sitting.
Same thing happened with me, I think 2-3 years back. I was doing it somehow with the curate that got dislocated and incus was totally dislocated. So superstructure was intact. So at that time I tried, I would say I waited for some time, and I waited for 3 months. And I kept that incus on the superstructure, and after 3 months it was almost in the normal anatomical position.
Yes,
now,
it does.
One suggestion is to put a small piece of silastic, very thin silastic between the long process and the drum, so that the drum does not pull away the incus.
What is your protocol?
Gel foam around the incudostapedial joint and the incudomalleolar joint.
Yes.
Soaked in blood.
What is your protocol for not revising patient until certain period of time? Like you don't revise within 6 weeks, 6 months, 1 year.
For what? For a routine?
Revision surgery.
For revision surgery, minimum 6 months.
Minimum 6 months. And before that, we should allow it to be like this to heal or whatever.
No. Now again, if you are getting progressive sensory neural hearing loss, so on and so forth.
This is for conductive loss.
Pure conductive, I would wait for 6 months for everything to settle.
So the tissue remodeling, it is just that much.
Have you ever seen granuloma?
Honestly, I have not seen an oval window.
I have not seen, Satish. I think it was a fiction generated by the previous surgeons when things were not as sophisticated. You know, all that powder or glove powder, granuloma, foreign body we don't really see. They were blaming something and imagining it to be a.
But it has been reported to have a granulomatous lesion at the foot plate. And there are many, there are many reasons people are giving. Not only the powder or gel form or anything, but even a persistent perilimb fistula can result into mucosal reaction, autoimmune reaction, many other things. But granulomas have been definitely reported. We have not seen, that is different. But how come there are so many cases reported? So many.
They used to, the immediate post-op catastrophe, they used to blame it on a foreign body granuloma, no? From what I know from the history.
If you don't understand anything, then could be granuloma.
Yeah.
Something like that.
Yeah.
So, coming to the Malleus tapedotomy, if you are you using that ball valve piston now?
Absolutely.
That is amazing. Now question number 1, what according to you is the best site for fixation of the piston on the Malleus?
Although Fish recommends fitting At the distal to the lateral process of the malleus, I prefer fitting it at the neck.
Neck. Yeah.
Yes. But now
Me
another thing
also.
I do is I drill the neck a little bit to
Yes,
thin it
yes.
out.
Yes. Neck is, to me also, the neck looks better. You can make a, using a diamond drill, you can make a fissure over there and you can pick your piston.
Yes.
Ashish, you're saying anything?
I have done malleus stapedotomies, but I would not like to do it anymore. I just feel that the precision, the whole obsession with fit and size and length that we are with the incus stapedotomy, all that goes for a toss in a malleus stapedotomy. All that we respect and worship here, it goes away. And then the basic thing about the movement that you said in nanometers to microns, the whole dynamics changes. And in today's day, when everybody is flying all the time, I sort of think that a malleus stapedotomy in my hands, I think I should not be doing. Technically, I can do the fenestra, I can fit it, but I just don't know the perfection. I don't know what is the right way to measure the length, what is the right angle at which it should be. These are my reservations now.
Ashim.
I'm completely in agreement with you, Ashish, because our obsession with measurement is such. But having said that, when you are left with no other choice, the neck, the attachment at the neck is better than the attachment at the manubrium.
That I agree, because I think
because of the lesser movement.
It is well protected. It's not direct.
No, the range of motion is less.
The movement is very small.
Yeah. At the the manubrium of the malleus, the range of motion is sometimes more than a millimeter. And that can be hazardous.
The best way to measure is to put it in position before the fenestration.
Yeah, that ball valve joint is amazing. Even if you once you put the piston with a
to fix it to the neck, keep it there, move it aside, and then make the fenestra and then move it.
That problem is over if you are using a ball valve joint piston. Even you anchor to the malleus first or put to the fenestra, still you can change the angulation height of the piston any point of time. That's the beauty of that piston. Now, coming to the situation of second year, like you asked about the findings we have discussed, Ashish, you had a booklet earlier with ABR Desai had given me once, mentioning that in the second year you will not do the same technique or you will do something else. What is that idea in the second year?
That was the original method of thinking when we did a direct piston on 1 year. Dad always thought that to do something more physiological, like doing a posterior cross and perichondria.
But why? See, why is the patient coming to you for second year once he is happy with the first year?
Because he is damn happy with the first year.
And you have already given enough time of 2 years or so for the second year.
Correct.
So
so we have changed now. So now, if because we do the cost technique on one side, we definitely will go ahead and do the other year without reservation 1 year down the road.
So, what is your recommendation once somebody has undergone tympanoplasty, had associated atherosclerosis? How long would you wait to consider for the Stapes surgery?
1 year. See, now if it's bilateral atherosclerosis, I'd operate on the opposite side for the Stapes. But if both, if there is only one-sided hearing loss, atherosclerosis with CSOM, I would wait for about 9 months to a year before I do the Stapes surgery.
Great. So that is important message. Sanjay sir, any questions before we move ahead?
Having few questions.
Yes, please.
This is from Dr. Girish. He is having so many questions. Let me have one by one.
You take the issues which we have not discussed now.
Yeah. So, did you find any reactionary exudate post-op stapedotomy causing conductive loss?
Reactionary?
Exudate.
Not really. See, what all can happen post-op is a serous labyrinthitis. A serous labyrinthitis, believe me, once you open the vestibule, it is inevitable and it doesn't give much problem. And it resolves over a period of time. The problem comes when it converts to the purulent labyrinthitis, and that is disaster. Otherwise, I don't think any exudate or anything that happens to other post-Stapes surgery.
I have had one
Another
case on a
question.
fifth post-op day facial paralysis.
Yes.
On the fifth post-op day, everything went perfectly well.
Viral. Viral.
Yeah,
It's a viral.
Viral reactivation.
yeah.
Most of the time.
So it's very scary, but to face a patient like that.
No, but as long as it's late, it always recovers.
Yeah.
And you know, one was a very good publication recently. This viral reactivation happens to occur, though it is not common, but whatever, the incidence is more when you use laser because of the heat.
So no,
Heat
this happened before.
reactivates the trigeminal, dormant viruses more than the regular surgery.
I have not seen that actually.
I have seen 2 cases.
I have seen many years.
Resolved over the period of time on its own.
Yeah, they recover. In fact, recover quite quickly.
Okay, another
Actually,
question
yes, but I have
is,
not seen the increase.
With the laser, you're saying, okay.
No, I have seen this. I have seen 8-10 cases, but never with the laser.
Yes, sir. Next question.
okay, another is primary incus dislocation. Can it be fixed in the incudomalleolar joint with bone cement?
He has already answered, Dr. Ashim has answered. There are 2 kinds of situation of dislocation, a partial or a complete one. And if you reposite it properly in a partial one, it remains in place. In a total one, you can think of using bone cement. Some people use fibrin glue also.
Yeah.
It can work. So it is a matter of apposition more than using all these materials, which makes a
But
difference.
I think the point is that if you use a bone cement, it is more predictable. So it's
Yes.
a good idea. Because
Yeah,
it's not
but see, bone cement, it's not the mechanical, it's not the mechanical approximation of the incus and malleus. This
Yeah.
incudomalleal joint, it is more important. It is a gliding joint. This is one of the most important joint, as far as the impedance is concerned. So we have to give joint rather than a bony position. Yes,
Other than the rigid fixation.
yes. So next.
Next is, I have a query that is there any difference between the necrosis, neo-ossification caused by the cochlea caused by the meningitis and the other caused by the otosclerosis?
Yeah, it is by and large the management is same, but it is altogether different. The reason is, in otosclerosis, it is the osteoid bone deposition. This is the otosclerotic bone deposition in the cochlear lumen or in the cochlear different areas, or the bone is replaced by such kind of a bone. Meningitis is a inflammatory bone deposition. It is a reaction, inflammatory reaction which leads to osteogenic reaction and bone deposition. That is different, and that happens mostly with the pneumococcal meningitis afterwards. So these are 2 different situations, and this bone and dealing with these 2 situations is altogether different. I am coming to it when I discuss the far advanced otosclerosis.
Okay. I read somewhere this particular point that in otosclerosis mostly the basal turn is involved. The first half of the basal turn is involved.
Yes, to begin with.
Rather than the whole of the cochlea.
No, it completely can get involved. That is stage 3 from the Rotavirus classification. Diffuse, discrete, confluent involvement of the cochlea with multiple cavitation, and that is worse a situation you can imagine. The reason is you don't know where the lumen is. There are so many cavitation because of the otosclerosis that everything looks like a cochlear lumen. So you never know where the sensory epithelium is to be stimulated. So that is worst.
Okay. So we are finished up with the question. You can carry on.
Okay, so we coming to the very important part before ending the session, the far advanced otosclerosis, and this is important. Up to 3 to 4% of the patients of the otosclerosis ultimately develop this, and we have already discussed the definition. When it goes, the air conduction loss goes beyond 85 dB and the bone conduction measurable, and we are left with limited options in those situations what to do. So decision making is important, and then management is equally important because it is not all that easy.
So I mentioned in the beginning, we take into consideration three criteria for the decision making. One is, like Dr. Ashim Desai said, the speech discrimination score. Second is the airborne gap, and the third is the CT scan, Rotavir's classification. That how severe is the cochlear involvement, that is again a decision making. Everything is a value. Now, for example, patients who have a good speech discrimination, the first choice is stapedotomy followed by hearing aid. In spite of having a profound loss, Stapes surgery is the indication followed by hearing aid. Whatever time it can sustain. The question is, if this doesn't work, CI is always a viable option. It doesn't violate the possibility of the good result with the CI. The CI result is always an option. So in situations when you have a good speech discrimination, the first choice for surgery is Stapes. The reason is, it works, number one, hearing along with the hearing aid, and it gives a better hearing quality than CI itself.
Yes.
The dynamic range of hearing of the acoustic hearing is 1000 times better than the electrical hearing, which is a less dynamic range. The music appreciation, everything is better with the acoustic hearing than the electrical hearing. And secondly, this operation additional, in case it doesn't work, this additional operation of Stapes surgery doesn't cost much. Your Stapes, the CI option is always there. The only thing against this is, if the CT scan shows diffuse lesions, and if there is a possibility of CI insertion at that time, better to go with the CI, because if you wait, it can further destroy the cochlea, and then you are the option of cochlear implantation is over. So CT scan is a decision making factor in any given situation. So all three things are important. If CT shows limited lesions, Stapes is the answer, except poor speech discrimination. Suppose CT is not showing a too much of involvement to the cochlea, but the speech discrimination is poor, airborne gap is very less, better to go with the hearing aid, and then cochlear implant if it doesn't work. So the indications of three things are different. For stapedotomy, if the speech discrimination is good and there is AB gap, with not having too much of destruction of the cochlea on CT scan. Hearing aid is good when there is no airborne gap and the cochlea doesn't have that much of destruction. And cochlear implant is straight away when all these things fails, or straight away when there is diffuse cochlear involvement. So this is to be very, very clear in decision making when a patient with far advanced otosclerosis comes. Now, once it comes to cochlear implantation, like you asked before, cochlear implantation in these patients is not all that easy. Intraoperatively, postoperatively, the problems are always there. Intraoperatively, difficult to find the lumen sometimes. You have to drill away. If it is limited to the basal tan, you can drill away that lesion and pass your electrode, and then it is like a normal implant. But if it is diffuse cavitation, sometimes you are in the wrong cavity. Sometimes you may have to do a multiple drill out in different turns to make sure that you are in the you are stimulating the sensory epithelium only, not the cavity of the otosclerosis. So insertion is challenging because of the destruction of the cochlea due to otosclerosis, and even if you have done a good surgery, post-operative course is difficult due to many reasons, and the biggest problem is non-auditory stimulation, because this bone is not as dense as a regular otic capsule. It becomes more conducive, more hypodense, and whatever current you are using with the cochlear implant can be passed or can be circulated, can be diffusely go out of the cochlea to stimulate the surrounding things, like facial nerve, which is in close proximity to the upper basal turn of the cochlea where the labyrinthine segment passes. It can stimulate the Jacobson nerve on the promontory even, giving the pain in the ear. It may stimulate the vestibular system in the close proximity of the cochlea as well. So anything it can happen, and that becomes sometimes a difficult thing to treat. Though it happens, doesn't happen in 100% of the patient, but once it happens, it's a very, very difficult thing. So once it happens to occur, what all you can do? You have to localize what is happening. If it is a facial stimulation, it is always the upper basal turn which is responsible, and you can reduce the current of those electrodes. If it doesn't work, you can deactivate those electrodes. If it still persists, you may have to explant it. And second thing, during insertion also the insertion of the electrodes, it is better to have perimodular electrodes, so the current flow out of the cochlea is farther. It is not as much as current flow out as compared to the lateral wall electrodes. So keep the electrodes away from the lateral wall of the cochlea for the too much of the current to pass out of the cochlea. So this is one of the indications for perimodular electrodes. And another thing nowadays recently, the thing advocated is, we have no experience, is a direct acoustic implant, cochlear implant. DACI. DACI is what? It preserves the acoustic hearing rather than an implant where we give electric hearing, even in the profound loss. So this involves a surgery wherein an artificial incus is implanted, a titanium incus, and a stepidotomy with a titanium piston is done, with the loop of the stepidotomy is on that artificial incus, the titanium incus, and then the loop goes inside the foot plate, and then the mechanical system stimulates the artificial incus, which is known as an actuator, to induce vibration to the inner ear and give good hearing. So this way it preserves the acoustic hearing rather than the cochlear implant, and it is supposed to give a good result. So we have no experience, but the literature is now more and more coming out in favor of this DACI rather than cochlear implant, because in case it fails, still cochlear implant is the option.
So it's got.
Huh?
So you remove the normal incus, put a whatever the
actuator.
Okay.
Just one point I wanted to make about the audiology for far advanced otosclerosis. Again, in these cases, the Rene is negative.
Yeah, your voice is breaking.
Another suggestion.
Your voice is breaking.
Bone conduction at 3000 hertz. Okay. Can you hear me now? Can you hear better? Hello?
Yeah, we can hear.
Okay. The thing is that bone conduction at 3 kilohertz is very important for judging far advanced otosclerosis. Because generally you have nothing by air, nothing by bone. 2 kilohertz, the bone conduction is down due to the Carhart notch. 4 kilohertz is down because of the extreme high frequency involvement of the basal turn. So 3 kilohertz is where, if you can find hearing at 70 dB or 75 dB, that is where you'd be able to do your stapedotomy on that particular ear. The reason I say this, as most audiologists don't do 3 kilohertz audiogram. So I recommend that all your audiologists do 3 kilohertz audiogram in such cases. And the second one is to judge the speech discrimination. Your regular headphone speech discrimination is at around 100 dB. You want SDS at 120 dB. So we suggest doing speech discrimination scores using an old type pocket model hearing aid like a BM78 hearing aid. When you use that, you are giving 120 dB of sound, because for real speech discrimination, you should be at least 30 decibel supra threshold. So these are the two practical points I just wanted to put in for far advanced otosclerosis.
Brilliant. Yeah.
Good.
Yeah. Any questions?
No. So one young lady just have come for the surgery. She has to go for marriage 1 month after this. Will you go for the surgery? Because after 1 month she has a planned surgery, operation, marriage.
Yes, of course.
Of course. Absolutely.
Because okay. That's question asked
Of
by
course, I will
Dr.
recommend vein interposition in that case.
Mr. Dr. Dhaval Patil is asking simple. Last keyword, that was the last question from his side.
Is it related to a pregnancy or just a marriage? If there's a planned
Pregnancy,
pregnancy,
I
you would
think
rather
his
do the
Ashish.
sterectomy before.
yeah, the
Ashish,
point would be the pregnancy actually.
Ashish, I'll mention one thing here about this issue of reality of the this autosclerosis, whether it worsens with pregnancy or not.
Yeah.
You know how this issue came out?
Huh?
This was the issue raised in 1939 in Germany. That time the German medical board had certain guidelines. They issued the guidelines to abort all pregnancies or do sterilization for all diseases which have a genetic cause. So some surgeon, some Dr. Griffenstein published a paper to sterilize all women having autosclerosis or either abort the pregnancy or sterilize. And then ultimately it turned out to be a political edict by the Nazis to purify the race. That was the reason behind. There is nothing to do. Autosclerosis has nothing to do with the pregnancy.
Oh.
Yeah,
Okay.
okay.
So
Okay.
I'm sorry, my knowledge about pregnancy was in the Nazi era. That means. So no, so the conclusion: pregnancy does not affect the progress of
Not at all.
autosclerosis.
Not at all.
Okay.
If, however, one caveat that I would like to put here is that if there is a pregnant lady or a lady who is considering pregnancy for autosclerosis, it's better to operate on one side for her social requirements and then following all her childbearing function, then to operate on the opposite side.
Yeah, that can
So
be.
the rule of 6 months and 1 year does not apply.
But why? If pregnancy is not having a effect?
No, not for the effect. But generally, if you're doing a piston, you find obliterative autosclerosis, doing a direct piston, so on and so forth. Because of the forces of childbearing and all that, during delivery and all that, you don't want both the ears to potentially be affected. So this is on the side of abundant caution.
So you're free now, Miss. One Aki, everything finished.
Pocket.
I have almost 100 small clips of 10 second, 20 second regarding the Stapes surgery. So I've just selected few only. Can it?
Yeah.
One interesting one that new people should not do such mistakes, and this would be just starting with the simple one, because I think
meantime, those who are online, our next webinar is on Thursday. That is a live surgical demonstration of various ear, nose and throat surgeries, 4 p.m.
Also, Satish, later on, if time permits, can I show a 2-minute clip or a 3-minute clip on the handling the prolapsed facial nerve?
Yes, we would like to see. We would like to see.
Yeah, we didn't speak about the facial at all. Yeah.
Rajeev, please proceed.
Yeah. What is the earliest stage you have done, Miss? Earliest stage of the surgery?
I'm sorry?
What is the earliest of the surgery you have?
At earliest age?
Yeah.
8 years.
And okay. I think you should write, because some issues with this presentation. I think you can start it.
Okay.
You show your facial.
Okay, so here you can see a very heavily prolapsing facial. Now, when you first look at, can you see it?
Yeah.
Okay, now when you first look at it, you can imagine that you can actually drill out part of the posterior crust and directly access the foot plate. But in this case, it was not so. Although this posterior crust is appearing very thick,
it's very wide but not thick. It's transparent. You see the color?
Yeah, and it is hidden.
No. This is overhang. How much of the oval window was covered by the facial?
You can see that once when I remove this, you will see about 80% plus is covered by the oval window.
So now Ashim is drilling the posterior crust.
Yes.
From inferior to the
Yes, I'm drilling always from
Because the burr cannot go towards the facial, so he's
Exactly. It's always drilling from inferiorly in the axis of the foot plate.
This is one area where laser is contraindicated when the facial nerve is prolapsing or facial nerve is dehiscent. You have to be very cautious about it.
You have to be very, very careful here. Okay, so now you can see the foot plate is there.
Yes.
This is promontory. This is
Yeah.
now the way that I use to crack the anterior crust is to twist it on the axis of the anterior crust.
The incudostapedial joint is disarticulated.
Can you see it's a twisting movement, and with this movement the chance of mobilization is almost nil.
There is no
Really?
I think you should rewind and show it one more time.
What? I didn't get. What are you saying? What? Twisting?
so
I'm
once the
twisting
posterior
it.
crust is drilled through.
I'm twisting the
So he is pushing.
structure on
It's
the
a
axis.
rotational
It's a
movement.
rotational fracture.
Incudostapedial joint is disarticulated.
It's a rotational fracture.
And
So
as you
he's
see, we are using a twisting movement. And this twisting movement ensures that there is no chance of subluxation or dislocation of the foot plate. So the Stapes superstructure is now
So
extracted.
you see, the foot plate is here. This is all promontory. So
And
I'm
it's
drilling a little
very
bit
deep, so a little bit of saucerization is required.
at very, very slow speed.
You are drilling the promontory nice.
Slightly.
the edge,
Just the edge of the promontory.
and now the shaft of the burr touch the sheath of the facial nerve, but
So
no
what?
problem.
Nothing happens. I've done it many, many times.
Of the foot plate.
You have to go very slowly. You cannot let heat generate.
And not for too long.
Yeah. And here you can see I'm actually
And
stuffing gel
insinuating
foam
it between the stapes,
to compress the facial nerve out.
plate and the facial nerve.
Yes.
So what happens that there is gentle compression by the gel foam as the gel foam absorbs the fluids and the capillary oozing.
Now you have
See,
space.
slowly you are getting to see more and more of the nerve,
Gain better
of the foot
visualization
plate.
of the foot plate. Once you see
So you did this sequentially several number of times.
Yes, it just keeps going on and on.
But as you can see, we need more space.
See, this is a
This is
0.5 millimeter
0.6
burr.
millimeter burr. We are using a BNS heater, and over a period of time, we are slowly skeletonizing the foot plate, as well as lowering the promontory.
See, now you keep stuffing dry gel foam out
Promontory is
there,
required in
and it
order
keeps
to
expanding.
access the foot plate in a better way. Once again, we are using dry gel foam to create greater space.
So let's just go on.
Yeah. Now the color's changing.
So now
You can see the foot plate.
The blue, yeah.
A little bit of
And then more gel foam. It just goes on and on.
But now the part of the promontory, oh, okay. So the
Yeah, yeah.
extra is including a little edge of the promontory?
No. It is exactly in the foot plate. You can see.
see.
At the lower edge of the foot plate.
I've just saucerized the promontory a little bit, made it slope
For the axis of the burr.
for the axis.
Millimeter big.
Beautiful.
And then, of course, my piston, and that's
It's
it.
very important. This
So this was an accidental finding or you were knowing it?
3.4
Sorry?
millimeters piston.
Was this an accidental finding? Or you knew it?
No, this was an expected finding because I'd done a CT scan on this.
Okay.
In fact, the CT scan showed a greater degree of prolapse, so I told the patient I may not give any improvement at all. So anyway, that's about it.
It is applied.
Lovely.
And now again, even in this, I will do my hanging test and bending
What
test.
is known as a hanging test.
You know,
It doesn't matter if the shaft of the piston is touching or abutting against
doesn't make any difference. Doesn't
It
injure.
doesn't matter. It's a Teflon piston or titanium, it doesn't matter. Okay, so that was about it. Thank you.
So these facial nerve abnormalities prolapse
We are very sure
onto the Stapes foot plate is not uncommon, and the reason is developmental. At the time when the stapedial crura develop is the time where the facial nerve develops, and we have seen many a times facial nerve completely covering the whole window, even coming to the promontory. And in one of the case, the facial was too low that we had to drill above it and put a piston in the vestibule above the facial nerve. So in situations, I could show that video, is not here, wherein we did a vestibular fenestration above the level of the facial nerve. So that can happen in many a situation, the facial nerve abnormalities. But the best thing is you can predict all these abnormalities through a CT scan easily.
Can you see something on the video?
Yes, boss.
Louder.
Yeah. Because this is regarding a few tips. I think for newcomers, those who are starting surgery, they should keep in mind this point that, like, suppose you are there doing surgery, while taking the incision that Dr. Satish told in advance, don't take a long flap. Take a proper 5 to 6 millimeter flap, because if you take a very long flap in the posterior canal wall, that can create problem during surgery. Though you can manage very well, why to get frustrated during surgery? That is one more point. Second is that suppose don't use a drill so much, because that I discussed that bone dust can create problem later on, and that's why blind curating at that end, because like the surgeon is doing this drilling using drill, but at this stage if you use the curate, whether it is good quality, bad quality, and just see the surgeon is doing, and just see the curate, he at this end is blind now, and that should be avoided. Just see the response reaction just after the curate, what happens to the eye.
It should be under vision, you mean to say?
Yeah, now the incus is gone. That because of the blind curating, the incus is dislocated, and now you can imagine what will happen to this case. You have to abandon the surgery, and suppose once it is happened, your incus is hypermobile, then I think best time, never fiddle with this incus. Don't try to put, even after you have done this thing, your hole. But I think at this step, put a vein graft and abandon the surgery. Don't try to play with this hypermobile incus, otherwise you will destroy the ear. That is, these are real-time videos. So I think this step should be avoided. As I told you, just hold it for a few months, or if you are want to do in single stage, then go for the malleable staphylopraxy. That is one more obstacle. So these points I think we should avoid, and one Stapes point. So yeah. There's one more point. I think this, as Satish told, okay, just never use a better quality piston and never compromise with piston, because once, if you are using a bad quality piston, if you have to manipulate it, then just see the quality of the piston. It is very bad. So I think better to go for a good quality, whether it is that your choice. And never suppose during surgery, it happens with many people that during putting piston, it goes inside. And this is the time you should have patience. Give 20 seconds, 30 seconds, 1 minute, take rest, and then close your eye, then use a proper instrument at this level. Never try to fiddle with this to take it out in a hurry, and just use a right angle or whatever instrument you have, and just take it out. Otherwise, in this procedure, you must have done damage, I think 5 to 10 decibel, as must have given 5 to 10 decibel as loss to this patient. So at this level, keep patience and and this, I think this was already shown vein graft. So I think this is before starting learning Stapes surgery, you should know how to take a vein graft, because you never know what time you have to go for this vein grafting. And this I already shown in this previous video. And one thing I think this word is very important point. This is my mistake. I would say suppose this was a Teflon and titanium piston, and when you used to cut it, I think use a proper sharp knife. Never try to use a old card, because just see this tag. And I didn't see that tag, and I put that surgery was wonderful. But after 48 hours, or you can say 20, in fact 12 hours, 13 hours, patient is having severe vertigo. And when I checked it, everything was fine. His hearing was not bad. Then I had to take it, and after, when I took out this piston, I could see some tag was there that was creating problem. And I had to re-explore it and put one more piston, and the patient was okay, finally okay, hardly some loss was there. And one thing is no fight when open the piston, because this is the quality of the piston. If you are using good quality piston, then that memory is very good. Like in this case, the surgeon is trying to engulf the piston in the incus, and that is not a good, because it can damage your incus, it can dislocate it. So open the piston properly, then try to insert it in the incus. And same thing, if you are not very much comfortable with this technique, then one more option is there. You can use this technique, and I think this is one more better way. Try to make a nick on the opening side, and then try to put, though I don't have a video, I had a video, but it is not very good, but that's why I make this picture. That one more way you can insert your piston very well in the incus. And I think two more are there. This is regarding. Okay. That's why never remove attic bone excessively in the Stapes surgery, because otherwise what happens, you get a secondary retraction, and you may get a exposure of your piston in the attic area, and that can lead to recurrent discharge from the area, maybe granulations. And these are the cases you may have to go for the revision surgery, because it can damage your piston and recurrent discharge. So these are peeping piston with beeping drum. It should be avoided. So try to avoid these steps. These are few things which there's almost hundreds videos are there, but I think these are few points I want to share, because since morning these were left, that's why I just shared this thing. Thank you.
Thank you, boss.
Thank you, Rajeev.
Thank you.
Excellent.
Thank you. Very nice.
Super.
Good points. Very good points.
Super.
Satish, I think, are we at the end?
Yes.
So, anybody has any questions, or we call it a day?
I think we should call it a day.
Dr. Kakkad sir is there. One question from his side.
Yes.
I can ask, this is last on case recurrence is associated with the incus necrosis and blood supply of the incus from bone marrow inside incus body and not from the stapedial tendons. So revision is problem, so be careful. Some comment from Dr. Kakkad sir. In obliterative case, recurrence is associated with incus necrosis and blood supply of the incus is from bone marrow inside incus body and not from the stapedial tendons. So revision is problem, so be careful during surgery. These are the points.
Yeah, agreed. We said that.
Okay, so see you all on Thursday, 4 p.m. with
Thank you very much.
some live surgeries, interesting one from ear, nose and throat, from basic to advanced. And
we did justice to almost everything in Stapes surgery. Or
yeah, this is a huge topic, you know. You can discuss more and more.
Boss, we can go on another day if necessary.
And in our coming webinars, we'll be keeping some more variety of Stapes situation, including revisions.
Lovely. Thank you so much.
Super. Thank you, guys.
Thank you, boss. Thank you, Sun Pharma. Big thanks to Sun Pharma and big thanks to Pachauri boss for everything. Thank you.
Thank you very much.
Pharma, thank you.
Thank you, Sanna boss.
Thank you.
Thank you, Sanjay Khanna sir. Thank you.
Thank you, all of you.
Thank you.
Take care. Bye.
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 Bye.